Ladies and gentlemen, good morning and thank you for being here with us on time. This is just to remind you that we'll be starting in exactly 4 minutes 50 seconds. If your friends and colleagues are still around networking or having a bit of coffee or still deciding whether to join us or not, tell them that we're about to start in 4 minutes. Thank you. Is in my mind.
Very nice. So then we'll discuss further. हाँ 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 तन निकल रहे क्या हाँ आ रहे हाँ एक सेकंड आ रहा एक सेकंड में आ रहा
Guys, you ready to rock and roll?
one guest of honor added. I told you no two. One is the chief guest, one is the guest of honor. Okay. Then अभी भी same. Chief guest and guest of honor. Chief guest is Dr. Hanuman Muli. Because we have another is Dr. Jacob James Raj. He is from Triple M. He is a IACTS General Secretary.
Okay,
Dr. Jacob James Raj. IACTS, surgeons, IACTS General Secretary.
CTS General Secretary.
Right. So what
Now
you
he'll be guest of honor, so he will speak first, and then this guy will speak. Anvay Bule will speak after him.
Yes, no problem. Whatever. This is super spot. And now,
But you need one more.
okay. So you are going from where? Yeah. Okay, right.
So first I will go. I'll just say a few lines. Then I will say, please rise for the national anthem. We will rise for the national anthem. Then I will say, try to bless in Lord Ganesha, blah blah blah. Please dance, perform. They will dance, and there's a track to perform. After that, we will go to lighting of the lamp, where I'll invite all of you on stage.
Okay.
Yes.
Right.
Or I'll invite Ravindra Savardekar. He'll call everybody.
You will
on
call
stage.
everybody. Very
Fine.
nice. Okay, nice.
And then you will light the lamp.
Right, line.
After you light the lamp,
Mm-hmm.
after you light the lamp, then you will take seats.
That's it.
Yeah, and then we will start with the welcome.
Welcome. Thank you.
Green signal. Green signal.
So while we are hello, now the guest of honor का कुछ introduction मिलेगा, कोई 4 लाइन.
Guest of honor का introduction.
अभी आया जो.
क्या नाम क्या था? Dr. Anvay Muli है ना?
He has become chief guest. Dr. Jacob James IACTS. Ladies and gentlemen, good morning. And I thank you all for being with us here on time, because we're all in this hall, and those who will be stepping up on stage, always involved with something very specific, and that is saving lives, which has to be on time every time. So thank you, ladies and gentlemen, for being here on time. It just shows and delineates your passion for the profession. This is the 26th annual conference of the Indian Society of Extracorporeal Technology. And ladies and gentlemen, we have a packed 2 days, and we can't afford to even let a second go by. So once again, a warm thank you to all of you. And just to remind you that as we go through this very wonderful packed 2 days, it's going to be lots of information, lots of networking, and of course, sharing of lots of views. But before we start, just to remind you that while you're in the hall, please ensure your mobiles and connected devices are on silent. Do always wear your delegate badges for logistics purposes. And there will be signs and displays telling you as to where the conveniences are and what time are the breaks and when lunch and tea is being served. With those wonderful warm words, ladies and once again, it's a good morning to you all. And as we all are gathered in this wonderful land of India, ladies and gentlemen, may I request you all to please rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, ladies and gentlemen. Do please take your seats. You're all aware, guys and gals, ladies and gentlemen, that perfusion is not just a profession. It is precision, it is responsibility, and it is life sustained beyond the heart. But no matter what we do and how hard we work towards it, there's always the hand of the Almighty that guides and blesses us. Today is no difference. It's a conference and a seminar, but we still need the blessings of the Almighty. We now start by invoking the blessings of Lord Ganesha, the remover of obstacles and the harbinger of wisdom and success. To help us do this, we have three very talented performers who are also students of perfusion technology. They're going to step up on stage. There's going to be Avni Goshai, Shravani Prawar, and Tanisha Nair, who will step up on stage, and they are going to perform to the Ganesh Vandana. As they step up on stage, just to remind you that this is an endearment so that this conference may be filled with knowledge, meaningful discussions, and collaborative growth. The Vatapi Ganapitam. Ladies and gentlemen.
वातापि गणपतिं भजे
तं तरि तकजुनु तज्जं दीं तरि तकजुनु तज्जं कृतगदगडतं
वातापि गणपतिं भजे
तं तरि तकजुनु तज्जं दीं तरि तकजुनु तज्जं तं तरि तकजुनु तज्जं कृतगदगडतं कृतगदगडतं कृतगदगडतं
वातापि गणपतिं भजे
तं दीं तं नं तं तरि तकजुनु दीं तरि तकजुनु तं तरि तकजुनु नं तरि तकजुनु तकदेवि तकजुनु तकदेवि तकजुनु तकदेवि तकजुनु तद्धि कृतगदगडतं कृतगदगडतं कृतगदगडतं
वातापि गणपतिं भजे वातापि गणपतिं भजे वातापि गणपतिं भजे वीतरागिणं विनुतयोगिनम् वीतरागिणं विनुतयोगिनम् वीतरागिणं विनुतयोगिनम् वीतरागिणं विनुतयोगिनं विश्वकारणं विघ्नवारणं वीतरागिणं विनुतयोगिनं विश्वकारणं विघ्नवारणं वाराविगणवरे वरण चुम्बरभयं श्रीवाराविगणवं भजे
Thank you, Avni Goshai, Shravani Pawar, and Tanisha Nair. Thank you very much. After this traditional invocation, we also have another endearing tradition, and that is lighting of the symbolic lamp, which of course signifies the gaining of knowledge and dispelling of ignorance. In true academic pursuit, today we do that, and may I now request our eminent dignitaries to please step up to the dais for the lighting of the lamp, starting off with our chief guest, Dr. Anvay Mule. I'd also like to request our guest of honor, Dr. Jacob James, to please join. Also, people from who matter to us, the President of ISEC, Mr. Rajendra Kokane, the General Secretary ISEC, Mr. Loknath Tiwari, Jagannath Kalgude, President ISECCon 2026, Mr. Ravindra Savardekar, Organizing Secretary of ISECCon 2026, and Vikas Mali, Chairman ISECCon 2026.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा
Thank you very much, gentlemen. That was a brilliant start to this ISECCon 2026 right here in Mumbai. We have delegates, speakers, presenters, and chairpersons from all across the world with us here today. And it's going to be a wonderful ISECCon because of the large numbers of people that are involved, not only in participating, but also being part of the audience. And I hear that lots of family members have also joined their spouses on this wonderful occasion to be a part of this fraternity that takes care of your heart in more ways than one. So without further ado, ladies and gentlemen, after that brilliant start by invoking the Almighty, it's now time to formally start the welcome. And for that, ladies and gentlemen, I'd like to request the one gentleman who has been working hard along with his entire team to make it a reality. Please put your hands together for the Organizing Secretary, ISECCon 2026, Mr. Ravindra Savardekar. So you will follow them on stage? Yeah.
Good morning to one and all present here. Thank you for being here and making ISECCon truly special with your overwhelming presence and the rich variety of scientific presentation over the next 2 days. Our team has worked tirelessly to organize this conference, and I sincerely thank you, every member who contributed to making it success. We have packed program ahead and no time to waste. So without further delay, I invite Dr. Anvay Mule, sir, Dr. Jacob sir, Dr. Rajendra Kokne sir, Mr. Loknath Tiwari, Mr. Jagannath Kolgude, and Mr. Vikas Mali to kindly come on the stage and being the proceeding.
You know, the silence is like as though an operation is about to start. The serious part is always when you work. Today, it's not so serious. We're just sharing information and also networking. So big round of applause would be appropriate at this point of time. Well, thank you, Saurdekar, for the warm welcome to everybody here, and to start off and giving us the timing that we have a packed program and we don't want to waste a second. That's right. We'd like to thank our eminent chief guest and our guest of honor who have taken time from their very busy schedules to be with us here. And we'd like to request them to share a few words with us before we ask the president for his address. Our guest of honor is Dr. Jacob James Raj, a highly experienced cardiothoracic and vascular surgeon with over 30 years of experience, primarily practicing at the Madras Medical Mission Hospital in Chennai. He specializes in heart transplants, beating heart surgery, and valve repairs. He holds an MCH from the Sri Chitra Thirunal Institute. Ladies and gentlemen, please welcome Dr. Jacob to the podium.
Good morning. It gives me great pleasure to be here amidst all of you. And as the Secretary of the Indian Association of Cardiothoracic and Vascular Surgeons, I extend a warm greetings from the association to every single member present here. The perfusionist is more than a backbone of the cardiac surgeon. And we acknowledge that. We are very happy that so many of you have gathered here to exchange knowledge, to learn, to teach, and to equip yourselves for us and for our patients. It is also my responsibility to help you set up your regulatory body, which will help you to streamline things with the perfusionist as a separate profession and as an elegant module for recognition of the various teaching programs and also for certifications and for advanced certifications. The NMC chairman at the moment is a close friend of mine and also a cardiac surgeon. So it will help us to get these things done in a more easier manner. The communications from the ISEC to the IACTS have already started, and I have already spoken to my team to help out, and we will be drafting the letter very soon to the NMC to help this happen, and hopefully in this coming year we should be able to see some strides towards this. I wish all of you will have a great conference, learn a lot, benefit a lot, and at the same time socialize and have a bit of fun. God bless you all.
Thank you, Dr. James, for your warm and wonderful words. And yes, we will have lots of information and hopefully lots of fun, guys. Time to really take those words to heart. We're also very thankful to have with us the presence of our chief guest, Dr. Anvay Mulay, who has taken time off from his also very busy schedule to be with us here. All of you know, of course, Dr. Anvay Mulay. He really requires not much of an introduction, but it is my duty and privilege to do so, a brief introduction. Dr. Anvay Mulay is the director of the Department of Cardiac Surgery at Sir H.N. Reliance Foundation Hospital, and he obtained his MS General Surgery in 1986 after his MBBS in 83, and the MCH in Cardiovascular and Thoracic Surgery in 89. He has received specialized training in cardiothoracic surgery under membership of the Royal College of Surgeons and International Fellowship in Cardiac Surgery at St. Vincent's Hospital, Portland. He's also worked as a consultant at Leeds General Infirmary. He started the Rural Cardiac Surgery Program in Maharashtra in 2004 and was a key part of the open heart surgery programs conducted in the interiors of Maharashtra from 2004 to 2005. He also started the comprehensive minimally invasive cardiac surgery program in Maharashtra and established Western India's first comprehensive heart failure clinic in 2015. He has many more credits to his he has many more firsts to his credit, of course, but we have to move on, and I would take the all day talking about Dr. Muley, but we'd like to rather have Dr. Muley speak. So without further ado, ladies and gentlemen, please welcome our chief guest, Dr. Anvay Muley.
Thank you for the kind introduction. Actually, I was trying to forget many of those things which you said. You reminded me it again today. Whatever introduction I got it today was not possible without all of you. I think many of you are here, and in cardiac surgery or in the technology which is growing very fast, it is impossible to work alone in this field. I think Jacob has mentioned everything, and I'm very glad that at least sometime in next few years, there will be proper certification and proper the perfusionist or your association will have updated of your upgrading of your perfusion skills also and keeping you updated, and that is very important. So getting a degree and going in the market is what is the Indian practice is. But to keep up with the technology, keep you upgraded continuously, and the CMEs is very, very important, I think. What message I have to give, already given it in your book. There is nothing more than that. So you share your knowledge today and continue your excellence today from here onwards. Whatever you gather and whatever you exchange your knowledge. I wish you all the best for next 2 days and enjoy it also. Thank you very much.
Thank you, Dr. Muley, for two things. First of all, your presence here. Second, of course, your blessings. And also to remind us that we have to be brief in whatever we do here today and tomorrow. Thank you very much. Well, ladies and gentlemen, you are here because of an organization that really takes care of you. That's ISECTCON. And ISECTCON is built with people, some of you in the audience, most of them on stage here, who make it very special by their time, devotion, and of course, their commitment to it. And there's one gentleman who is totally committed to making ISECTCON, and over the years that I've known him, to become the brilliant organization it is. Without further ado, ladies and gentlemen, please welcome the president of ISECTCON, Mr. Kokani, to please step up on stage and deliver the presidential address at ISECTCON 2016.
Thank you. Thank you, Alaric. Respected Dr. Jacob James Raj, General Secretary of ISCTS, thank you, sir, for your kind words. Mumbai's pride, Dr. Anvay Muley, Director, Advanced Cardiac Surgery and Heart Transplant Unit, Sir H.N. Reliance Foundation Hospitals. Sir has done one more addition I want to add, Alaric. Sir has done more than 175 successful heart-lung transplant surgeries in India. And we are really proud of you, sir. Respected my seniors, respected my faculty, colleagues, my young warriors, and Mumbai Rockers. It gives me immense pride and pleasure to welcome you all, ISECTCON 2026 Mumbai. Mumbai is a city of joy, resilience, innovation, and full of energy. And that energy belongs to perfusionist community of India. So this conference is not merely an academic gathering, it is a declaration that perfusion in India has evolved, a declaration that we are ready for global standards. Under the theme Next Gen Perfusion, AI, Robotics and Personalized Care, we are stepping into a new era where technology meets precision, where data guides decisions, and where perfusionists emerge as leaders in advanced cardiac life support system. Let this conference inspire collaboration. Let it ignite innovation. Let it strengthen our professional identity. As president of ISECT, I assure you, this is just the beginning. Together, we are not only organizing conferences, but we are shaping the future of perfusion in India. May this gathering create knowledge, friendship, and milestones that history will remember. Welcome to Mumbai. Welcome to ISECCON 2026. Let us learn, let us lead, let us rise together. Thank you. Jai Hind, Jai Maharashtra.
That was the President ISECT, Rajendra Kokane. Thank you, sir, for your very inspiring words and, of course, your fantastic memory for remembering every aspect of every person you meet. Thank you so much. Moving on, ladies and gentlemen, we would like to felicitate this eminent panel for being with us here, taking time off with a very brief gesture of thanks with a memento. The first one will, of course, go to our chief guest, Dr. Mule. And may I please request Mr. Kokane and the other members to please step up and present this memento to Dr. Mule. May I like to request Loknath Tiwari, General Secretary, to please join in that. We'll similarly like to honor our guest of honor, Dr. James. And may I request Mr. Loknath Tiwari to do us the lead on that one, and everybody else also be part of it. Having done the honor, we'd also like to request, we'd also like to thank the ISECT organizing here from ISECCON. I'd like to request Mr. Ravindra Savardekar to please present a small thank you to the President. There is a shawl. Oh, yeah, there's a shawl to be given. Wonderful, it's still there. Thank you. And now, Mrs. Savardekar, I'd like to request you please present a small thank you memento to the President of ISECT, Mr. Rajendra Kokane. And I would similarly like to request the Chairman, ISECCON 2026, Mr. Vikas Mali, to do us the honors to General Secretary ISECT, Mr. Loknath Tiwari. Mr. Vikas Mali, if you could do us the honors for Mr. Loknath Tiwari. Thank you very much, gentlemen. Ladies, may I please request a quick round of applause to our eminent inaugural panel for starting off this ISECCON 2026 in just great stead. Can we have a group photograph, please? The entire panel's a little 2 feet ahead. Vote of thanks. Before the panel, after the photograph. While you keep the memory on, ladies and gentlemen, it's now time for a quick vote of thanks. And to do us the honors for the vote of thanks is the very redoubtable General Secretary ISECT, Mr. Loknath Tiwari.
Respected dignitaries, esteemed faculty, dear colleagues, life members, perfusion students, and distinguished guests, Dr. Anumay Mule and Dr. Jacob James Raj. On behalf of the Indian Society of Extracorporeal Technology, it is my proud privilege to propose the thanks of this auspicious opening ceremony of lamp lighting of ISECCon Mumbai. Today we are not concluding a journey, but inaugurating a new chapter of learning, collaborating, and professional excellence. First and foremost, I express my heartfelt gratitude to Dr. Anumay Mule, who recently left now for his busiest schedule, for his gracious presence and visionary guidance. Your insights into the futuristic pathway for clinical perfusionists have truly inspired us to embrace innovations, research, artificial intelligence, and advanced technology with confidence and responsibility. I extend my sincere thanks to Dr. Jacob Jamsraj, who stood by us on behalf of the ISCTS for that statutory body making of this perfusion community, and also giving vote of thanks to our President, Sri Rajendra Kokne, for his enlightening and motivational address. Your words continuously strengthen our community and ignite renewed dedications toward the professional growth and recognition of perfusion as a noble and vital career of the healthcare. My special appreciation goes to dynamic organizing team of ISECCon Mumbai 2026, Mr. Vikas Male, Mr. Jagannath, and Mr. Ravindra Savaredekar, and also Mr. Rafiq Sheikh, who is going to take charge after this vote of thanks. A special note of gratitude to the vibrant city of Mumbai, giving us the opportunity to host this prestigious conference. The warmth, discipline, and progressive spirit of Maharashtra truly inspire us to aim higher and serve better. As we formally open this conference, let us commit ourselves to learning deeply, sharing openly, and advancing collectively for the betterment of patients and the future of perfusion science. Once again, I thank each and every one of you for being part of this remarkable beginning. Jai Bharat, Jai Maharashtra. Thank you.
Thank you, sir. That was General Secretary for ISECT, Mr. Loknath Tiwari. Thank you, sir, for your really encouraging and motivating words. And, you know, it's always important to get the inaugural away because that's a very important start. It's like getting into a surgery. All the equipment is there, all the experts are there, and you're just ready to start. Now, we're at that point where everything has been properly done. The OT has been pre-prepped, and we are ready. So let's go start immediately with what we're supposed to do today and start off with the first scientific session. For that, we have each session will be chaired by a panel of 3 chairpersons. And at the end of the session, there will be a question-answer session. So in case you have any questions of the panelists out here, just keep those questions with you. We'll take them all together at the end of the Q&A session. You can step forward to the mic, ask your question. Remember that we have very little time, limited time, so there's going to be only 1 or 2 questions that could be taken in the time permitted. And of course, there'll be felicitation of our speakers and our chairpersons at the end of every session. This first session is Advances in Contemporary Perfusion Practice. For this session, we have 7 presentations, and this is going to be chaired by Dr. Subhash Saswant, Mr. Makwan Nilesh M., and Dr. Vishwas Paul. May I please request our chairpersons to please grace the dais? While the chairpersons grace the dais, I'd like to remind our presenters that strictly we are going to keep to time. There's a maximum of 15 minutes. We'd be happy if you finish in 5. But if that's not possible, around the 10-minute mark, there's a little counter there that will start the moment you step up on stage, and under no circumstances can we allow you more than 15 minutes because we are extremely pressed for time and we're already slightly behind schedule. So with our chair and place, it's now time to welcome your first presenter. So for the people in the hall, you can see the presentation on screen, and if you're at the rear of the hall, the presentation's out there. Can we have the tech team please connect this laptop before we start? Our first presentation at ISECCon 2026 right here in Mumbai on the 27th of February 2026, ladies and gentlemen, is Evolving Perfusion Approaches in Endoscopic Cardiac Surgery. The presenter, Gaurav Sasmal from Manipal Hospital, Kolkata. Sir, you have 15 minutes max, and hopefully you'll save your time.
Chairperson, distinguished faculty members, and dear colleagues. First of all, I would like to sincerely thanks to the organizing committee members of ISEC for giving me this valuable opportunity to present my topic, Evolving Perfusion Approaches in Endoscopic Cardiac Surgery. Myself, Gaurav Sasmal, Senior Clinical Perfusionist, Manipal Hospitals, Mukundapur, Kolkata. As we all know, modern cardiac surgery is rapidly transforming with technological advancement. Today, technology is everything, and with the help of the technology, it's regulate how we plan, perform, and monitor the whole procedures. Before we discuss modern perfusionist strategies, coming to the quick recap, as we all know, John Gibbons had innovated the era of cardiopulmonary bypass and done first ASD operation successfully with the help of the machine. And from then to now, we continuing the procedures and maintaining the relationship with more concreteness between surgery and CPB. And taking the help of the technology, CPB machine also became more compact with maximum convenience for us. It's more simple and user-friendly too. After the development of cardiopulmonary bypass, the next major transformation is in the surgical approach itself. Here you can see from the conventional sternotomy, we are doing now endoscopic cardiac surgery. This is the incision view of conventional sternotomy, minimal invasive cardiac surgery, and endoscopic cardiac surgery. So why endoscopic cardiac surgery? First, there is increasing clinical high demand for endoscopic surgery that reduce minimal trauma to the chest wall, and it also reduce post-operative chronic pain. Compared to conventional sternotomy, in endoscopic approaches, patients typically experience faster recovery and shorter hospital stay. And patients also experience earlier return to normal daily activities. From safety perspective, the risk of infection is lower, especially the risk of deep sternal wound infection and chest wall stability has been preserved through this surgery. In endoscopic approaches are very less, so requirement of blood is also minimum, transfusion rate is also decreasing. So now we are doing endoscopic aortic valve surgery, mitral valve surgery, endoscopic arterial septal defect, endoscopic LM myxoma, and endoscopic CABG. So this is the pre-op planning and setup. First we define the case strategy, whether it is port access or mini thoracotomy, and after that it is determines to the cannulation approach and circulate the circuit configuration. Then we have to check the our cannula inventory for femoral, arterial, and venous cannula. After that, we are discussing about the cardioplegia options, which is selected based on procedural requirements. Temperature strategy and prime volume targets are carefully maintained for physiological stability, and we must focus on minimizing hemodilution. For femoral artery and venous cannulation, we planned with the help of ultrasound mapping for femoral vessels because it ensured safe access and optimal flow dynamics for every cases. Finally, a structured team communication briefing with the surgeon and anesthesiologist is conducted to ensure coordinated intraoperative management. This structured preparation is crucial for safe and efficient perfusion during endoscopic procedures. Here you can see our circuit. And this is our live circuit we use during endoscopic cardiac surgery. We use modified Del-Nido in place of Del-Nido solution. I will tell later on it. And In modified Del Nido, we use higher concentration of potassium only. Rest are same as normal Del Nido. And we followed that after surgery, myocardial protection is better with modified Del Nido. In 1 liter plasma-lite solution, we use 20 ml of potassium concentration, and in 500 ml plasma-lite, we use 10 ml of potassium concentration in spite of 7 ml potassium concentration. Rest compositions are the same. And we use long femoral venous cannula to RA, SBC or IBC as per procedure, and femoral arterial cannula for femoral artery. If there is any arch of aorta involved for calcification or any issue with the femoral vessels, we use axillary artery for antegrade flow. To prevent limb ischemia, we provide a distal perfusion cannula, or we can use biflow cannula as well. We give antegrade cardioplegia with the help of minimal invasive aortic root cardioplegia cannula, which is 12 gauge cannula we use. Here you can see our cannulas. This is the smart cannula we use for venous drainage. This is Biomedica's aortic cannula. You can also use it for jugular vein to SBC. And this is the cardioplegia cannula, puncture needle, guide wire, and dilator in conventional. So here is a short video of smart cannula. You can see this is the constructed with a collapsible wire mesh or spring-like material. It can be inserted through a small introducer which make the cannula deflated, and it expands after insertion, as you can see, into the vein for maximized drainage. Excuse me, sound is not working. So as you can see, after the puncturing the artery, guide wire inserted, and our sir, Dr. Sandeep Sardar sir, who is expert in endoscopic cardiac surgery, he dilated the artery. This is a 17 or 19 French Biomedica's aortic cannula, which we use for the requirement of the procedure and patient body weight and flow. Now we are preparing the smart cannula for venous cannulation. One thing I want to mention that at the time of smart cannula insertion, you must push the dilator from backside. Otherwise, if it is inflated, then there will be some issues for inserting. Intraoperative echo guidance is important to verify the cannula position. As you can see, the guide wire is in descending thoracic aorta. And this is the Biomedica's cannula into right atrium. And this is the smart cannula inserted through IVC, and the tip of the cannula placed must be in 4 centimeter insert in SBC. This is the cross-sectional view of smart cannula, which is 4 centimeter inside the SBC. As you can see, this is the tip of the smart cannula, and this is ascending aorta. So we use retrograde autologous priming to reduce prime by 300 to 800 ml as patient tolerated with the hemodynamics. We maintaining hematocrit 25 to 30%, and we use vacuum assisted drainage to limit reservoir volume, and antifibrinolytics and salsavage we use for some cases if there is any bleeding tendency. We keep the ACT greater than 480 seconds. We use vacuum assisted venous drainage with the pressure of -20 to -30. I must not recommend to exceed it in -50 millimeter of mercury. because if you exceed more than -50, you can face the hematuria after the case. We added albumin for every cases, temperature cooling 28 to 30 degrees Celsius as per procedure, and modified Delnito we use in an interval of 60 minutes after first dose. After cardioplegia insertion administration, we must reverse the route for decompress the LV, because in endoscopic procedure, after giving plegia, surgeon may command LV is distended, and this is the only concerning way for empty the LV. We use cuff for, as we use Delnito or custodial in every cases for endoscopic cardiac surgery. We use we do ABG and mixed venous blood gas for confirming tissue perfusion. Before opening the cross clamping, we give hot shot mandatorily, and after opening cross clamp, we started single lung ventilation as we give retrograde flow. After coming off, we do MAF for all patients. And another thing is cerebral oximeter is important, but now we are not doing and checking the saturation of brain. As per my knowledge, I am sharing some probable troubleshooting during the procedures, though I am just faced only of few of these. Initially, we placed the tip of smart cannula into the RA, and the drainage was not adequate. But after shifted the tip to the SBC drain was absolutely fine. For checking the cross clamp, what you need, stop the cardioplegia, open the connection from surgical side and check whether the blood from aorta coming back or taking inside. If there is any arrhythmias after unclamp, you should consider your temperature, should check the residual air in the help of T, and you can consider additional hot shot if required. One thing I also faced that after going on bypass, after some time I check the PCO2 level in ABG is high. It's because of CO2 insufflator. You must check that CO2 insufflator may not more than -5 liter to 6 liter per minute. Team communication and hands-off are very important. You have to structure briefs on bypass, cross clamp, and hot shot, and also the weaning, and closed loop communication for all the cardioplegia dose, pressure, and temperature calls. We document every cardioplegia dose, route, timing, and if there is any changes, we announce loudly. So future trend is for smaller low prime circuits and smart sensor for air or flow pressure, which is now in the advanced cardiopulmonary bypass. And we automated cardioplegia mixer with precise pressure flow control. We enhanced DAR algorithm using T and AI prompts. And percutaneous aortic occlusion balloon, which is also known as endo balloon, we can use at the replacement of cross clamp. So goal-directed perfusion is central for the safety in endoscopic cardiac surgery, and proper communication between perfusionist, surgeon, and anesthesiologist are key to successful endoscopic cardiac surgery. So this is our one endoscopic MVR patient, fast POD. As you can see, and this is second day. He is hemodynamically stable and absolutely doing fine. This video is not opening, sorry. And this is our 73 years old female patient for endoscopic CABG. Now she is doing absolutely fine, and she is absolutely okay. Thank you.
Thank you. That was Gaurav Sasmal with the first presentation at ISACCon 2026 and finishing on time. Thank you very much, sir. Ladies and gentlemen, we move on to our next presentation with the permission of our chairpersons. Questions, and we'll be taking at the end of the session. You have a question, sir? All right. While the laptop is being set up again, once again, I'd like to remind even the audience that in case you have any questions, just please keep them with you At the end of the session, at the discretion of the chairpersons, the mics will be on, and they will take a question or two just to enable us to maintain the decorum and, of course, the schedule. Up next, we have extracorporeal cardiopulmonary resuscitation and a life ex vivo. This is being presented by Sai Priti Narayanan of Kaveri Hospital, Vadapalani.
Good morning, respected chairpersons, distinguished faculty members and colleagues. I really thank the ISEC Mumbai team for giving me this opportunity. So today, I am honored to present on topic eCPR, the advanced cardiac life support through a mechanical circulatory assistance when traditional method fails. So emergency cardiac support has evolved dramatically over the past decade. Today, we as a perfusionist stand at the forefront of the revolution of the resuscitation medicine. So as we all know, cardiac arrest is the sudden cessation of effective blood circulation. So when the heart stops, blood flow to the vital organ ceases. The brain begins irreversible injury within 4 to 6 minutes. Every passing minute reduces the survival by 7 to 10%. Despite high-quality CPR and ACLS, survival remains poor in refractory cardiac arrest. So this is where the eCPR interrupts the progression towards the death. So this is the conventional AHA guidelines of chain of survival in cardiac pulmonary resuscitation. So here the eCPR is placed between the high-quality CPR and defibrillation. So what is eCPR? eCPR refers to the CPR along with the VA ECMO. Unlike conventional CPR, 20 to 30% of the cardiac output, eCPR restores full systemic perfusion, adequate oxygen delivery, and increases the coronary and cerebral blood flow. And it always buys time to treat the reversible causes of the arrest, that is the 5Hs and 5Ts. So we often refer the golden hour, that is the early recognition of the arrest, starting immediate CPR, rapid decision making, and initiating the ECMO within 40 to 60 minutes. So these are the factors that determines the neurological survival. Note here the time is brain and myocardium. So early recognition is always important. So eCPR provides a stable hemodynamics and end organ perfusion. Most importantly, it converts non-perfusing arrest rhythm into a controlled circulatory state. So it provides the end organ perfusion, bridge to recovery, bridge to definitive interventions, and gives an adequate oxygen support, and creates time for definitive interventions like PCA or CABG to be done. So what the ECMO circuit usually consists of: venous drainage cannula, a centrifugal pump, heat exchanger, and a return cannula. So patient selection is always very important while going with eCPR. So it denotes the cornerstone for the success in the eCPR too. So the ideal candidates includes patients with witnessed arrest, initial shockable rhythm, age considerations, time to eCPR, the time when we start the eCPR, the reversible causes which can be treated, and good pre-arrest function. So these are our exclusion criteria. That is the age. In our institution, we exclude that the age less than 18 years and age more than 75 years patients were excluded. Patients with terminal malignancy were excluded. And post-cardiotomy shock with inability to wean off cardiopulmonary bypass also excluded during the surgeries. And irreversible organ failure patients are also excluded. So these are the absolute and the relative contraindications in the eCPR techniques. So general consideration for cannulation includes a rapid vascular access. Usually while ongoing CPR, femoral access provides the most accessible route. We typically used 21 to 25 French drainage cannula and a return cannula of 15 to 19 French. We always follow a Seldinger technique with real-time ultrasound guidance, as it reduces vascular injury, bleeding complications too. So this image shows the view of the common femoral vein and the femoral artery in the ultrasound, which will help us to easily guide the drainage or the return cannula as easy as possible, as early as possible, sorry. So after initiation, our monitoring includes ECMO flow, arterial pressure, oxygenation delivery, hemolysis markers, anticoagulation. We usually maintain an ACT of 120 to 180 seconds with end organ function, neurological status, and limb perfusion. The goal is not just survival, it is the neurologically intact survival. So eCPR team is never a single person effort. So the team includes the emergency physician, the cardiac surgeon, perfusionist as well, cardiologist, ICU intensivist, and a team of good ICU nurses. The preparedness and the protocolized workflow reduces the communication time and even the cannulation time dramatically. To handle these situations, simulation training is invaluable in the institutions. So this is our data. We had 25 patients who had undergone eCPR, which is taken from past 10 years, with 15 patients in past 3 years. So 4 patients were initiated with VV ECMO for respiratory arrest. Eventually, 2 were converted to VA ECMO. We had a survival of 48%, which is which comparing to ELSO registry, it is around 31 to 42%. We have a higher survival rate of 48%. The mortality, we had around 13 mortality, which was which was mostly due to unresponsiveness, inactive CNS, and multi-organ dysfunction. So here you can see, as we had 25 patients with the predominant male population, with an average weight of 67 and an average height of 159. In 25 patients, we did 21 VA ECMO, with 7 VA central ECMO and 7 VA peripheral ECMO, and 4 VV ECMO for respiratory arrest. Later, we had a conversion to be done. We had 1 conversion of VA ECMO in that VV ECMO. As I said, we had a survival of 48%. Our average ECMO support was 2 days, with an average hospital stay of 10 days. We could maintain a full flows according to the patient requirement. In that 7 VA central ECMO, we had 4 actual ECMO and 3 we did with emergency cardiopulmonary bypass. So this is the patient primarily presented with the refractory cardiac arrest. So first we initiated him with IABP. We stabilized him with IABP. Then we couldn't achieve a full stabilization. So we initiated with VA ECMO. After a few hours, patient's upper limb SATs dropped. So we couldn't wean the IABP also at that time. So we just did a right jugular venous cannulation and started with VA-V ECMO and monitored the bidirectional flow. Here you can see we see the monitors with the bidirectional flow. The red color one with the arterial flow and the blue one with the venous flow. So our weaning is considered when adequate cardiac output is improved, ventricular function is improved, stable hemodynamics is maintained, lactate level is reduced, and with reduced inotropic requirements. So here is the 2 articles. This first article is from the Journal of Cardiothoracic and Vascular Anesthesia in 2019 and 20, Boston. This article, in this article, they have taken 71 patients who underwent eCPR. They had a good survival outcome, that is off ECMO, But the outside hospital, but the discharge to the hospital, they had a extremely high mortality. So they said that the complication rates were high and the renal failure in the particular demonstrated an extremely high mortality. Actually, this was a single institution study. So they just vaguely concluded that eCPR will help improve, but the post ECMO care to be given at the most. So this is a second study which was presented in the Cardiovasc Inter. So here they have concluded that the rescue in in-hospital cardiac arrest score can be used by all the clinicians in the real time to predict the in-hospital death among the patients with in-hospital cardiac arrest who are treated with eCPR. So generally what we do is we just consider the eCPR thing. Generally what we do is we just see the eCPR. We initiate the ECMO. Once the patient is weaned off the ECMO, we just leave the patient. So the thing is that we have to go along with the patient till the rehabilitation, how the patient goes out of the hospital. That matters because our flow, what we maintain during those eCPR time, how we maintain our flows, how we maintain the patient hemodynamics is also matters. So that is what they say in the study, that we have to always maintain a scoring card in in-hospital cardiac arrest, so we can improve the refractory cardiac arrest patients' lives. So what if ECMO is not feasible at first? So we are in India, so we obviously know that everybody cannot afford ECMO at the initial stage. So what if ECMO is not feasible? So here is one case presentation I have to give. So it was a middle-aged person who who had a surgery of hernioplasty repair. Second POD, he had a sudden arrest in the ward. So patient was immediately started with eCPR. Patient was immediately started with conventional CPR. And with the ongoing CPR, he was shifted to ICU. So we got the cardiologist in. Cardiologist just had an echo, and he was definitive with the echo findings that it was sure it is a pulmonary embolism, and we have to go and treat it immediately. So immediately we took the patient into the OT. We went on to emergency CPB. So normal with central aortic and venous cannulation, we went on to CPB. So this was the clot embolus we took from the pulmonary trunk. So this was the patient's ABG. You can see that the preoperative, it is fully acidotic with high lactate levels. But immediately after an initiation of CPB, within 20 minutes, we can see the changes in the pH values. And in 60 minutes of support, you can see that pH is nearly getting normal. So acidosis is getting corrected. So for this patient, we really supported him for 4 to 6 hours in bypass. Later, we could be able to wean him from bypass itself. So on first POD, we extubated him. On fifth POD, we actually discharged him without any complications. So this is out of interest. One of the study which I came across the internet, that is from the Lancet. From the Lancet of Respiratory Medicine. So this study explains in detail about the last 10 years of eCPR data, along with how it has been evolved over the years. So my take-home message is that eCPR or eCPB for cardiac arrest is always safe. eCPR in hospital cardiac arrest patient have better outcome when it is timely done. So people, please note that we generally have perfusionist coverage of just in up to say, we don't have a full coverage of 24 hours of perfusionist. So what I say is that our 24-hour of coverage of perfusionist in hospital can improve the, even in the night, if we have a cardiac arrest patient, we could immediately go and start with the eCPR. So adequate training for a future generation, if adequate training with the eCPR is given, even we can also achieve the outside hospital cardiac arrest patient also, we can put the ECMO and we can get him back to the hospital. And multidisciplinary departmental coordination is always required, and all-time readiness and alertness to be there. So I conclude by saying this wonderful phrase, the early bird catches the worm. This emphasizes the alertness and quick action. It increases the survival of the patients as well. Thank you.
Thank you. That was Sai Preeti Narayan of Kaveri Hospital. Thank you, ma'am, for finishing on time. Before we move on to the next presentation, I'd like to remind you all that the poster presentations, which are also extremely packed, are already on in the venue, which is just on your right-hand side, the hall just opposite. We'll move on with the next presentation with the permission of our chairpersons. This next presentation is why goal-directed perfusion may not work every time, factors that may derail the practice. And for that, we have Pradeep Kumar Pillai from Kaizen Media Systems Private Limited. Medisystems Private Limited, thank you.
Right, I will just go with them. So, good morning all, and it's a warm welcome to all of you. It's always a pleasure to be back in the city where I was born and raised. So for those of you who don't know, I'm a thoroughbred Mumbaikar. So with that, we start off. This is what I'm going to talk on, why goal-directed perfusion may not work every time. I'm sorry for the title, but there are certain factors that can actually derail the practice. So these are the topics that I'm going to touch on. A brief introduction of what goal-directed perfusion is all about, the parameters that we normally discuss, which are part of the GDP practice. Then we go on to a familiar scene which most of us have encountered in our practice. A brief idea of what happens on extracorporeal circulation. What are the factors that can impact the delivery of oxygen to the tissues? How to mitigate the impact, and a take-home message. What is goal-directed perfusion? So the goal-directed perfusion for perfusionists is what flight paths are for pilots and Google Maps are for drivers today. It's basically, to be simply put, it's an index of physiological parameters within specified ranges that need or warrant constant monitoring while on extracorporeal circulation. The benefits are, this practice gives a reliable, based, predictable and favorable outcomes, reproducibility of outcomes, basically, with near parity of results observed, and you also can achieve standardization of practice. The parameters of goal-directed perfusion, well, the classic one is the oxygen delivery, made famous by Dr. Marco Ranucci and his team, which maintains that you need to have a DO2 of greater than 280 ml per minute. It goes up to 350 neonates. The oxygen consumption, which is on bypass at 95.8 ml per square meter. You have the DO2-VO2 ratio, a very important factor. In a normal individual, it should be 5:1, but on bypass with the lowered values, 3:1 is perfectly acceptable, and an oxygen extraction ratio of 0.2 to 0.3, which corresponds to a venous oxygen saturation of 70 to 80%. Now we come to a familiar scene which all of us have encountered. It's a routine case, employed mild hypothermia, you've had the cardioplegia administered, the surgery performed, aortic declamping done, weaning. The GDP monitoring was done and all the parameters under GDP were perfectly fine. But in the ICU, the situation changes. You have persistent acidosis, the patient requires inotropic support, and the surgeon starts yelling, what has gone wrong? Has GDP failed? Why are the lactates rising? So what happens in extracorporeal circulation? There is a loss of pulsatility. Obviously, non-pulsatile flow is initiated. There is flow diversion to vital organs. You have a metabolic stress, basically, CPB. Surgery itself is stress. CPB adds insult to injury, and the result is you have a generation of heat shock proteins, which is a response in generation to stress, and obviously the ubiquitous SIRS syndrome. The effect is it has capillary shutdown. you have flow compromise to non-vital organs, and in this case, the gut is the one that is the most affected because no one really cares about the gut when the heart and the other systems are in functioning on, are on demand for CPB. You have a capillary leak syndrome which can lead to ischemia, anaerobiosis, hyperlipidemia, and reperfusion injury once the capillary opens up. So the factors that can impair is the hydrostatic pressure, the colloid osmotic pressure, the use of vasopressors, and again SIRS, the good old SIRS. Hydrostatic pressure, it's the pressure exerted by the blood against the vessel wall. Now, an impedance in this or the venous return to the heart can increase the hydrostatic pressure. And the primal cause of the increase in the impedance is your venous cannula, which is present. An improperly placed cannula or an improperly sized cannula can affect the hydrostatic pressure. And what it does is it impedes forward flow from the arterioles to the venules, thereby creating a sort of a congestion in the capillary, at the capillary level. Colloid osmotic pressure, it's the pressure pulling fluid into the vessel. It opposes the hydrostatic pressure. Low COP, which is a result of the hemodilution that occurs on bypass, can, in extreme cases, lead to fluid extravasation into the interstitial space and again contributing to the same old tissue congestion and edema as was mentioned earlier. Use of vasopressors. Once CPB is initiated, we have linear flows. So there is a loss of vascular tone. To compensate for that, we need to inject in some vasopressors to maintain an adequate pressure head for generation of perfusion. So the impact of use of vasopressors is the non-vital organs again get deprived as always. There is compromised blood flow at the capillary and capillary level. And of all of the vasopressors that are in use, noradrenaline is supposed to be the lesser evil, as in low to moderate doses, it definitely preserves splanchnic circulation, something which is most conveniently overlooked during bypass. So SIRS, again, the inflammatory response mounted by the immune system to contact of blood with a foreign environment, in extreme cases can lead to loss of capillary integrity, fluid leakage into the interstitial space, and can hamper with the normal blood flow sequence. The pathophysiology of all of this. Venous congestion and hemodilution, it's a vicious combo. It pools up blood or it pools up fluid in the capillary space. There is congestion, creation of anoxic lethal corners or hypercapnic lethal corners as well, with the end result that whatever is being delivered, it does not reach the tissue. The tissue is not able to grasp the benefit of an oxygen-rich blood reaching it. Now, this is the oxygen pressure field theory, which certainly explains the formation of the hypercapnic or the anoxic lethal corners. As you see, the bright red represents the arteriolar end and the blue represents the venular end. Any loss of hydrostatic pressure or colloid osmotic pressure can shift this towards the left, that is the blue becoming more and more pronounced towards the left. This certainly impacts the availability of oxygen-rich blood to the tissue. The tissue is actually deprived. It does not have the wherewithal to get the blood somehow into the system. So what are the steps that you can use to mitigate it? Proper venous drainage, cannot emphasize it enough. Proper cannula selection and placement. A rule of thumb here is your cannula size should be 60 to 80% of your vessel size. You can use TOE to determine the size and appropriately select the cannula. Colloid osmotic pressure maintenance, again a very important aspect. Despite using isotonic solutions, the hemodilution of blood proteins need to be suitably compensated for, and here I would strongly recommend albumin in the prime and to use as a maintenance dose throughout procedures for prolonged CPB runs especially. Regulate the use of vasopressor usage. Well, it's a necessary evil, you cannot do it without, but if you do need to, preferably go in for NORAD at a moderate dose or low to moderate dose. And the standard management protocols for SIRS do apply here. Steroids in prime, although the results are very anecdotal. You also can do hemofiltration, and now you have cytosorb filtration as well. So these are the additives for optimal CPB management. One, you can use the TOE for checking the cannula position and placement as mentioned earlier in many of the talks earlier as well. You need to have an adequate sedation to minimize the metabolic stress impact. That is, you need to have a BIS monitoring in place to measure the level of sedation that is required. Some institutes incorporate the superior mesenteric artery flow and carotid artery flow Doppler monitoring on CPB to find out the flows and adjust the strategies accordingly. You can use NIRS, especially the dual chamber NIRS. So one on the brain and one on the area of the kidney gives you a fairly good picture of what is happening. And of course, venous with the modern heart-lung machines you can monitor the arterial flow on the line that is going to the patient and the venous flow that is coming back. Rule of thumb again here, the difference between these two systems should not exceed 150 ml per minute. So to conclude, GDP is a very good platform, an excellent platform for optimization of practice, standardization of practice. Monitoring regulatory factors on bypass is of paramount importance. Equally so is a close, honest, and constant communication between the members of the team. Like if the perfusionist has a problem with the venous drainage, the surgeon should look into it without a second doubt. And yes, this is my most favorite line, if you can regulate the change, you can most certainly regulate the outcome. So I thank you for your time, and once again thank the organizers of ISECCON for providing me with this opportunity to speak in front of you. Thank you very much.
Thank you, Mr. Pillai. That was definitely well within time. Thank you for helping us catch up with some of the time that we are behind. Moving on, Chair people, the next presentation is by PVS Prakash. It's real-time continuous monitoring of delivery of oxygen during cardiopulmonary bypass. Will it make a difference? We'll know in a second or two. Just to remind our paper presenters that when you present the paper, please stay around at the front of the hall. We'll call you again at the end of it.
That's okay. Sure. Yeah. And for the very good morning to everybody. I would like to thank ISECCON for giving me this opportunity. It is wonderful to be in the maximum city and the city of opportunities. So the talk is real-time continuous monitoring of delivery of oxygen during cardiopulmonary bypass. Will it make a difference? Yes, Pradeep had given an outline in the previous thing. Some of the slides are little repeated, but we'll go through it. So the disclaimer is I am sponsored for this study and talked by Thermo India, and it is a retrospective observational study. The study was conducted without any bias. The statistical analysis was done by our clinical research team. So the objective is to analyze the efficiency of Thermo CDI 550 continuous monitor and study the advantages of continuous monitoring of both the oxygen delivery and the consumption during CPB with post-operative data analysis. So mainly I have focused on the post-operative data rather than during the cardiopulmonary bypass. So this is how we all started. Even 60, 70 years back, everything was very crude. There was no proper monitoring technique. We learned from mistakes. There were a lot of trial and error, but we are in an era of AI and a lot of advanced monitoring system, so we should make use of it. So present day monitoring is more like a cockpit, like everything is coming on the screen of your heart-lung machines. A lot of new technologies have come where a perfusionist is somewhere like sitting like a cockpit with a lot of monitoring, cell saver. So many devices are required now, both for medico-legal reasons and as well as for advancing the patient care. So if you see the difference between continuous versus intermittent monitoring, there is, when we go on bypass, we give the cardioplegia. There is a lot of bias with the perfusionist also, because the perfusionist is a student in front of the headmaster cardiac surgeon, so he wants to show the best results. So what he will do, even if you give del nido cardioplegia, there is lot of hemodilution, but the perfusionist will nicely filter, send a ABG, and he will show excellent crit. The lactate levels will be low, everything is fine. But in between those 20 minutes, lot of changes happens. And we are actually not giving the patient care, but we show ourselves as we have done the best thing. In that way, the continuous monitoring will not tell lies, and it will tell you the correct parameters. And this is an important slide on the fundamentals. So a perfusionist can fiddle on with two things. One is the cardiac output, or which is his blood flow, which he gives from the heart-lung machine. And the other one is the hemoglobin, which he can either concentrate it to bring it up or down, and according to the requirement of the DO2, you can manipulate these two parameters during cardiopulmonary bypass. So this slide, Pradeep had also told what is the normal value we have to maintain, 260 to 272, and the DO2-VO2 ratio. What he said of 3:1 is the borderline. That is the lowest value, but always it is better to keep it little higher by monitoring both the blood inlet and the outlet flows. So we have studied divided the patients into two groups for continuous monitoring, and the other group was there was no monitoring, only the ABGs and other things. The sample size was 30, and all were complex CPB cases like aortic arch aneurysm and pulmonary thromboembolectomy. Having only one CDI monitor, we cannot afford to use it for a regular case, and we always prefer to use it for very complex surgeries. And we did the data analysis of all pre, intra, and post-op lactate, DO2, and LFT, and I will discuss the results of this. So if you see, the one with the orange color is without DO2 monitoring, and the blue one is with the DO2 monitoring. So post-operative lactate levels are much higher because the cases were also very complex, so it went up. But with DO2 monitoring, we were able to adjust the flows then and there. So we were able to keep it at a lower level. Same thing with serum creatinine also, which indicates the kidney failure. If you look at the without DO2 monitoring was going up compared to with DO2I monitoring. The EGFR levels were also much better in the continuous monitoring compared to the intermittent monitoring. Same thing with the post-op results of bilirubin levels, which were without DO2 monitoring, it was higher, and here it was lower. So the discussion is definitely online monitoring will improve the organ perfusion because you will keep on adjusting the flow based on your values which are coming continuously online. So the end organ perfusion is much better. The liver, kidney, and the brain are well protected. The real-time adjustment of flows and hematocrits leads to a better perfusion management. If you feel that the values are coming lower, either you can even concentrate by hemofiltration or increase your flow. Something you will keep on doing to improve the organ perfusion better. So it leads to better organ protection and definitely a lower lactate levels. Online monitoring during CPB, if you see overall, it reduces the ICU stay and the hospital stay also, because the organs recover much faster and you can transfer the patient to the ward much earlier. The scientific evidence, as we know, Marco Renacci is the father of DO2s, the delivery of oxygen and reduction in acute kidney injury, and Philip D. Soma. These are the main authors who have done, and this is nothing new. It has been followed from 2005. The goal-directed perfusion strategies, which tells about the predictors to maintain 272 ml per minute per meter square and have a better hemo concentration and maintain a higher crit. All these papers support continuous monitoring. Even the AMSEC standard guidelines nowadays, they say it will be good if you have an option and if you can use it online monitoring for a continuous basis. So what we have is a thermo CDI monitoring, which has 22 vital patients parameters which can be displayed with real-time monitoring, with partial pressures, carbon dioxide, oxygen, the potassium, even the bicarbonate level, everything, you get it. And I heard they have another version coming where the lactate will also be incorporated. That will be wonderful if you can get the lactate also on continuous monitoring. These are the two disposables which are available. One to be connected in the arterial line. It takes a bit for calibration, but once it is done, you get a continuous value. Once you need to just cross-check it with your ABG. After that, it is all fine. You have a continuous online monitoring for the measurements. So what is the value of continuous monitoring? It increases definitely the safety and reduces the risk. Adopting monitoring technologies, it will provide early warning and it will provide early detection of oxygen or gas source failures. We can prepare ourselves and correct it in a much advanced stage, and it allows a tighter control of blood parameters with desired result. I think in future, online monitoring will become a critical component of perfusion safety and improvement outcomes. And studies have shown the appropriate regulations of blood gas parameters is essential to avoid negative outcomes. So current guidelines and adoption, it is increasingly recommended by perfusion societies, the European board, the American board, everybody recommends it and use it in high-risk patients, especially very useful in high-risk patients like complex arch repairs, pulmonary thromboembolectomies and all those cases. And if you see, more and more complex cases are coming to the perfusionist. The cardiologist will take the EC stenting and other things, and elderly patients who are living up to 80, 90s, they will be coming to the perfusionist, and the perfusionist needs to gear up with modern technology. Chronic kidney disease patients, this will be a great device to tackle complex or prolonged CPB, and definitely it requires a team coordination, surgeon, anesthetist, and the perfusionist. So, does real-time continuous monitoring makes a difference? Definitely yes, it does make a difference. Continuous monitor will help in intraoperative risk analysis, reduces postoperative morbidity, it will improve organ perfusion with real-time data, it will reduce the ICU and hospital stay, and definitely future versions will have AI adoption with the help in predictive decision making, which will help, maybe if it is connected with the pump control, then the pump itself will either it can suggest the perfusionist better increase the flow, the DIT is going to come down, DO2 is going to come down, and your oxygen requirement may be higher. These are the future things which I feel it will come in the next 5 to 10 years. So online monitor will be the norm. Already it is happening in the partially in many of the centers. So this is one case of CDI monitor where we are used to give systemic potassium for the arrest. Because of a complex case, we couldn't cross-clamp it. So we wanted a systemic potassium to be given. And you can see that for the cardiac arrest, the CDI monitor, here the potassium is 2.7. You have all the values. And over a period of time, when we give the systemic potassium, you can see the potassium value going up 4.5, then to 8. And you can also see the cardiac arrest on the monitor. It has gone above 9.5. And can you see the heart becomes a straight line? This is very, very useful in very complex cases where you are having all the monitoring parameters and you can arrest the heart and know whether your potassium, whatever you have delivered to the system is adequate for the arrest. This was one another use which we found out during the usage of CDI monitoring. With that, I complete my lecture. Thank you so much, and I will take the questions as and when it is asked.
Thank you, Mr. Prakash. Once again, just to remind all our presenters that questions will be taken at the end in the common question answer session. For those of you just coming into the hall, please ensure that your mobiles and connected devices are on silent while you're in the hall. And to remind you also that we do have a poster session concurrently going on, which is in the hall as you leave the hall, just in the smaller hall up front. Can we have the tech desk to please help our next presenter? Once again, at the end of this session, this presentation, which is the last presentation in this session on advances in contemporary perfusion practice, we will then take questions from the audience at the discretion of the chairs, of course. There's a mic out there. If you could step forward to ask your questions, and our presenters would be glad to answer those questions. A few very brief questions because we're pressed for time. This next presentation is the role of auto-transfusion system as clinical improvement. And we have Manoj MC from Livanova. Can we reset the timer?
Thank you, organizers, for the opportunity. Good morning, everyone. And it's always a pleasure to be in Mumbai, personally and professionally, because I grew professionally here in Mumbai, and personally also because my both daughters were born in Mumbai, so I have a strong connection with Mumbai always. I'll be talking on, I'm Manoj, I am a clinical manager for Livanova, and I'll be talking on auto transfusion system, the role in improving the patient outcomes. So if you talk about auto transfusion system, I'll start with blood conservation strategies actually, because that is the role of auto transfusion system. So if you ask, it is normally divided in three stages: pre-operative, which is you stabilize before surgery itself, maybe iron therapy sometimes, you can do auto transfusion, or if there is an anemia, treat the underlying cause. And then you comes to perioperative, you have where your role comes basically, or as a perfusionist, our role comes. The circuit modification, fluid restriction from anesthesia side, hemostasis and surgical discipline from the surgeon side. Auto transfusion devices are also a part of it. And then comes post-operative also, because surgical discipline, and nowadays the present auto transfusion systems you can use even in post-op scenarios in ICU also. See, this concept is nothing new. It is started in 1818 by James Bundle, but if you ask me, this has started by 1914 by Jonas Thesis in gynecology. There is a gynecologist, post-cesarean, he couldn't control the bleeding, so that is how it has come. And from there, it is there widely accepted in cardiac surgery, in complex other aortic surgeries also. So the problem with auto transfusion system, whatever available in the market as of today, is because you can only get RBCs, you can't get other products. That remains the same till today, because it has got a simple, a single pre-factory setup RPM, which rotates at 5,600 or whatever it is, because to get other components, you have to centrifuge it different temperatures and different RPM, which is not there in those machines. That is why it becomes, you have no platelet, no FFP, nothing available. It's only RBC, you can get it back. Issues behind homologous transfusion, I don't think I have to discuss that in this crowd, because everybody knows that what are the difficulties, and nowadays it is most difficulty to get the donors also, because you come to a city like Mumbai, you want donors, getting donors becomes very difficult. And even the laboratory test has, the cost has increased, and now if you ask me, it is equally, if you ask one blood cross-matching, it's in a corporate setup in Delhi or Mumbai, it is close to 5,000 rupees. So if normally for cardiac surgery, if you cross-match 2 units of blood, it is around 10,000 bucks. That is how we justify the use of auto transfusion system when it comes to cost. The ICU stay, which we never say, ventilation timing, this all adds actually cost to it. And the labor, because if you want to have 3-4 donors coming for donation in your blood bank, that also takes a lot of time. Their time, energy, their wages, everything, we never take into account of those things when you calculate the cost. The complications, there are enough transfusion-related issues, starting from coagulopathy, hypothermia, metabolic abnormalities, transfusion-related lung injuries, sepsis, electrolyte imbalance. There is a lot of effects in that. Why auto transfusion is safe? Because it is patient's own blood. It is always, there is no compatibility issues, and it's always fresh, because you get from the theater, you process, within 6 to 7 minutes you can retransfuse. It is cost effective, I already told, because now if you cross-match 2 units of blood for a patient in your hospital, if you use it or don't use it gets chance to the patient. That's what we have seen in our practice. And it is readily available always, because in case of an emergency, trauma, you don't have to wait for the blood bank to arrange blood, so it's readily available. Indication, actually, we say cost-wise indication is all the three things: anticipated blood loss equal to or greater than 400 ml, procedures where routinely 2 units of blood are cross-matched, and 20% of the patient were routinely cross-matched. These 3 things I am talking about in terms of cost. Otherwise, if you ask me, even if you want one single transfusion, I will say that I don't want to take a transfusion. The cost is not that much that we can afford it, and you don't have to take an homologous transfusion. Emergency procedures, I already discussed, because you will not get time to even arrange blood. Rare blood group, some is another indication, and some religious implication, patients don't receive bank blood or blood from other people. In these cases, you can use it. As Livanova, we are in the market for more than 40 years. From 1981, the first model of Autotrans came, and the current one is Extra, which is launched in 2010. And I think in a year, we are coming with another one little modification in the Extra, and you will see another machine soon. So actually it comes in three parts. One is the cart where it is move-ups, and one you have got a centrifuge cell or centrifuge well, and then it has got an inbuilt vacuum system. That is the beauty of it. It's a silent vacuum system. You can range from -50 to -300 in OT settings. It's a robust ergonomic system. You have multiple protocols. You can make your own protocol. There are 3 or 4 set protocols which comes from the factory. It has got a built-in hematocrit monitor, because you know what is the hematocrit of the blood coming into the centrifuge and what is going into the transfusion bag. That is also available. Data management, you can have connect to a printer. It's an inbuilt printer. You get it printed. You can transfer through an RS-232 to a computer. And we have something called pre-operative sequestration facility. I'll talk about that a little late. That is now going to come in India also. We are not using it as of now in India. And there are many other modes and the technical things of it. I think we have a machine outside. Now you can have a hands-on session on that, because I don't have time to explain all that. Basically, it has got sensors for hematocrit, RBC, clamp in and out sensor, your RBC and fluid loss. If you are losing any fluid, that also it will show. And if air comes in, all sorts of sensors are there. When you come to equipment, it is one part is the equipment part, the other one is disposable part, which is a day-to-day what we will be dealing it. It comes in 2 different packs. One is, we call it as a collection set, which has got a reservoir, a capacity around 3,700 ml, which has got a depth filter with a screen and a defoamer in that, and then you have a processing unit. So we normally tell everybody to assemble the collection kit first. You can always wait to assemble the processing kit, because if the blood is, you're not getting a good amount, or the quality of the blood comes into your reservoir is not good, you can even discard it. You don't have to waste the processing unit. It comes in 4 different bowls. For small neonates and pediatric, you have a 55 ml. Then comes a 125, 175, and complex cases where aortic aneurysm, or you expect a lot of blood loss and you want to process immediately, in a higher quantity, then it comes to 25 ml. These are the 4 protocols I was telling. One is P optimum. It has got a factory set wash, how much it has to take and everything. And there is one thing called P-fat, where you expect traumas and all that. A lot of fat comes into your reservoir, so it does an extra wash. So that is P-fat. And one is P-standard, then comes P-post-op, where even if you use an OT, you can use the same circuit, shift the machine into ICU. You can keep it for at least 6 hours. You can connect your chest tubes, connect to it. And when you put the post-op mode, you can keep the vacuum as low as -10 to -100. That is an advantage of, because you can't accidentally also keep a -150 or -200 negative pressure, which is dangerous. That if you have chest cavity, a negative pressure of -150. Processing time is normally 6 to 8 minutes, but you can have a quick wash if you want. That is possible in 3 minutes. Average hematocrit is around 60 to 65%, but that depends on what you get also. It is, if you are getting all water into your reservoir, you may not get hardly anything in your transfer bag. Coming to this one, normally we say that when you're on pump, you come off, and we normally transfuse the whole thing. If you are using it in your OR, you can suck these blood also, whatever come off the blood from the pump also, you can suck into the auto transfusion system, you can centrifuge it, and you can give concentrated RBCs to the patient. That means 99% of the heparin, what is in that blood, gets washed away. So there is you don't have to depend on an extra dose of protamine and all that in this. We recommend to retransfuse whatever processed blood within 6 minutes. 6 hours, 4 hours is ideal, but you can extend it up to 6 hours. it will not clot because there is no clotting factor in that. Even people send a sample of this to check the ACT, it will never clot, it will go 999 or because there is no clotting factor in that. So if you want to find out what is the what is the heparin in that, you need to send a heparin assay to the lab. You should never do, because I have seen a lot of people doing an ACT of that, it will never clot. Then the anesthetist normally says that, no, this bleeds because you are giving this blood, so that is why my patient is bleeding. But the truth is that there is no clotting factor in that, so you can't depend on ACT. You need to send to lab for a heparin assay. This is what I was telling about, extra for sequestration. So you have a polycythemic patient coming for maybe a adult tetralogy with hematocrit of 60 or something. So you can take 2 units of blood, you can put it into sequestration set, you can get plasma and RBC separate. So RBC, if you want, you can transfuse it. If you don't want, then the plasma with all the clotting factors, you can transfuse it back to the patient. So normally sometimes we discard that because we don't want a hematocrit of very high when you come off all these congenital basically patients or coming for surgery. Pediatric patients, washed RBCs, because couple of centers in where my colleagues are working, they say that every bank blood comes to the OR, they put it in an auto transfusion system, they wash, and then only they add in pump. What we do normally is that we add in CPB by circuit, we add some normal saline or whatever, we do a pre-bypass ultrafiltration, send a lab, because it's not affording for our patients sometimes. So we don't do that, we call it as pre-bypass ultrafiltration, and we get rid of whatever lactate in that, or optimize the prime before going on bypass. But these centers, they use, they wash the cells before using it. Redo surgeries, because by the time you enter the heart, you lose a lot of blood. There is one indication for, may not be for small kids, but at least a bigger kids like 8-10 kilos and above, you can use it for all redos, so you can retransfuse the blood. Asanguinous prime, because some people believe in, I will not use blood on prime, so those cases you can use it. And rare blood groups and special population, always, it's better to use an auto transfusion system. Actually, we have taken the full circle, that's what I was telling, because it started from gynecology, it became a cardiac surgery OR specific thing. Now it is going into liver, into spine surgeries. I think because we as a cardiac surgery fraternity, 200 ml, 300 ml blood loss, we don't mind normally. We play with blood, but in orthopedics and in gynae, now they see a spurter or little blood loss, they panic. In many of the places now, what I'm seeing is that in liver transplants and scoliosis correction in spine surgeries, they are routinely using auto transfusion system, because blood loss, you can control a lot. You can control a lot of transfusion in those patients. Because I have seen multiple transfusion on a scoliosis correction because of high potassium fibrillating on table. You see the literature, you can find many, some people have a myth that in oncosurgery you can't use it, but there are papers, oncosurgery also, it is safe. And then comes to liver transplant, I already told, because some people say bile gets sucked in, but bile also gets washed. It is only RBC suspended in normal saline which goes, because the RPM is very high, it is 5,600 RPM, so everything it throws out except the RBC. So what is the takeaway is that bloodless cardiac surgery is possible with auto transfusion system if you are aiming for it. But I know always blood transfusion is not a single man job. It has got a team effect. You need the anesthesia support. You need the scrub nurse. You need the PA because they wash a lot. Everything depends on when it comes to blood conservation. And extra has got 4 bowl sizes. You can use from pediatric to adult patient. It has got a powerful silent modular vacuum pump. Thank you so much for patient listening, and if any questions I can take it now.
Thank you, sir. That was MC Manoj. We'll just have to wait a minute or two before we get to questions for you, Manoj. Yeah. But you can remain here on podium. Maybe there'll be a question or two for you. We'll take questions at the discussion of our chair. The chairs for this session include Dr. Vishwas Patil, Mr. Mikwan Nilesh, and Dr. Subhash Sawant. If you have any questions, please step up to the mic right there and ask for a question. Presenters will be glad to take the questions at the discussion of our chair, of course. But before you guys step up for those questions, there might be questions other than the scientific ones, like we're in this wonderful city of Mumbai, which is said to be the urbis prima of India. And if your spouse or if you to Mumbai for the first time, or maybe just don't want to revisit what happened to Mumbai since you were away, what happened to Mumbai? Well, there's a Mumbai Darshan bus which is ready to leave. Just head to the registration desk, and it will take you around to see what difference Mumbai makes, or what's new in Mumbai. So just to remind you that in case you want to move around Mumbai, the Mumbai Darshan bus is ready. And now, gentlemen, if it's time for Q&As, please.
Yes. Good morning. And very nice presentations today we had. Now I want to ask one question to Mr. Manoj. How much it will be cost for a patient?
I think it is something, one kit costs around 12,000 plus or minus maybe 1 or 2,000 here and there according to the states and the center also. Otherwise, it's around that. So what I have seen is that we did a study with a couple of corporate hospitals. So what we have seen that it is equivalent to 2 units cross-matching. What is the cost of it? It is close to that.
How much cost of the machine?
Machine will be. I am a clinical guy. I don't know this one, but still I think it may be around 22 lakhs or something. Yeah. It's close to that. I don't know the exact price, but it is close to that. Yeah.
Thank you very much. Can you step forward to the mic, please? Thank you.
Hi.
Yeah.
I have that is the pitfalls of auto transfusion is that is the complement activation, especially C3 and C5. So do you have any pilot study of that after post-operative it is increased that SIRS syndrome? So do you have any pilot study of that?
I have one study that was I was closing, quoting in that I have in my slide on IL-6. I can share with you that. I have one, yeah. Emmanuel, no question from you. You are a pioneer. You uses it more than me.
No, not for you, Manoj. Yeah. I think you can step down, not for you.
Thank you. Thank you.
My question is the people who did the minimal invasive and DO2 together. So I would like to ask them, in this era of keyhole surgeries and in this era of AI with DO2 and all those, how is it possible to maintain the DO2s with smaller cannulas? What are all the strategies they follow? My question is to Prakash and the minimal invasive.
Thank you. May I like to request the presenters to please step forward so it's easier and quicker to take the questions? Yeah, if you could step to the podium.
Should I answer from here or I have to come?
You could use that right now, sir. Please, yeah. Save time and just answer from there. Okay. The other presenters may be please requested to please come up forward. And people who are asking questions, if you could just please either identify yourself or the organization you're with would help.
Emmanuel, 2 things in this. It is all the more useful, the DO2 is more useful in minimally invasive surgery because you are not going to maintain the flows. And we need to see how we can manage the DO2 and VO2. So one answer is hematocrit. If it is higher, especially if we can maintain around 28-30 hematocrit, we are mostly able to manage the DO2 with even 80% of the flows. And another thing is, if there is a struggle in managing the DO2s, we can cool down little more to 28 degrees. That is what we follow. And the second thing is, the cannula technologies have also improved a lot. Like the cannulas are much thinner, and what happens is when you flow, it expands little bit. And we are able to, for example, 17 French biomedicus cannula or a Maquet cannula, we are able to flow with 4.5 liters. Of course, it is not an ideal situation. There will be a slight increase in the line pressure, but we can always fiddle with that. And with the knowledge of DO2 online, it will be very, very helpful, like either increasing or decreasing cooling and all that. That is the way we are managing the...
So what is the maximum line pressure you accept?
Maximum line pressure up to 150, 160 we accept. Gradient, I mean, this thing. Yeah. Otherwise, you cool down a little bit and reduce your flow. Most of these cases, robotic surgeries are done at 32 degrees centigrade, 32 or 33. We cool down to 28 if it is required. Sendil has any take, if he is there. Another pioneer in robotic surgery.
You both said DO2 on pump is 270, more than 275, and in units is more than
350.
But this is at 37-degree temperature. And what about if patient is at 28-degree temperature?
Excellent question, but I don't know the answer. The reason is they have done it only at 37 degrees centigrade. Even Marco Ranocchi's last year he had presented a paper in Livanova conference in Delhi. There is a leeway in that they have not exactly studied, and what happens to the microcirculation is not fully understood. So
it must be lower than
it must be low, but in order to have safeguard this thing, we are trying to maintain a higher DO2s nowadays. That is the trend as far as possible. And Pradeep spoke about hydrostatic pressure and all. So we maintain a higher oncotic pressure. Like less than 5 kgs, we add 100 ml of albumin almost to maintain a higher oncotic pressure. And a lot of papers are coming that you need to maintain an oncotic pressure of 22 to 25 millimeters of mercury for neonates like that. Any other argument from other people, we can always listen. I think Sam is raising his hands. Yeah.
Hello, this question for Prakash sir. Good morning, sir.
Yeah,
my
please.
question is that as we discuss online monitoring,
Yeah.
so in India, it is little different than perfusion. How we are medico-legally acceptable in online perfusion? Is it that online monitoring, or still we are dependent on ABG? In medico-legal I am talking. And second thing, we are in India, already we are going under cost cutting, so that cassettes or sales for online monitoring, how much it cost and how much we can explain to the management for that use. So it is regarding cost and it is medical legally. Or we are still depending on ABG in court.
80% or 90%, even we are depending upon ABG only. In between we do the DO2, VO2 calculation whenever we take a ABG and VBG, and we use Madan's app which is very handy to calculate. But online monitoring will definitely help, because though everybody says we and cardiac surgeons are a team, but when case ends up in a problem, there is always some scapegoat is tried to be found out, like where it went wrong, like that. And perfusionist being the weakest link in the team, he will be the bakra there. So it will be very, very helpful if we can convince the management that overall the long-term cost, like because the organ perfusion is better, your ICU stay will come down. The cost will be spread over a few days. Like instead of patient spending 3-4 days in the ICU, if he spends 2 days, that is a cost saving. That is how we can prove it. And I think the cost and the clinicians are opposite. Like it is like Mumbai. You can live with a vada pav for 10 rupees and you can have a 50,000 rupees lunch also. So it depends upon the center, like how much they are going to invest for the cost. I really don't have an answer for cost, sir. Like that is a big problem for all of us.
Last 2 minutes.
It will give a good this thing. Like if you know all these things, when you run the pump even without a monitor, you will try to maintain a higher hematocrit and higher flows. Nowadays, the trend of reducing the flow is coming down during perfusion, even if you have a moderate hypothermia.
Thank you.
Just wanted to comment with all the discussions going on. One thing when we talk about the cost is, first let's value the product, or let's value what we are going to get. If you understand the value, then the cost gets subdued into it. So I would request all the perfusionists and the clinicians here to understand the value rather than questioning the cost. So that is one thing. Second thing is to talk about the DO2. Whether it is adult or pediatric, the key focus here is to keep the patient in the aerobic side. Whether you're increasing your flows, whether you're decreasing your temperature, whether you're going to cannulate it, whether you're going to monitor your values, the key focus is to keep the patient in the anaerobic cycle. So as all the experts have already put forth, my say is, of course there are a very detailed structure for pediatrics basically, which is focused about 380 to 400 above ml per minute per meter square is what it is going to be dictated of. But the key take home value is focus keeping the patient in the aerobic cycle and do what is possible with us. Thank you.
Totally agree, sir. It is called area under the curve, AUC. But perfusion, never you will get a real-time situation where everything will be rosy and you will be always able to maintain. Definitely.
Wonderful, sir. Chairpersons, we have just 1 minute and it has to be a question. You have a question, sir?
This is for Manoj, sir.
Sir, this is not a question. I have just experienced from Sorin Extra Cell Saver. I did a case, phenotype, blood group, and R2R2 phenotype, blood group, patient with aortic arch replacement, where patient is prone to alloimmunization risks and immunohematologic behavior post aortic arch replacement. So we did the case with the bank blood processed with the cell saver, and we found the good result, and postoperatively there is no complication with the patient. This is my experience, and I think this is the first experience in the world which gives Sorin Extra Cell Saver very much good result.
Thank you very much. That's good to end on such a positive note. And now it's time to thank our chairpersons and, of course, our speakers. May I request the speakers to please step up on stage? Stay on stage with us, all of us, very quickly. We are very short of time, and I'm going to do this very quickly. I also like to remind those in the audience that the Mumbai Darshan bus is about to leave. If you need to be there, go to the reception. Okay, ladies and gentlemen, a big round of applause to our first technical panel today. We've had a fantastic session. Yes, all our speakers are here with us, and of course a big round of applause to our chairpersons also. I would request our chairpersons, our speakers, to please be with us on stage while I request our chairpersons to felicitate them with mementos. So starting out with the first recognition, and this is to, I'm going in the order that they spoke. Gaurav Sasmal, if you could please step to the center of stage, and I'd like to request Dr. Subhash Sawant to please present a memento to Gaurav. I'm going to make it quick, of course. All our chairs are going to present mementos. The next one goes out to Sai Preeti Narayanan, and I'd like to request Makwan Nilesh to please do us the honors. Presenters, after you get the recognition, can you please wait on stage with us in the corner? Gaurav, if you please wait here, thank you. Makwan Nilesh, if you could please present a memento to Sai Preeti Narayan. Oh, wow. Come on, ladies. So we'll keep it moving very quickly, continuously. So just for your information, the next recognition is to Pradeep Kumar Pillai, and I'd like to request Dr. Vishwash Paul to do us the honors for that one. Moving on, Pradeep Kumar Pillai. For the next one, once again, I'd like to request Makwan Nilesh to please do us the honors for PVS Prakash. That's a good, smooth transition. And finally, Dr. Vishwash Paul to Manoj MC. Thank you. I hear that some multidisciplinary hospitals also have this system where, operations happen in one theater, move to another, while the next team gets in to act. So we're going to do that little on stage. So while one is finishing, the next is ready. May I request the entire panel to please give us a group photograph very quickly together? Our chair and the panel. Please step forward, sir. Yep. Ladies and gentlemen, this is the panel and our chair. The first panel, Advances in Contemporary Perfusion Practice. Ladies and gentlemen, and thank you for that silence. A little bit of applause, come on. Okay, and now we'd like to thank our chairs for doing such a wonderful job. May I please request Jaswinder Singh to step up on stage and felicitate Dr. Subhash Sawant. Chippa Osmangani for Macron Nilesh. And Bhaskar Pant for Dr. Vishwas Paul. Bhaskar Pant, can you do us the honors for Dr. Vishwas Paul? Thank you very much, ladies and gentlemen. We now move on to the next panel of the day. Pediatric perfusion challenges, innovations, and clinical success. Once again, before we start this panel, I'd like to remind our speakers for this panel that it's a 15-minute maximum. You see the timer there. Question answers will be taken at the end of the session at the discussion of our chair. Our chairpersons for this panel, it's Bijender Singh Bali, Mrs. Shri Jayanti, and Mr. Azharuddin. May I please request our chairpersons to please grace the dais. Ladies and gentlemen, please give them a big round of applause. They're going to spend the next couple of hours on this 3 chairs transfixed. They need a little more encouragement. Come on, give them a big round of applause, ladies and gentlemen. Thank you very much. That's our chair, Mr. Bijender Singh Bali, Mrs. Shri Jayanti, and Mr. Azharuddin. All right. So I'm going to let the chairpersons do justice and the duty. Before we start the session, just to remind both the chairpersons and the speakers that the timer is there, 15 minutes for both to see. Question answers at the end of the session at the discussion of the chairpersons. And after each speaker makes a presentation, please stay near the stage so that we can call you quickly in case there's question answer requirement. With that, it's time for me to hand you over to your chairpersons for this session on pediatric perfusion challenges, innovations, and clinical success. All yours, judges, chairpersons. Thank you.
Good morning, everybody. Welcome to this 26th annual conference of Indian Society of Extracorporeal Technology. First of all, congratulations to the organizing team. Wonderful sessions, wonderful talks, interactions arranged for this meeting. So welcome you. So our session is pediatric perfusion challenges. In India, when you compare the adults, there are very few pediatric centers, and of course, and people who get trained and do this are really great because there is so many minor aspects which we have to see in pediatric perfusion. It is good that all of us should know about it. At one stage or the other, we would have a challenge to do it. So now I welcome our speakers one by one. The first speaker, Mr. Debashish Ray from Kolkata.
Debashish, bhai, kahan hai?
Yes. Hi. इसको बड़ा स्क्रीन कर दीजिए पूरा कंप्लीट बड़ा स्क्रीन नहीं होगा वही पहला वाला जो है मेरा वाला बाई वैलिड इसको बड़ा स्क्रीन नहीं होगा इससे बड़ा नहीं होगा ये दोनों क्यों एक साथ आ रहा है वन बाई वन इट शुड कम yes and now to go to this one next and this one is this. Good morning. Good morning to my respected chairpersons and all the delegates. First of all, I am giving thanks to the organizers for allowing me here and giving me this opportunity to present this scientific paper here. My paper is, I am going to present the paper. This is a clinical perfusion-based paper titled Successful Use of Bivalirudin for CPB in Al-Kappa. This paper highlights the management of a 5-month-old infant undergoing Takeuchi repair. Al-Kappa, a rare congenital anomaly, anomalous left coronary artery from pulmonary artery, presents a rare but life-threatening congenital coronary anomaly occurring in 0.25 to 0.5% congenital heart defects. Without early surgical correction, infant mortality approaches 90% within the first few years of life. Clinical presentation includes congestive heart failure, myocardial ischemia, and severe mitral regurgitation. Successful surgical repair requires cardiopulmonary bypass with effective anticoagulation strategies critical for optimal patient outcomes. The anticoagulation challenges in pediatric CPB. Standard protocol, unfractionated heparin is the gold standard anticoagulation for cardiopulmonary bypass procedure worldwide. And heparin resistance defined as ACT less than 400 seconds despite high dose heparin administration creating significant surgical risk. Underlying mechanism most commonly caused by antithrombin 3 deficiency, particularly prevalent in infant populations. Clinical imperative alternative anticoagulation strategies became mandatory to safely proceed with the cardiopulmonary bypass. Now, bivalirudin, the mechanism and advantages. Direct thrombin inhibition. Bivalirudin functions as a direct thrombin inhibitor, bypassing the need of antithrombin 3 cofactor actively. Rapid pharmacokinetics. Onset of action occurs within 2 to 4 minutes with a predictable half-life of approximately 25 minutes. Dual mechanism effectively inhibits both free circulating thrombin and clot-bound thrombin for comprehensive anticoagulation. Antithrombin 3 independent provides reliable anticoagulation even in patients with antithrombin 3 deficiencies or heparin resistance. See, you can see in the extrinsic pathway, the heparin, with the help of antithrombin 3 cofactor, it inhibits the thrombin. In case of antithrombin 3 is not there, it is absent, then in that case, bivalirudin directly inhibits the thrombin. Patient profile and presentation. One 5-month-old female infant admitted in our hospital, her weight was 4.3 kg, height was 60 centimeter, BSA was 0.27 meters square. Significant failure to thrive. Clinical presentation, acute respiratory distress, poor feeding and growth delay, sign of congestive heart failure. Diagnostics findings, echocardiography, dilated LV, left ventricle, severe left ventricular systolic dysfunction, confirmed Al-Kappa anatomy means LCA was arising from the left-facing sinus of the main pulmonary artery. Moderate to severe mitral regurgitation, mild TRO was also there. So surgical plan, Takeuchi repair, procedure scheduled to re-establish dual coronary arterial blood supply and restore myocardial perfusion. Operative details. Procedure type, Takeuchi repair, intrapulmonary artery baffle to redirect LCA flow from the aorta. Total CBB time was 125 minutes with the stable bivalirudin anticoagulation throughout. Aortic cross-count time was 98 minutes of myocardial protection with cold blood cardioplegia, that means it was used del nido. perfusion pressure, mean arterial pressure maintained 40 to 45 millimeter mercury throughout the CPB. And for adequate tissue perfusion, LA pressure was maintained 8 to 10 millimeter mercury. Hemodynamics, hematocrit was maintained around 27 to 29% throughout the CPB. Venous saturation was maintained around 75%, and moderate hypothermia was around 28 degree to 29 degrees Celsius temperature. See, reasons for bivalirudin. Pre-CPB, hemodynamics was all right. Baseline ACT was 138 seconds. This is very important thing, how we have gone for bivalirudin. So baseline was 138 seconds. Before cannulation, heparin was administered 16 mg, that means 4 mg per kg body weight. First, post-heparin, ACT was 220 seconds. We repeated the sampling done after 5 minutes. ACT was 179 seconds. Administered another 10 mg heparin from different batch number vial. ACT done after 5 minutes from different ACT machine. And ACT machine used Medtronic ACT Plus. Bivalirudin loading, this is, now the ACT was 206 seconds. Total 26 mg heparin, that means 6 mg per kg was given, but target ACT was not achieved. Now FFP, 15 ml per kg, that means 60 ml FFP was administered slowly over 30 minutes. Waited for 20 minutes and repeated ACT. It came again to 26 seconds. So we confirmed it was a case of heparin resistance due to antithrombin 3 deficiency. As in a life-saving scenario, we decided to administer bivalirudin as an anticoagulant. Perfusion management for anticoagulation strategy of bivalirudin. Bivalirudin loading dose was 4 mg, that means 1 mg per kg that was administered. CPB circuit was primed with 25 mg of bolus of bivalirudin. After 5 minutes, ACT was more than 650 seconds. So CPB initiated with the maintenance infusion of bivalirudin. During CPB, infusion rate was 2.2 mg per kg per hour. We prepared bivalirudin infusion at 5 mg per ml in a 50 ml syringe. On CPB, ACT was checked in every 25 minutes. The ACT was more than 850 seconds. After 50 minutes of CPB, bivalirudin infusion rate was reduced to 1 mg per kg per hour as the ACT was more than 900 seconds. Bivalirudin infusion was discontinued just before weaning of CPB, and the mapping was done very carefully. The recirculation lines of the CPB circuits were continued with 0.5 ml per minute of bivalirudin. No protamine was used. Circuit management considerations: avoided the stagnant blood zones like connectors, as much as less connector used in the circuit. Pump flow was continuously maintained, and cardiopulmonary suction minimized, temperature maintained at moderate hypothermia. MAF performed cautiously since bivalirudin remains active in the filtrate. CPB initiated smoothly with ACT values checked every 25 minutes and consistently within the target range. Post-operative bleeding management. After wean-off, the bleeding was the main concern. 2 units of cryoprecipitate, 1 unit of platelet, 1 unit of PRBC was transfused post-wean-off. We checked the ACT 60 minutes after wean-off from CPB, and it was 410 seconds. Surgical hemostasis had been ensured, and the patient was shifted to ITU with hematocrit of 44%. ITU management. In ITU, the patient was bleeding, but it was gradually reduced. Total surgical drainage was around 400 ml in 12 hours. Inotropes and vasopressors gradually reduced. 2 units of PRBC, 1 unit of platelet, and 2 units of cryoprecipitate, and 1 unit of FFP were transfused in ITU in a span of 12 hours. Then ACT was measured. It came 182 seconds. That was in the next day morning. Re-exploration was done, but no surgical source of bleeding was found. The patient was transfused to total 3 units of PRBC, post-re-exploration, first and second POD. The patient started improving gradually. On 4th POD, the patient was extubated with milrinone and dobutamine support and shifted to the step-down ITU. The patient got discharged on 12th POD after some supervision in the step-down ITU. So no drug reaction were found for the patient. ACT response comparison, you can see, this is the two lines, two graphs are there. The down graphs are, you don't have, excuse me, any pointer? Yeah. See, you can see this is the ACT due to giving the administering the bivalirudin, and this is the ACT due to administer the heparin. So this is the differences. This is the comparison activated clotting time response demonstrates the dramatic difference in anticoagulation efficacy between conventional heparin therapy and bivalirudin in this heparin resistance patient. Bivalirudin dosing protocol, I have already told you. Loading dose intravenous bolus of 1 mg per kg administered immediately prior to cannulation to establish rapid anticoagulation, and circuit priming 25 mg bolus was given directly to the CPB circuit. Maintenance infusion, continuous infusion was 2.2 mg per kg per hour throughout the entire duration on cardiopulmonary bypass. Though it was come down, I have already told you, 1 mg per kg per hour after 90 minutes, I think so, yeah. ACT after 50 minutes, sorry. ACT monitoring, serial ACT measurement performed every 20 to 25 minutes to ensure therapeutic anticoagulation levels. This is ACT monitoring during CPV. This is the bar chart. You can see this is the, after giving the bivalirudin, this is the loading, post-loading bivalirudin 650, and going on CPV initiated, now it is more than 800, and then it came up to more than 900, and it keeps remain on 900 ACT throughout the CPV. This is the time, and this is the ACT values. Bivalirudin pharmacokinetics mechanism of action. Bivalirudin is a synthetic 20 amino acid peptide that binds directly to thrombin's active site and substrate recognition exosite. The dual binding provides potent inhibition of both circulating and clot-bound thrombin. Metabolism and clearance, approximately 80% metabolized by proteolytic cleavage and 20% renal excretion. Plasma half-life was 25 minutes. In patient with normal renal function allows for predictable offset of anticoagulation. See, this is the 2 to 4 minutes of onset time, and this is the 25 minutes of half-life time, and proteolytic clearance is 80%. Risk stratification for heparin resistance. This is the high risk, highest risk, high risk, moderate risk, and standard risk. This is neonates, highest risk, neonates, prematurity, previous heparin exposure, highest risk, infant less than 6 months, complex CHD, prior CPB, moderate is history of thrombosis and liver dysfunction, and this is standard is older children, first cardiac surgery. Preoperative screening, baseline ACT measurement, antithrombin 3 levels assessment, it is not there in our hospital. So coagulation profile analysis, prior heparin exposure history. Intraoperative vigilance, post-heparin ACT, 3 to 5 minutes, post-response curve evaluation, antithrombin 3 supplementation consideration, and alternative anticoagulation readiness. Conclusion and clinical implication. Safe alternative. Bivalirudin represents a safe and effective alternative anticoagulation for CVB in pediatric patient with documented heparin resistance. The early recognition, prompt identification of inadequate heparin response through systemic ACT monitoring is crucial for the patient safety and procedural success. And perfusion excellence, meticulous perfusion management is very much important here, and the expanding application bivalirudin role in pediatric cardiac surgery continues to expand, offering solution for complex anticoagulation challenges. Take-home messages: think early, suspect heparin resistance when ACT fails to respond, act wisely. Bivalirudin offers predictable antithrombin 3 independent anticoagulations, then perfusion meticulously, continuous flow and vigilant circuit management are essential. Plan ahead. Absence of a reversal agent demands precise strategy with prior protocol, and vigilance vivalurin is a safe and effective alternative during CPB. This is vigilance. Work as a team, success depends on the coordination between the surgeon, anesthetist, and the perfusionist. Acknowledgement this case report contributes to the growing body of evidence supporting bivalirudin use in pediatric cardiac surgery and highlights the critical role of perfusion expertise in achieving successful outcomes. These are the references. This is the operation was going on. I am running the pump here, the artificial heart lung machine. This is HL20 is using here. And this is the patient is going home all right with her parents, and myself is here, and my colleagues Ujjal and Kaustav is there. Dr. Ritojyoti and Dr. Jaita, the intensivists are there, other ITU nurses are there. So thank you very much.
Thank you, Mr. Debashish. Very interesting topic. We'll have the questionnaire at the end of the session.
Thank you, ma'am. Thank you very much.
Next, I call upon Ms. Vaishali Ritesh from Chem Hospital. And the topic will be complex can be transformed into a success, a case report, intra-aortic arch repair.
Good morning, respected dignitaries, my friends. I am Mrs. Vaishali Ritesh Mete, clinical perfusionist, CVTS, KEM Hospital, Parel, Mumbai. I am going to discuss about the complex can be transferred into success, a case report, interrupted aortic arch repair. Under this, we are going to discuss about its definition, types, history, diagnosis, its plan, conduct of CPB, post-op recovery, and conclusion. Sorry. First of all, we see its definition. Interrupted aortic arch is a condition or anomaly in which artery does not allow continuity of flow from ascending to descending aorta. Basically, it is an interruption. Its types splits into the three types ABC. There are three types. It depends on the Sillery and Patton's declassification, 1959. Sillery and Pattis are the name of scientist. The types are given: type A, type B, and type C. First, we'll see for the types. Type A, it is occurred 40% of total occurrence of the anomaly. This type A, there is an interruption distal to the subclavian artery that is ipsilateral, that is it's at the one side of the second carotid artery. You can see clearly the interruption here. It is below the left subclavian artery. Now we'll go to type B. It has occurred generally 50% of the total occurrence of the anomaly. It is the interruption below the second carotid anilateral subclavian artery. At anilateral, it is the in between with the LCC and LSA. And type C, it is found rarely. It is 5%. It is interruption below the between the carotids. Here, it is a interruption between two carotids. Now we'll see the associations. Association means that interruption is found with the some anomalies that is described as type A. It is generally found with the aortopulmonary septal defect in TGA. Type B is most common along with the contractile anomaly with the large VST, subaortic, and DGO syndrome. DGO syndromes are the syndromes in which there is a cyanosis of the skin and the palate left lip-like structure in the patients, and basically the broad nose and eyes, these this is a D-Jaws syndrome. It is quietly resembles with the Down syndrome. Type C, it is rare. It is found with the along with the VSD actually, or any shunt in the artery and aorta and pulmonary artery. It is so rare. I didn't mention it in the PPT. Now we'll see the case history. Patient was a 4-year-old female child. Its pulse was 115 beat per minute. BP was 110 of mercury, 110/70 of mmHg. Heart rate was 115, temperature 98 Fahrenheit, and patient with the chief complaint of cough, cold, and upper respiratory tract infections. Now we'll see the diagnosis. It includes X-ray, 2D echo, and CT MRI. In X-ray, we can see it is a dilated LA and left ventricular hypertrophy. And in 2D echo, clinical findings are, of course, it was congenital heart disease, interrupted aortic arch type A. There was a small mid-muscular septal defect, that is VSD, it is left to right shunt, and large patent ductus arteriosus that shunt supplies to the descending aorta. Of course, as I described in the X-ray, it was LA was dilated and left ventricular hypertrophy, and patient having the severe pulmonary hypertension. In CT, we can see in first side there is a PDA that is joining to the descending aorta, and in third slide we can clearly see these pulmonary arteries giving rise to the descending thoracic aorta. So the distal perfusion was going through this shunt, and it was causing a large difference to the lower extremities pressures. Now we'll discuss about the plans. Plan was described as a perfusion perspective rather than surgeons. Patient's height was 101 centimeter, weight 13 kg, BSA of 0.61 meter square, blood flow rate 1.58 to 1.83 liter per minute, HB 13 grams, PCV 39, CPCV 25.8, blood group of B positive, create 0.8. We decided to go with the pediatric oxygenators and tubing, 2 12 French straight tip arterial cannula for dual cannulation, innominate and pulmonary. 16 French, 18 French venous metal tip cannula for SVC and IVC cannulation respectively. 18 gauge aortic root needle for cardioplegia administration. It was small, but as surgeon demanded for the 18 gauge, so we had to give it an 18 gauge aortic root needle. And of course, we decided to use hemofilter for hemoconcentration. Here our setup after priming. And in conduct, patient taken in OT, complex, all invasive monitor lines attached, right radial and left femoral artery lines take to understand the gradient pre-op and post-op. Patient intubated under GA, NIRS monitor applied, painting and wrapping done under aseptic conditions, sternotomy done after the pericardium open, then stage bursting taken. Aorta cannulated with 12 French aortic cannula near the innominate artery, and another 12 French arterial cannula in main pulmonary artery. Main pulmonary artery cannulated because it was acting like a descending thoracic aorta, and it would help us in cooling the patient uniformly. Both arterial cannula attached with the help of Y connector in arterial line. We can see monitor that showing the difference between right radial artery, that is 90/60, and left femoral artery 39/21. It is because of the low pressures in the lower extremities. Here in two pictures, I have shown the preparation of arterial and venous cannula. The downward side Y, it is prepared for the venous cannulation, and upward that clamped Y is the preparation for dual arterial cannulation. And in second picture, we can nicely see the color difference. One cannula was placed in the aorta near the innominate artery, that showing bright red color, and then another cannula was placed in the main pulmonary artery. Then again, we will go through the procedure. Then SVC and IVC cannulated with the 16 French and 18 French metal tip venous cannula. CPB started. Here I want to mention that both pulmonary artery were snug to avoid excess flooding or towards the lung or lung overload. Cooling started with 1 degree per 3 to 5 minutes, keeping the gradient below 10 degree up to the 18 degrees Celsius, and it took about 50 to 60 minutes for cooling. In between of cooling, as we go to 28 degrees Celsius, aorta cross clamp, delnudo cardioplegia deliver, ICR VSD done. Just after TCA, arterial cannula has turned to innominate artery and pulmonary artery cannula clamped. TCA done for 90 minutes for 18 degrees Celsius. Antegrade cerebral perfusion started at the rate of 10 ml kg per minute during the TCA. Here, I just want to add that when we are going to the antegrade cerebral perfusion, there are two types of cerebral perfusion is there. Whether we want, it is not decided previously whether we want to go with the unilateral or bilateral. So for that, it should be basically decided on the basis of circle of Willis of the patient. If the circle of Willis of the patient is complete, then we have to go with the unilateral, and if the circle of Willis of patient is not complete, then we have to go with the bilateral or unilateral antegrade cerebral perfusion. And there are many scans are available like magnetic resonance angiography and advanced color Doppler, carotid Dopplers. From that we can decide the circle is Willis is complete or not. Then patient head is covered with the ice packs for the neuroprotection, additional sodium bicarb, thiobentane, 10 to 15 mg per kg, and methylprednisolone 30 mg per kg added to the circuit for adequate dosing just before the TCA for the purpose of protection. Then PDA ligated, aorta reconstructed and attached to the distal aorta. It was the homograft. We didn't use any another graft. Innominate artery cannula turned to the ascending aorta, then circulation started. Deworming done slowly at 36.6 degrees Celsius with the hike of 1 degree per 5 to 7 minutes. Keeping the gradient below the 10 degrees Celsius, it took around 80 to 90 minutes. After that, dearing done, proper rest time given. After releasing cross clamp, we come off bypass gradually. Here's a small video that of operative field. Sorry, I can't give you an exact view of the of operation. Here the screen time, total bypass time was 311 minutes, that is around 5 hours, and clamp time 201 minutes, and rest time was 68 minutes. Post bypass ABG, and here the monitor showing that difference that was quite different values that come to the same value. That is left subclavian artery, sorry, it is right radial artery and left femoral artery. It was come near the same values after the correction. Here is the patient. It is a photo of late recovery of the patient in the ward. And from this, we goes to conclusion with the complex cases can also be performed with the ease if proper surgical, anesthesiological, and perfusion management techniques used collectively. Thank you.
Thank you, Vaishali. Next.
We would like to invite Ramakrishna from Narayana Institute of Cardiac Sciences, Bangalore, and he will be presenting successful bridge to transplant of bivalve pediatric patient, a case report.
Good morning, everyone. On behalf of NH Perfusion Department, I am here to present a successful bridge to transplant of bivalve pediatric patient, a case report. Introduction. Pediatric dilated cardiomyopathy, the most common cardiomyopathy in children. Incidents were 0.6 to 1% in 1 lakh children in a year, higher in infants, characterized by LV dilatation and systolic dysfunction. Approximately 40 to 50% risk death or heart transplant within 5 years. Advanced cases required mechanical circulatory support like ECMO and ECMO for a short-term stabilization and VAD for bridge to transplant. Bridge to transplant strategy improves survival in end-stage heart failure. Coming to objective, to present the case of 14 years old male with dilated cardiomyopathy with required prolonged BiVAD support for 51 days as a bridge to transplant and subsequently underwent a successful heart transplant. Challenges in pediatric heart transplant. Pediatric patients with congenital heart disease often have undergone some surgery for palliative procedures. They have complex anatomy which needs tailoring of implantation techniques, highly sensitized from previous blood transfusion, exposure of homograph materials for repair, elevated panel reactive antibodies, and high pulmonary vascular resistance, resulting in high chances of rejection, complications in post-op management. It's becoming difficult. Coming to case presentation, and 14 years boy is achievements of state level athletes with multiple achievements. His initial he presented with fever and prolonged progressive breathlessness. He evaluated in one of the small clinics, and echo finding shows severe LV dysfunction with EF of 20 to 25%. He was progress in symptoms was recurrent breathlessness, reduced exercise tolerance, unable to cope up with the physical exertion. This patient went to Delhi, patient went to Delhi NH Gurgaon, evaluated, he diagnosed with dilated cardiomyopathy, referred to advanced leading a NH heart failure center, and we are active in transplants and circulatory support. Patient was referred to go to NH Bangalore. Course of treatment in Bangalore, first deterioration in after 2 weeks. Patient is admitted in emergency admission for the initiated IABP in cath lab. Hemodynamically stabilized, achieved, and discharged after 1 month. And second deterioration, and again a patient is readmitted after a few months, and then we initiated IABP, but switched out because he is unstable, and we switched out to bioventricular assist device. In February 2025, he developed acute decompensated heart failure, and his EF in subsequent months, his EF further reduced to 15%, and he is listed for a transplant. Decision for mechanical circulatory support. Indications for BiVAD: severe biventricular dysfunction, EF of 15%. Recurrent acute decompensated heart failure, LV apical thrombus, pulmonary embolism, renal infarct for end organ involvement is there. Hemodynamically instability despite of IABP, listed for emergency heart transplant, Intermax profile 2. Why not LVAD alone? Patient size, LVAD BSA should be more than 1.8 meter square. High risk of right ventricular failure, pulmonary embolism, which will increase RV afterload, global ventricular dysfunction, not isolated LV failure, risk of septal shift and RV collapse with isolated LVAD, high risk of RV failure and post LVAD. This is our circuit. Cannulation strategy, we used a CentriMag and PC coated circuit. And for LVAD, axis cannula is LV apex and return cannula is aorta. And RVAD, RA is a axis cannula and return cannula is a pulmonary artery. These are the RPM for LVAD, 3800 to 3100, lowest RPM, flows 6 liters to 3.5 liters. And RVAD is RPM was set for 2.8 to 2.6, 2800 to 2600, and 4 liters to 2.5 liters. BiVAD perfusion management, flow target set to be prevent pulmonary edema and pulmonary edema hemorrhage because of back pressure. Remember, BiVAD is a ventricle become a filling chamber. If not kept empty, it can cause pulmonary hypertension and lung failure, requires additional oxygenator in RVAD. Always, as perfusionist, we remember as soon as we initiate the BiVAD, LVAD flow should be more than LVAD flow should be more than RVAD flow to tackle this situation. Otherwise, we'll be ending screwing if RV and we need to add a oxygenator. Anticoagulation management. Posting a perfusionist, it will be, he can monitor oxygen, perfusion and temperature management and daily mobilization. And anticoagulant strategy for this particular patient is heparin we use for 20 days. And we, after that, after 25th day of BiVAD, we switched over to warfarin. And heparin was disconnected. Warfarin dose was subsequently titrated based on INR. These are the ACT we maintained during ACT was 160 to 200 and INR was 2 to 3 when we used warfarin. We used to mobilize daily, and as a perfusionist, we should be very careful when we are mobilizing because a lot of tubes are coming out from the chest. We should be very, very careful. And daily, if patient is, we need to make him that you need to be mobilized properly. If you mobilize, it will be good. And we used to cover the circuit with aluminum foil to maintain the temperature. Just a minute. Post-transplant outcome. Successful orthotropic heart transplantation. Post-transplant echocardiography shows EF 57%. Adequate graft function. No documented primary graft dysfunction. Stable blood pressures with mechanical support. Hemodynamically stable at discharge. Actually, when we are supporting him for a BiVAD, after 42 to 45 days after he got a infection, transplant was delayed, and after that he underwent proper antibiotic therapy. Then he first initially listed for transplant, but he got infection. Then we treated, then followed by, then he underwent a successful heart transplantation. Coronary angiogram, normal coronaries, CT chest, no active infection, maintained nutritional status, gradual recovery during post-transplant hospitalization. Experience of BiVAD management, supported for 51 days, maintained daily mobilization, good appetite and preserved nutritional status. And as I told before, there is infection when BiVAD. Then later he was recovered from the infection and underwent transplant. Transplant delayed by 1 week because of infection. After blood cultures turned negative after antibiotic therapy, successful underwent heart transplant. Post-operative recovery was uneventful. Discharged after 1 month in stable condition. Summary, pediatric dilated cardiomyopathy can be rapidly, even in athletes, progress in rapidly in athletes. Early recognition of mechanical sulfate support is crucial. Biventricular BiVAD can safely bridge pediatric patients in transplant. Nutrition and mobilization strategies improves the transplant readiness, and multidisciplinary team is crucial for success. Thank you.
Thank you, Ramakrishna. Nice presentation. We'll have the questionnaire later.
Okay. Madam, I want 2 minutes. I just want to congratulate Prakash sir receiving Best Achievement Award, Life Member Award. Sir, it is happy, sir, we working with you. It is actually working in NH is very, because is my HOD, why I want to tell you something. Because here we have some 4 floors and some 15 cardiac OTs, cath labs, and leading as a HOD in last so many years. It is it's a very tiring job because running some 30 to 40 cases per day, and nowadays cath lab, lot of TAVIs are going, and here also there are a lot of emergencies will be there. Handling is very difficult, but sir, working with you is we are very happy because thank you.
Next speaker is Mr. Sujit Gopichand Bame from Fortis Hospital, Mumbai.
Good morning, everyone. Thank you, Isaac, to giving us opportunity. So here, my topic is listening to the TCU oxygenation NRS in children with heart surgery. So basically, how organs are actually receiving the oxygen, not just how oxygen looks in the blood. So as we all know, brain is vulnerable during pediatric cardiac surgery. So there are there are many articles which shown us the new brain injury in MRI seen in 36 to 73% of neonates undergoing surgery with CPB. That injury may be white matter injury, ischemia, ischemic infarction, hemorrhage infarction. Or somewhere in preoperative MRI injury is seen in 20 to 30% of neonates. In infants, 21 to 69% incidence of long-term neurodevelopment problem after infant congenital heart surgery were observed. Recent emphasis has shifted away from cardiopulmonary bypass. Should patient factor be considered? Yes. See, prenatal condition, genetic condition, socio-economic condition of the patient, and perioperative should be considered. So, to see in all those problems, we need to consider the cerebral oximetry monitoring, that is NIRS. We have to monitor. So these are the many articles which gives us idea why NIRS is required. So basically, what is NIRS? NIRS is a near infrared spectroscopy. It is non-invasive monitoring tool. It uses near infrared light 700 to 1000 nm to measure tissue oxygenation. It provides continuous bedside monitoring of regional oxygen saturation, that is RSO2. Why it needed? Children, especially neonates and infants, have limited cerebral autoregulation and are prone to hypoxia and ischemia. CPB with deep hypothermia, TCA, low flow perfusion increase the risk of cerebral and end organ injury. So our conventional methods of monitors like ABG, pulse oximetry, blood pressure may not reflect the regional oxygen delivery accurately. That's why we need NRS. So my indication to use of NRS in neonates, like neonates with complex congenital heart surgery like HLSS, interrupted aortic arch, coarctation of aorta, TAPOCs, TGA, shunt surgeries, and in paid group, severe cyanotic child with corrective surgery, topped with multiple epicollaterals, MAPCAs, BDGS, redo surgeries. So how it apply? We need how apply NRS pad. So it look like ECG electrodes. So first we need to prepare the skin For skin preparation, clean and dry the forehead to remove oil and debris. Pad position, place NRS pad bilaterally on the forehead, ensuring correct alignment above the frontal lobe. Firm attachment S to secure pad firmly but avoid excessive pressure to prevent skin irritation. Check signal S, we have to ensure the device detects consistent and stable reading before proceeding with monitoring. Yes, we need to see the renal oximetry. So renal NRS probe position, we place the probe over the left renal bed on the left flank just above the hip. Why we need to check renal oximetry? Yes, in many diseases like coarctation of aorta or arch surgery, during surgery we may compromise the lower body perfusion. So that time we have to see the renal oximetry. So after placing two pads, we see monitor look like this. So how it works? A sensor emits near infrared light. Light penetrates skull and brain tissue. Hemoglobin absorbs the light differently depending on the oxygenation. The detector measures how much light returns from the cells. So there is one law, that is Beer-Lambert law. So it needs work on Beer-Lambert law. The machine calculates the exact RSO2, that is regional oxygen saturation. So what needs measures? So it measures regional oxygen saturation, that is RSO2. It reflects cerebral oxygenation, balance between oxygen delivery, that is DO2, and oxygen consumption, that is VO2. What should be normal brain values on NRS? In adults, we consider it is 55 to 75, and in pediatrics and neonate group, it is 60 to 80. So here one important note, always document the baseline NRS value, that is before pre-induction. And thumb rule is, if our RSO2 value is below the 20% of the baseline, so we have to act immediately. So temperature NRS, yes, temperature affects on the needs value. During cooling, below 22 degrees Celsius temperature, demand drops faster than supply. So needs, we get NRS value up to 80 to 90% or sometime above that. So we call it luxury perfusion. So yeah, that condition we can reduce the flow. During rewarming, as we all know, demand and supply ratio changes. So faster rewarming may drop the NRS value. So here we can slow down the rewarming or increase the blood flow, or in some condition we have to may increase the hemoglobin. So when to intervene or when perfusion should be alert? Yes, when RSO2 value is below 20% of baseline, we have to react. So first check the needs sensor pad position. So here we have to consider many aspects like mean blood pressure, oxygen saturation, CO2 level, pump flow, venous drainage, hemoglobin. So there is one famous Dinol protocol. So in that, as we seen cerebral desaturation, here we apply two pads. So that is bilateral, either saturation bilateral deduction or one side deduction. So that time we have to just first check, verify the head position, inspect the central, inspect the cannulation, either aortic cannula or either venous drainage. If after inspecting all those things, still there is reduction in needs value, first check the mean arterial pressure. If mean arterial pressure is okay, we have to check the systemic saturation. So it is, if saturation is down, we have to act on that. If saturation is okay, still needs value is down, we have to check the PCO2 of the patient. If PCO2 of the patient is below 35, we have to increase the PCO2 level. If still PCO2 level is correct, still needs is down, we have to check the hemoglobin. Because needs value is also directly proportional to hemoglobin. If our hemoglobin is below 10, we have to correct the hemoglobin level. So advantage of needs, yes, it gives pre-bypass cerebral oximetry. It helps to identify compromised perfusion in duct dependent circulation or patient with low output state.
It guide us as a perfusionist for pump flow, perfusion pressure, oxygenation, hematocrit. It is useful especially in TCA and selective cerebral perfusion. Benefit to manage inotropes and ventilation and fluid management later on post-surgery. So factor affecting on the NRS, yes, there are many factors which are affecting on the NRS. First is affected by the extracranial tissue, skin and scalp, as NRS light should pass through skin, fat and skull. So this tissue may absorb some light, so that time we may get low NIRS value. Reading may influence by the scalp blood flow, skin temperature, as we already seen how temperature effect on the NIRS value. Vasoconstriction, vasodilation, false reading may can occur even the brain oxygenation is normal. So false sensor placement, oily skin or sweat may can affect the NIRS pads, and there we will get low NIRS value. Low HB, yes, low HB absorb less light, so we get low NIRS value. NIRS light penetrate only 2 to 2.5 centimeter in the tissue, so in big patient or little big kid or adult patient, it may get false value. NIRS is sensitive to the high intensity OT lights because it work on Baird-Lambert law. So because of photodetector saturation law, we may get less NIRS value. Excessive head elevation can reduce the NIRS value. So NIRS during MUF S. If we are doing AV MUF, we are stealing the blood from the arterial line. So that time we may get low NIRS value. So TCA, yes. During TCA, we are cooling below the, we are cooling towards the lower temperature. So at time, if we are cooling very fast, so that time maybe we get deflection in the NIRS value. So here what we can do, here we have to see the baseline of the NIRS. If our NIRS value is going down below the 20% of the actual value or basic value, then we have to we have to go towards intermittent TCA to avoid excessive low in NIRS value. So limitation of NIRS uses, yes, in country like India, the cost of the pads we have to take in consideration. Incidence of major CNS complications nowadays have reduced over the last few decades because of better perfusion techniques. It unable to correlate NIRS critical value and clinical impact. Sometimes it gives abnormal value without any clinical instability. So still, after all those things, still cerebral oximetry is one of the essential monitoring tools during cardiopulmonary bypass. Thank you.
Good presentation, sir, and very informative. Thank you, sir.
Thank you.
Next, I call upon Mr. Karthi Murugan from Christian Medical College, Vellore. And his topic will be on modified MUF circuit for effective ultrafiltration and better outcome, comparative analysis of two MUF circuits.
Thank you, sir. Thank you for the introduction. Very good morning to everybody. I know we are in the era of AI, robotics, and we are going so farther, but still my talk is on MUF because it's an institutional practice, so where we are in Rome, we should be in the Rome. So I'm going to talk about the MUF circuit, which we have made, and the effective outcomes which we have experienced and we are experiencing will be about my talk. So warm wishes from CMC Vellore. So I don't want to dig about the things which we all know. So we all know that these are the types of ultrafiltration. We can also classify based on the like pre-bypass, during bypass, and post-bypass. So MUF is absolutely post-bypass ultrafiltration. So modified ultrafiltration, it's usually employed in the termination of cardiopulmonary bypass before protomy, and the surgery like procedure or the repair is complete. So it has been proven that it have reduced the accumulation of the total body water, which will increase the hematocrit and which will eventually lead to the better outcome in the ICUs and the patient outcome. So it also proved that it removes the circulating pro-inflammatory mediators, which results patients doing well in the post-operative. So in history, the MUF was first done in 1991 by S.K. Naik et al. And in CMC, we have adopted this MUF in 2010 by the team who has come from Liverpool. So I will keep this earlier MUF technique in the CMC, which was adopted from the Haldari Hospital as a group A, where the filter will stay at the single place throughout the procedure, where the cardioplegia pump will be utilized for pre-bypass ultrafiltration, conventional ultrafiltration, zero balance or dilation, and also for the MUF. So in these techniques, we have noted like whenever the patient receives the second dose of cardioplegia, despite washing out the heat exchangers properly, we felt that the cardioplegia was not sufficient or the wash is not sufficient, which were end up in one more pint of blood in the adding in the circuit. So we eventually came to the new circuit. So before that new circuit, I want to discuss the drawback which were happening in the A. It was very difficult to assemble. We have to have a close watch to the circuit to make sure there is no air entry in anywhere, whether it is clamped properly, where the clamp should be there or where the clamp should not be there should be watched. So it was very difficult and tedious for us, and we may need, at the end of the day, we may need 2% to look after the MUF as well as the main pump. So we felt these are the things which need to be sorted out and we need to overcome. So we came up with this group B. So group B will be like hemofilter will be kept in a place for zero pre-bypass, zero balance ultrafiltration cuff, and it will be postponed to the before heat exchange while doing MUF. And it was everybody while doing like this only, but we felt good results due to that advanced machines. And also any patients like more than 12 kg with 12 gram, we were not adding any blood for these groups and any pediatrics. So we were able to maintain 8 grams during bypass, 10 gram while coming off bypass with these MUF techniques. So this is the thing. So the pre-bypass ultrafiltration cuff and zero balance will be done like where the filter will be in between, like I may put while lower in the recirculation line or the purge line will be utilized, and through this circuit all the ultrafiltration will be carried out. Post procedure, this hemofilter will be put back here and we will be doing the MUF. So we were happy with the results, and I will show you in the upcoming things. So this is the same thing, like blood will be routed to the hemofilter to the reservoir in these 3 types of ultrafiltration. This group B, I'll add one more layer to the existing connectors in the heat cardioplegia device. So these 2 will be utilized for MUF. So this is how the MUF things will be done. So you can see that adding the filter inlet and filter outlet. So I'll tell something more about the MUF, what we will be doing, like these 3 steps we will be doing, that normovolemic, transfusion, hypovolemic. The normovolemic, mostly we will keep the flow rate of almost same and make sure that heart is not distending, and also the reservoir volume is being chased. So in this type, we will be like, after off bypass, the SVC will stay inside, and through the IVC, the line will be siphoned, and the siphoned volume will be keep on chased through the arterial outlet till the MUF pumps. So in the normovolemic phase, the rate will be almost similar or down to that, and it will not be more than the arterial line. Like if pressure drops, we'll go up with the arterial flow. So hypovolemic phase, the moment we are sure that all the volume from the reservoir is chased to the Y line of the MUF, we'll stop, and then we will continue our MUF till, like you suppose the CVP was 12, we will aim for 8 CVP, and the pressures of 90s, we will aim for 860s. And we will be aware that pressures will be dropping and they will be in the calm situation, and we won't react. So we will make sure the patient is stable and that ejection does not fall. So once that is over, the transfusion phase, which is the thing which we are started for all the cases, the arterial line will be filtered, like arterial line will be clamped and the pump will be put on recirculation. This time this all blood will be chased off and it will be circulating the primes fluid, and then again we started chasing this line So the blood will be chased and the hemofilter will be chased and the all blood will be given. The once this all blood will be given, then this line, the muff will be stopped, then recycle will be clamped and the artery line blood also will be chased. So in this way, we are able to achieve the every blood to back to the circuit. And everybody may be doing the same thing, but in this time all lines will be inside and we can go back and bypass at any time without any time delay. So this is what we are able to achieve. Like during bypass, this will be like this. Post muff, we can see everything is chased. So these techniques helps us like more than 12 kg of more than 12 gram, we never had blood. We are going with only albumin and plasmolite prime. Of any cases, any complex cases also. So these are the things which we are achieving very easily, like we are chasing everything. So you can see how this chased, everything chased. So I did a small study how to tell that group B is good to my surgeons. So where these are the things which I have utilized. We used the only Sorin, we stopped the other cardiac delivery device for effective chasing. This 1/8 delivery line for less than 12 kg, 3/16 delivery for more than 3, then hemofilter for less than 10 and the BL for more than 10. So in group A, we all end up with adding second blood in the bypass itself because of more chasing and all thing and the efficient second dose of cardioplegia. And group A received more blood in the ICUs than the group B. And this is the thing, this group, one case of ECMO need in group A made us to change the circuit and we felt something wrong with our mouth. So we need to do some immediate actions. So that led to the group B. So when comparing the group A and group B, this is the thing, like only one manpower is enough for doing all these things as like it's not so tedious like the group A. And also group A, we were able to filter, like we will maintain the hematocrit all the time, even in case of cardioplegia delivery. We used to give nowadays 30 ml per kg also. We will make sure the hematocrit won't drop. So this is one more usages. We started using that ILBM sensors in the muff line to make sure how much HP we want and we will stop muff when the desired HB is achieved. Usually when the surgeons tell, I want 16 gram, we keep 2 more gram extra so that the 1 gram may be for hemostasis and 1 gram for the ICUs. So this is one of the case of BD gland with atrial septectomy. There was still enough blood to chase, but surgeon was like, I'm happy with 16. So we stopped at 18 grams. So my message is clear. This group B is very safe, easy to adapt, and you don't need to depend on anybody to be with us. It's picking up from the old one and hooking up into the new place. It's very ASL free. We can go easily. And most of the cases we did with only blood prime, which of HB of 10 grams, 9 grams like that. And we can make sure that adequate dose of cardioplegia and effective dose of cardioplegia is given. And we are happy with this, and the lactate clearance also very good because we are not adding more blood than the one which is in the prime. And also we will do enough good pre-bypass ultrafiltration to make sure that matches with the baseline of the child. So we found this is good and the childs are doing well and the reduced usage of blood and blood products. So I want to finish my thing, like the best profession to me is to be allowed to perform the necessary repair, however long leaving the patients, they have never been on bypass. So that's what we have achieved with the group B, and we were happy with it, and we are going for it. Thank you.
Thank you, Karthi. It was a nice presentation.
Now we are coming to conclude this session, and now I would like to invite Mr. Anil Mohore from Mahatma Gandhi Medical College, Jaipur, and he'll be talking about a novel cardiopulmonary bypass assisted myocardial perfusion technique for L-Kappa repair.
Good afternoon, dear seniors and dear my friends. Today I am telling about our experience in different cardiopulmonary technique in L-Kappa repairs. Let us start. Introduction. What is the L-Kappa? L-Kappa is the rare congenital anomaly where the left coronary artery arising from the main pulmonary artery, left coronary artery arising from the main pulmonary artery instead of aorta. So how to symptomatic the child? After the birth, falling on PA pressures, reducing the coronary perfusion pressures, then myocardial ischemia and progressive LV dysfunction. They are presented only on around 2 or 3 months of age. This is the diagram of normal heart and another heart showing the Al-Kappa disease, where the left coronary artery arising from the main pulmonary route. What happened during early CPV? If we are going on CPV, so systemic perfusion is stabilized as the heart is emptying and PAP rapidly falls and LMCA perfusion further compromised and ST elevation and risk of ventricular fibrillation can occur and further LV ischemia. Methods. Single center retrospective study around 2012 to 2025, 12 cases with echocardiographic diagnosis of Al-Kappa underwent surgical repair using 2 different coronary perfusion techniques. 5 out of 12 repair with standard coronary perfusion technique, like we are giving cardiopia in aortic route first, then opening the MPA and then giving the direct ostral cardiopia to LMCA. And another 7% out of 12 repair using modified dual coronary perfusion technique. This is the diagram of dual coronary perfusion technique, where you see we are placing one more cannula in MPA to giving continuous normothermic oxygenated blood to LMCA perfusion, and this is the regular cardiopia cannula placing on ascending route. So my goal is that if we are giving, we are going on bypass and heart is emptying, that time RV is empty and PA pressure also drop. So why we can be giving good normothermic blood to both coronaries simultaneously. Additional cannula placed in MPA to enable direct LMCA perfusion. After initiation of CPV, both PA branch are snagged and allowing continuous delivery of normothermic oxygenated blood to the coronary, to left coronary system at adequate perfusion pressure via Y connectors. Result. Baseline characteristic, mean age of diagnosis is 3 months, youngest is 1.5 months and oldest is 3 year boy. Mean weight is at diagnosis is 4 kg, youngest is 2.9 and oldest is 10 kg. Mean ejection fraction pre-surgery is around average 15%, lowest is 8% and highest is 30%. Variables during in both coronary perfusion techniques. Average CPV time for standard coronary perfusion technique is 150 minutes and dual coronary perfusion is 220 minutes. Average clamp time for standard coronary perfusion technique is 120 minutes and dual coronary perfusion technique is 95 minutes. ECMO requirement in standard coronary perfusion is 3 out of 5 with around 3 days. And dual coronary perfusion technique is no need of any ECMO. Cardiopulmonary delivery, as I tell you before, initially we are giving in aortic route, after clamping and after that opening the MPR, giving to direct left coronary artery. And in dual coronary perfusion technique, we are giving in same time simultaneously to both coronaries. Average immediate post-op EF around 20% in standard coronary perfusion technique and dual coronary perfusion around 25%. Pre-discharge echo is 40% in standard coronary perfusion technique and dual coronary perfusion technique is around 45%. This is the diagram showing the snagger to both RPA and LPA before going on bypass. We prepare with everything before going on bypass. And another second video showing the MPA cannulation. And this is the aorta, this is the MPA to performing our goal. And this is the, And this is the another third video showing both great vessels cannulated with isolated cardiopia cannula. All the purpose we completed before going on bypass. This is the post-op day 1 echocardiography. EF is around 28%. And this is the pre-discharge echo. And you see the EF around 40%. Comparatively study of my 12 cases. Standard coronary perfusion technique, we operated with 5 cases. In this technique, 3 came on ECMO and 2 came on non-ECMO. 3 came on ECMO, they are severe LV dysfunction and severe MR situation. And another 2 cases, we are easily wean off in theatre. They are pre-op echo is around 20 to 25%. And this is the another 7 cases, we operated with dual coronary perfusion technique. When you see, we have no ECMO requirement in all cases and all discharged with good EF. So my concern is only that if Al-Kappa with severe LV dysfunction is extremely vulnerable during early CPV initiation, rapid fall in PA pressure, and during standard CPV can precipitate critical LMCA ischemia before cardiopia. Standard perfusion technique in our cohort result in 60% echo requirement and high mortality rate. Continuous LMCA perfusion using the modified dual coronary perfusion technique eliminate the ECMO requirement needs and improve LV recovery. Proactive myocardial protection during early CPV may be the key determination of survival of sick Al-Kappa infants. They are our follow-up patient. Few patient is operated in 15, one patient in 2018, other is 21, and last one, 6th child is last year, December 25, operated in December 25. Thank you.
Thank you, Anil, for a wonderful presentation.
Thank you, sir. Thank you, my mentor, Bali, sir.
I really feel delighted, actually. It's a very good technique, and I think we should also follow. And I would like to call all the speakers on the dais for the question and answer session. So you also remain seated.
Okay. Thank you, sir.
With the permission of the chair, I'd like to please inform 2 things. One is we have 2 more presentations yet to complete the session on pediatric perfusion challenges, innovations and clinical success. Up next, we have Adhav Ilango, who's going to talk about, Senthil Kumaran, my apologies, Senthil Kumaran, Dhanakoti on successful robotic DVR, followed by Adhav Ilango, who will talk on hemoabsorption cardiac surgery, and then recent advances in perfusion systems by Kevin Menezes.
I'm sorry, actually.
No worries, sir. I know this.
Different color, sorry.
Before the speech, I'd like to remind people in the audience, please maintain silence while in the hall, and we'd like to concentrate on the presentations happening. So if you have any discussions to do or calls to make, please do that outside the hall. And please make sure that your mobiles and devices are silent while you're here. Thank you. Over to the chair. Thank you, sir.
Good afternoon, everyone. Thank you so much, the chairperson, and thank you for giving me great opportunity, Medtronic India, as well as ISAC 2026. I'm here to discuss, this is a case which we are doing recently, the robotic DVR, and I would like to talk about it, which is a very milestone achievement in India, especially our Bangalore, Karnataka region, and this valve which is used, basically this Medtronic talk, and Medtronic has given a big valve, which is very nice valve, which is used for this DVR, a fantastic valve. The advanced robotic technology enabled complex DVR for 53-year-old female, which I'm not a Medtronic guy, but I am a perfectionist working in Apollo Hospital. Many of us know. Thank you. And the promise of robotic surgery. What is the promises of robotic surgery? Now, 2019, when I spoke about the robotic surgery 2019 in Ahmedabad, and they were all, not much attention. Today, the whole conference about the AI and robotic, fantastic. I'm very happy, proud to be this conference. The robotic cardiac surgery represents the convergence of cardiac surgery and surgical expertise and precise technology. Where the precise technology is perfusion technology, where we cooperate, we convergent with the eye technology of robotic and as well as the perfusion technology. The advanced approach enables a complex procedure through minimal access while maintaining the gold standard and surgical result. The results are almost better than the conversion cardiac surgery. We have a successful performed DVR using a latest generation, which is latest generation robot, which is XI platform, and demonstrating the feasibility and safe of cutting edge technology. Why the robotic? You all know, many of us know, many of us working with the robot, this exceptional 3D vision, which is very good. You would have seen, some of them would have felt, seen it in the console, enhanced surgical comfort. Surgeon is fantastic, like sitting in the heart and operating. The latest, the least chest wall trauma, and 8 mm port, which is just 4 ports is enough to do a surgery. The closed chest operation, actually this is a advanced minimal invasive surgery, allows entire team. It's not only the surgeon is operating. No, the whole team is operating and whole team is involved. This is the beauty of the robotic surgery. And the minimal access, the advantage, what you say, just now I told, minimal access, the faster recovery, superior visualization, and prone result. There's a prone result which I'm going to tell. The robotic selection, what patient we have selected is a 53-year-old woman and the teacher. How do you do as a professional, whether as a teacher, whether, but we find it while doing surgery, there was a 120 student just out of the OT, the complex. We were worried why the students have come. The teacher, she was a maths teacher and 11th grade and 12th grade, and she wanted to go back to the work. And she was delaying the surgery for a long time. And today, we have got a big technology and big everything, so that she accepted to go for a surgery. And the students were all waiting for her to come back fast. So that is, his sentiment with this thing. And the risk profile is, patient has had, teacher, that varicose vein, these things were there. Comfortable sensor. And pathology, severe aortic stenosis with severe MR. This is a patient. And technical suitable, whether this patient is technically suitable for the minimally invasive is very important. Whether you can't do it with a 20 kilo, right now 20 kilo patient we will not, because it is, that you need a room to operate. Instrument has to go and fiddle around inside the chest. So need to be at least suitable weight for the robotic surgery right now. Don't know. Future, pediatric also is possible. And the patient profile and preoperative assessment. We need to do before any surgery, as usual for that cardiac surgery. Vital status, what is the patient weight? 65 kg and body surface 1.85 meter square. The body mass index is very, very important for as per the robotic surgery. The patient should have, healthy, and of course the heart disease patient will not be healthy, but heart disease, you should have a little mass with that, so that robot can go and dock properly and operate. That is also important. The cardiac function, the severe, as I said, the aortic stenosis, where is the beautiful things which we have chosen. It is aortic stenosis, where we need not bother about the ostial cardioplegia. We can give only in the root cardioplegia itself enough. And the LV was also good overall. And additional finding, the mild lung issues are there. Mitral MR is there, so little bit lung issue are there. That was a preoperatively taken care. And hemoglobin, of course, the hemoglobin is very, very important. As per that, a lot of people are doing a minimal invasive. The robotic surgery, the hemoglobin plays a very big role, which I was discussing also, the DO2 and all. That time I want to say something this one, but that I did not get opportunity. Now I'm telling the hemoglobin is very important. The normal coagulation profile is also very important. And stable renal function, no problem. And all laboratory reports are all right. So we went to do a surgery. What cannula? The 19 French Biomedicus next generation cannula, and single venous cannula, which is Biomedicus with 25 French venous cannula, which is placed into the crossing the IVC, RA, SVC, placed into there. And drainage vacuum ADMA suction is one of the beautiful suction, which we can, reliable suction, we will use it and we get a good result in that. And the flow management is nothing, which is, and robotic and conversion, in a cardiac, conventional cardiac surgery is different. Robotic surgery and minimal invasive surgeries are different. You cannot expect both same thing. You can't flow and thinking that I want to do with the 2.4 cardiac index. No, it is not possible. It never get into the situation to operate surgeon properly. And this is a cardiopulmonary bypass management. The priming is as usual, which is, what I use, the different is the coated circuit, which is BL manufacture is good, and that coated circuit I'm using in. Flow parameter, which I said already, 1.5 to 1.8 millimeter of, liter per meter square for the cardiac index, which I use it. And 32, below 32, I don't go for the minimal invasive cardiac surgery. I don't never go below 30, moderate cooling. And myocardial protection, which is Del Nido, now moderate, somebody was telling a moderate cardioplegia technique in the first topic, which we go only regular cardioplegia, the regular cold Del Nido cardioplegia, which gives us 60 to 90 minutes of time. Most of the time we finish the surgery in that, whichever the surgery. The early filtration, the filtration is very, very important. There the place, the Essence machine is very playing big role. We know what is the condition, where is the, which I'm going to talk about in the afternoon, some topic, which I'll talk in that also. And this is a perfusion performance and outcome, 2, 6, 7 minutes of duration cardiopulmonary bypass. And if you see that cross clamp time is 139 minutes, so that is almost in 1.5 hours. And we have filtered so much. And 1.9, the lactate is very important. It's not during surgery, the post-operative. Post-operative, so most of the people who are thinking during cardiopulmonary bypass, my lactate was good. Post-operative is going up because you are low flow in the cardiopulmonary bypass. This was a question many people have asked me, but in this you see that 1.9, even post-operative 1.9, even you see what my calculation is, the lactate is 2, pre-operatively 2, plus or minus 2 is acceptable, which I wanted to maintain. It has been maintained. Some case, 1 or 2 cases, of course it has gone up, but it's not that. But I did a study with 100 robotic case, which I'm going to discuss in the afternoon. I will explain you much better way. Hemodynamic performance, which I said, and the DO2, which is more than 280, always I maintain. There is no question. The metabolic acidosis, no metabolic acidosis, stable hemodynamic throughout the case of DVR. And early recovery, you see the extubated 12 hours. Before 12 hours, we extubate, especially all the robotic, we do it. Even though we have taken a DVR big case, still we have accepted, we have taken it and extubated with no problem. ICU stay was 2 days and hospital discharge of post of 3 days. Follow-up excellent, within week patient came. I also taken. But only thing we did not take, because she said very adamant, I don't want to expose anywhere and I don't want to show my face anywhere. She, as a teacher, she was so much, so that's why we could not show her picture. And this robotic DVR represents the future of complex cardiac surgery procedure, provided See, not only the cardiac surgeon and the perfusion, you should keep involving ourselves. Today, if you say, for a lighter note, I want to tell you, the Rajinikanth today and 50 years back is the same. As a fan of Rajinikanth, the 50 years back was actor, today also actor. Today also superstar. So same thing. We need to keep, the age is not a matter, keep advancing yourself, addressing yourself and learning yourself, and you have to keep updating. You keep it with your level of surgeon. It's not possible, definitely you need to do it. Otherwise you will be dead out. You should be out of the field. So unless until you are in the field, you keep learning, making yourself important person. Our center has established expertise with the robotic cardiac surgery with excellent clinical outcome of the patient satisfaction. The minimally access approach enables the recovery, reduce the pain, and quicker return and work. Especially this madam really went back to the home without any problem. And see this. Precision in robotic, perfection in perfusion. This is a good line for us. We have always maintained it. See, here the surgery happens, only 1%, proud to say the perfusion. Though we are not in their field, but we are making field very clean and make surgeon to comfortable operation. That is very important. As a perfusionist, we need to, at the same time, patient stable and safety never compromised. That is very important for us. See, this valve which we use, mitris, for the mitral valve. For the aortic, we used the Medtronic Avalus Ultra. And the perfusionist, they're also there. And just I wanted to see that what perfusion is doing the other side and whatever the surgery has taken place. We had a press meeting for this because though this DVR was, somebody was telling, DVR was conducted already long back, but the successful DVR and the robotic, in the advanced robotic technology with advanced perfusion technology, we could do it successfully and achieved. So there we had a press meeting and we had made a lot of Indian newspapers advertisement happen. And thank you so much. This is the way we did it, a DVR, successful DVR, and it is a milestone for Indian cardiac surgery as well as in the perfusion technology. Thank you so much for the opportunity. Questions?
Thank you, Sendil. We invite our next speaker, Mr. Ada Vilango, Jaffran Biomedical. Hemoadsorption in cardiac surgery, the topic.
With the permission of the chair once again, a quick reminder to all our presenters and speakers, if you have any special requests, as in your own laptop or a pen drive, please approach the technical desk before your presentation so we can quickly adapt to that and save time. Thank you.
Good afternoon, everyone. First of all, I thank the committee for giving us this opportunity to talk about hemoadsorption in cardiac surgery. To start with, it's very, like last presenter, Mr. Sendil Kumar said, updating yourself is very important. You need to be like Rajinikanth to be successful in the field. So hemoadsorption is a newer therapy that is being established. So incorporating that in cardiac surgery will give out good outcomes. That is all about I'm going to talk about today. So I am Ada Vilango, Clinical Marketing Manager at Jaffran. So I'm not here just to market my product. I'm also here to talk about clinical evidences about the product. So CBP is essential. Like you know, CBP is essential, but it's also biologically aggressive. The moment blood contacts artificial tubings, it activates it activates complicated pathway, adds ischemia, reperfusion injury, and a cytokine surge like IL-6, TNF alpha, IL-1 beta. And in selected patients, this inflammatory surge translates into vasopegia, capillary leak, organ dysfunction. And this is not just theoretical, we see this quite often in OT and ICUs. So now let's look into what it means clinically. Refractory vasodilatic shock, escalating VIS score, rising creatinine, coagulopathy, prolonged ECMO support. At this point, we are no longer treating inflammation, we are managing the consequences that inflammation made. So the real question is, can this be intervened earlier, and can this be stopped? Like it always says, like the golden rule is, prevention is better than cure. We need to prevent it before it happens so that it is always the best go. So the solution for this is the hemoadsorption. This is where hemoadsorption comes into picture. So it is an extracorporeal blood purification strategy. Instead of treating the patient post inflammatory mediator response, you control the inflammation at the right place in the right time. So during the inflammation starts, you control it. So when the cytokine burden is higher in the blood, so you introduce hemoadsorptive cartridges to reduce the cytokine storm. So the image you see there is the product that magically removes the cytokines. We'll see more about it in the next slide. So why HA380 hemoadsorption? So HA380 hemoadsorption uses something called neutral macroporous resins. So these resins are made of double cross-linked. It's a technology called double cross-link. So this double cross-link gives you a solid rigidity so that it doesn't disintegrate during the therapy. And it also targets molecules that ranges between 10 to 60 kilodaltons. So any inflammatory mediator, any toxins that is between 10 to 60 kilodaltons are being absorbed here. Not just that, it also absorbs anything that is lipid soluble and protein bounded as well. So when I say 10 to 60 kilodaltons, the absorption targets are being IL-6, TNF alpha, CRP, protein bounded toxins, and lipophilic drugs including antiplatelet agents. And it has a high surface area. It provides somewhere around 54 meters square. It provides above 54 meters square of surface area, which is globally one of the highest surface area in adsorptive cartridges. Okay, so what happens? So so from now on, I'll just talk about the evidences. All this is backed by studies. So cytokines clearance evidence. So here we see in cardiogenic shock patients supported on ECMO, IL-6 reduction up to 94% at 72 hours has been reported. TNF alpha reduced by approximately 70%. CRP levels were significantly lower, and lactate improved within hours. This shows biological efficiency of hemoadsorption in cardiac surgery. So this is probably post-operative. This study talks about ECMO. So during the prolonged ECMO, also you see this cytokine storm, cytokine surges. So even there, the hemoadsorption comes into picture. So again, we come back to the operating room. HA380 can be integrated directly into CBP circuit without compromising the flow. Preliminary studies suggest that trend towards lower inflammatory markers and improved earlier renal parameters. This suggests we may intervene intraoperative, not just in ICU. And this is where it gets interesting. Compared with conventional ECMO, shorter ECMO, when you're introducing hemoadsorption with it, it has a shorter ECMO duration, higher weaning of success, lower SOFA score, reduced VIS requirements. That means fewer vasopressors, improved organ function. Importantly, no increasing bleeding risks and major complications was reported during this hemoadsorption incorporation in ECMO or CVP. So VA-ECMO itself amplifies inflammation. So post-cardiac shock, post cardiac shock, we often enter inflammation, vasophagia, more support, more inflammation. This is what happens in a cycle. So earlier hemoabsorption in this setting may be associated with reduced vasopressor requirement, improved metabolic profile, better ECMO weaning success. This is where a selective application may make bigger difference. So let's now shift into something more practical. Ticagrelor, that is potent P2 Y12 inhibitor. So no reversal agent on it. So when a patient has consumed the ticagrelor tablets a day before and he needs an urgent CABG, so at that moment we can't delay the surgery. So or we can't accept the high bleeding on the OT table. So what we do is even if infusing platelets, the medicine will work, the ticagrelor drug will work on the infused platelets as well. So that is where the problem arises. So the solution for it is again hemoabsorption. Ticagrelor is a lipophilic and protein-bounded toxin. It falls under HA380's absorption range. Intraoperative hemoabsorption during CAB can reduce circulating ticagrelor level. This may improve in platelet function and potentially reduce preoperative bleeding. This offers a potential solution to can't wait and can't stop dilemma. And it is also safe and feasible in cardiac surgery. Whenever we add adjunctive therapies, safety is very critical. Across studies, it says that adding hemoabsorption in these extracorporeal circuits has no signal of increased mortality, but no excessive bleeding, no increase in AKI, no compromises in extracorporeal flow. It integrated seamlessly with CBP, ECMO, and CRRT. And this is the circuit diagram I wanted to show you. So the first one you see, is hemoabsorption with CAB, where it is connected, where the inflow is post oxygenator, and the outlet is again a pre-blood pump. And this one is for the CRRT. It is just connected pre the dialyzer filter in CRRT. And the third one is in the ECMO, where it is connected post pump, and then the return is connected the pre-pump. And again, ECMO, where it is connected post-oxygenator. The inflow is post-oxygenator to the circuit, and then the outlet is pre-pump. And this is a small video of it showing the connections to the hemoabsorption on an ECMO circuit. So always it flows from the bottom to top. So the inlet is to the bottom of the cartridge, and then the outlet is above the cartridge. The blood flows anti-gravity, in anti-gravity. So to conclude, cardiac surgeries are challenging, not only in myocardium, but also in inflammatory surges. Hemoabsorption with HA380 offers inflammation modulation, hemodynamic stabilization, potential drug removal, including ticagrelor. It does not replace standard therapy. It complements it and carefully reduces the risk of patient. And you can connect us through the WhatsApp, and we have a stall here. The stall number is 10. You can also visit us. We can have more discussion on this product. And thank you for giving this opportunity.
Thank you, Mr. Adav. Next, we have Mr. Kevin from Spectrum Medical for presenting the topic on recent advances in perfusion systems.
No. Aane rahe. Hi, good afternoon, one and all. And on behalf of Spectrum Medical, I would like to thank the organizers and the chairpersons for giving me a chance to talk on the recent advances in perfusion systems. So, very briefly, I will like to run you through something new with respect to perfusion systems. Yeah. So, as we all know today, there's a lot of challenges in the types of cases that we undertake, right? So there's a lot of complexity with respect to redos, failed towers, etc. So we perfusionists are having a lot of challenges with this. Now, what is happening is cardiac surgery has become very safe, but our focus should be not on getting the patient alive. The focus should be on delivering better outcomes. Right, so we should focus more on reducing morbidity, and that is where our role comes in. So to do this, we need to have better equipment, better infrastructure in our setup. So the future of perfusion is definitely bright. We've already shifted from analog to digital nowadays, right? So everything is digital. Digital does not only mean electronic perfusion records. Digital means using the data that is generated during our case so that we can predict and adapt our perfusion techniques to deliver better patient outcomes, right? So quantum perfusion systems helps the perfusionist to envision the future or the immediate future of our procedure so that it relates to better patient outcomes. So we use predictive analysis and identify patterns in the data that we collect and use this to transform us into be a dynamic perfusionist so that we can deliver better patient outcomes. So we bring to you the next generation of perfusion systems. We are smarter machines with better outcomes, stronger outcomes. It's more intuitive, very safe with respect to level bubble pressure. We have very good complexity, flexibility, and it's easy to maintain. I'll just run you through this small video so you can understand our system very well. Sorry. So you'll see this machine, how very compact it is, how flexible it is with respect to doing perfusion. So this is a battery backup, which is a lithium-ion battery backup, the only machine in the world to have this, which gives you 4 hours backup. No maintenance, your biomedical engineer doesn't have to come and, charge, discharge every time. And we have 2 different types of frames, basically. Very flexible, where you can go very close to the operating table, reduce your, tubing lengths, reduce your priming volumes. Therefore, your post-op inflammatory response is also reduced. Very easy to add or remove a pump the way you want. No need of big cables running around and identifying which pump is what. These are very short cables because the entire engineering is through the framework of this machine. All electrical connections are routed within this framework. So you see there is no loose cables around, no nothing. It's very simple. We have one universal pump insert, which we call as bobbins. Any type of tube can go into it. You want 2 tubes can also go into it. Very easy to, choose. This is the occlusion. Very easy to set the occlusion. And very tough pump covers. You don't have to worry about breakages. And that's the beauty of it. Yeah. So universal pump inserts help you quickly go on pump in, choosing pediatric adult cases, etc. So we have a workstation which is one single screen, no need to look here and there. All the data, everything is in that one screen. So the entire focus, your attention is on one. We have this machine displayed at the surgeon's meeting, so I would be happy to show you around there. Yeah. So with respect to the selection of the tubing, one screen will pop up where it gives you multiple options of choosing what is your arterial pump head and what is the diameter of the tubing that you're using. And that automatically will calculate or calibrate the flow that the pump will be displaying to you. So it's very safe and easy to use. We have one large screen, like I said. You can control the pump digitally, and also you have this pump controller where you can mount it close to your pump, and you can control it digitally from here and from the screen. You have 24 parameters gauge bar right on top over here, where you can clearly display and see everything what is going on for you during the case. You have all safety parameters with respect to level, bubble, pressure displayed over here, and very easy to initiate, or you don't want to run anything, you can just disable it. You want it, you can enable it. So during the case also, you can very easily enable and disable all the safety features. This is how you can use the controller very close to you, or you can use it in another way where it is like this. So you can keep it over here and use it very comfortably. Yeah? So this gives you full visibility of the entire procedure, very clear, nice. If you're doing pediatric also, you see we have a system where you can have all the pumps mounted on top to reduce the tubing lengths, etc. An arterial pump very close to the oxygenator to reduce the tubings. This is with respect to the hand cranks. So very easily it fits on top and you can hand crank in the event of any emergency. We have venous occluders where you can put the tubing, the venous or the arterial line through this. And these occluders are basically flow-based. They are not occlusion-based, they are flow-based. So it will sense the flow going through this occluder, it will display the flow, and you can gradually wean the patient according to the flow from the venous line. We are the only machine which has continuous online monitoring without the need for any disposables. With the help of these sensors, you can connect it through your arterial and venous line, and continuously you will get the display of all vital blood parameters through that without any additional cost to the patient. So here you see we have level sensors again, which you do not need to use disposables. We just stick it on this with the help of a double tape. We have two sensors, basically one yellow, which is called as the safe flow. So as soon as the level hits the yellow one, the pump will automatically slow down. It will sense the blood coming in from the venous line, how much is the return on that, and based on that, it will slow down. If the level further drops to the red, the pump will stop. So we call this as the safe flow and this as the protected flow. We have sensors here also, which are 2-in-1. They are bubble detectors as well as flow sensors. So you can connect one sensor just out of the reservoir. So in the event of any air, it will detect and it will stop. This is the venous occluder you see here, where your venous line comes into it, and it will sense the venous flow going through this. It will display the venous flow on the screen, so you know exactly what is the amount of venous return you're getting. These are the sensors you see here for arterial saturation, venous saturation, and hemoglobin. This again is another sensor you can fit on the arterial line, which has inbuilt bubble detection as well as a flow display sensor. We have something called as a ventilation module. This again is first time in the world where it is not a gas blender only. It's an electronic gas blender which will give you everything in it. It will give you waste anesthesia gas scavenging system. It has an inbuilt vacuum assist controller for vacuum assist bypass. It will measure flows, pressures, temperature. It will also give you continuous display of PO2, PCO2. It will give you non-invasive measurement, of course, of PO2, PCO2. Then it will give you oxygen delivery, oxygen consumption. It will also give you MAC value. What is MAC value? We all use isoflurane during bypass, right? We don't know how much isoflurane we are giving and whether your patient is truly anesthetized on pump or no. We need to maintain a MAC value of less than 0.8 to ensure that your patient is nicely sedated during bypass. So this gives you a clear indication. So it's very good for fast-tracking anesthesia, etc. So you don't unnecessarily keep sedating your patient and, have more longer ventilator time. So with this, you can very comfortably control the isoflurane on pump. You can see here it's all electronic gas blending. You can go up to 0.25 sweep rate. So when you're doing a small baby, 2-3 kgs, there is no other gas blender which will give you a sweep rate of 25 cc's per minute. With this, you can get that, flow control for sweep. Right? You have inbuilt vacuum assist, continuous PO2, PCO2 display. You have a waste anesthesia gas scavenging system. And one more thing we have also beautiful is the oxygenator inlet pressure. So if you're having long time of bypass and there is a pressure being built up in your oxygenator, if your coagulation is not good, you will find that this oxy-in pressure keeps on increasing. So if this goes more than 150, it gives you an early warning sign that there is something going on in your oxygenator. Either you have to take preventive measures to check the anticoagulation, or whether sometimes your gas line is getting pinched somewhere, which is giving a high pressure. So this gives you an early indication of pressure within your oxygenator, oxygenating compartment rather. So here you see the screen. We have one large screen, 15 inches, which gives you everything. It's nicely color-coded. Even our pumps are color-coded. And you can easily identify which pump is what. This is the ventilation module again, which gives you entire display of your gas management. We have a Nomo line that we connect to the vent of the oxygenator. This gives you PO2, PCO2 measurement, your isoflurane measurement, etc. So this will help you. These are also reusable, so not much cost involvement. Like I said, MAC value, very important for anesthesia, isoflurane during bypass. We have a sensor on that. When isoflurane is on, you will get a blue indicator. When isoflurane is off, you'll get a green indicator. Our systems are very accurate and almost close to our blood gas levels. If you see here, when you compare the blood gas with what is being displayed, it's almost same. You see a PCO2 of 41, you see a PCO2 of 39. Very, very close. PO2 349, PO2 332. So very, very close to our normal blood gas analysis, which is very good for us to analyze and take preventive measures during bypass. So we also have auto initiation mode. This ventilation system that I showed you has a auto initiation mode where you can automatically initiate bypass in a very gradual way, where you don't have to, create hemodynamic instability. We have automatic PO2, PCO2 regulation. You can prefix PO2 value and PCO2 value, and this machine will automatically deliver you the set PO2 and PCO2. This is very good when you're doing long hypothermia cases. So this again is something which you can see how we do the auto regulation of PO2, PCO2, auto initiation of bypass. We also have something very nice here. You see a digital line pressure. You can monitor as soon as you do the aortic cannulation, you can see the line pressure very nicely here. So we have the auto weaning mode also. When you're about to go off bypass, you can very comfortably wean the patient off very gradually. Especially useful when you're doing very poor LV patients, complex congenital, etc. long. So you can gradually wean the patient off bypass with this auto weaning mode. We have very good centrifugal pump which is fully levitated, hydrodynamic based. In view of time, I'll just rush you through and I'll show you our centrifugal pump. We have inbuilt sensors to give you pressure and temperature. No need of connecting any transducer. Directly you connect the cable and you will get this readings. we have something which has a centrifugal pump and a heat exchanger involved in it. So you don't need to, add another heat exchanger when you're doing ECMO. Analysis, when you compare it with Centrimag, were equally good with respect to hemolysis or blood damage. This is how you connect the system. If you are using centrifugal pump, again, you can use our centrifugal pump very close to this. We have continuous data monitoring throughout the case. So from the time you start bypass till the time you end bypass, everything is recorded in the system, in the back screen. You don't need to do anything. Just enter the height, weight of the patient, that's all. And everything is recorded automatically. At the end of the case, you can analyze, remove printouts, etc. You can analyze the time. Now, since a lot of focus is on DO2, you can analyze how much time your pump run was less than 280 DO2. You can analyze this, and then this is all can be used for prediction whether your patient will have acute kidney injury in the post-op. So this is again tells you about electronic data monitoring. This is the type of perfusion data sheet you can generate. And this is, we have some of the top centers in the world which are currently using our machine: Texas Heart, Cleveland Clinic, Mayo Clinic, all the top centers in the world which are using our system. Thank you. Thank you. Yeah.
Thank you, Mr. Kevin. New generation pump. Let's think about it. Okay, now I think we will start the question answer session. So the audience can ask the question, and I think the respective speaker can answer it, isn't it? Because there are about 7 speakers or 8 speakers. How can it be?
Yeah,
Is
thank
that
you,
okay?
ma'am. I'd like to call the speakers on stage, so it'll be quicker. If you're here in the hall, please quickly step up on stage. Mr. Debashish Rai, Vaishali Mete, Ramakrishna Maravoina, Sujit Gopichand Vamne, Karthik Murugan, Anil Mahaure, Senthil Kumaran, Adav Ilango, and Kevin Menezes. If there are any questions, so it's easy if you're on stage to answer, you can step to the podium. And whoever has a question may please come up. We have barely 10 minutes for question and answer, so I leave it to the discretion of our chairs. So the mic is right there in the center. You can step forward to the mic and direct your question to our panel of speakers.
I have a question for Vishali. That 10 ml cerebral flow, is it enough? I think.
Hello.
10 ml of per kg flow for the integral cerebral perfusion for pediatrics. I think you should flow more.
Yeah, it is basically it is 20% of the total flow.
No, but they like if you see the protocols, so you should flow little bit more. So they say you can go up to 50 ml even for this SSCP, selective SSCP for the
Many journal
children.
it is written is 20% of the total flow. So basically it was
that is for the adults, but for the pediatrics, there are the guidelines which say that you should you can go up to 50 ml. Even 40 ml is good enough flow per kg for SSCP.
As we evaluate 20%, so it was 10 ml, 10 to 15 ml, it was basically 20% of the total flow. So can we go? For the adult, if we calculate 20% of the total flows or near about total flow, it comes near about 40 to 50.
Just think about it. Actually.
Okay, sir. Okay, fine. Thank you.
Sir, can you please in between?
Audience, any questions?
We have a request to call Mr. Rakesh Sakya from Manipal, Delhi to the dais.
My question to Mr. Karthi. How long do you do MUF for these cases? Do you have any calculations to achieve a hematocrit of HB of more than 10? I think you require a longer time.
We maintain more than 8 all the time, so we at least will not more than 15 minutes. 15 minutes. Yes.
You achieve the hematocrit within that 15 minutes?
Yes.
What hemofilter do you use?
That 0 to 0.2 Sorin for less than 10 kg, more than that pediatric from BA Life Sciences.
Okay. So on a group B, you drained completely the blood from the venous
Yeah, first itself we will drain from the IVC.
Okay.
That will be drained to the reservoir, and during the normal volemic itself, reservoir will be chased to the Y of the bifurcation line to the cardioplegia pump, like mouth pump.
Okay. Okay.
Yes.
Thank you.
Yeah.
Thank you.
My question to Karthi, in line with him. Yeah, it's a very good presentation, and I appreciate that surgeons, they cooperate by waiting for such a long post CPV procedure. So my question is, while doing the procedure, do you observe any temperature drop, and how do you manage it?
For straightforward, like VSD, AST, we don't cool. We stick with 35.
Yeah.
Unless the case is like Fontaine, Rastellis, we cool to 32 until they shout us too much of returns. Unless they shout and us, I won't cool. I'll stay at 35.
Temperature management in, I'm asking in MUF procedure, like post. Yeah.
Yeah.
How do you manage the drop in temperature?
Post clamp release, barrier also will be on, like 43. And my temperature won't go more than 38.
Since you are using a cardioplegia delivery system with a heat exchanger.
No, with heat exchanger. And also, we will room temperature will back to 24. It will be 20 and it will back to 24 while closure.
Yeah, because especially you chase almost all the
We
volume.
will change the temperatures.
Right. Thank you.
Thank you.
My question to Sujit, a very good presentation on NIRS. My question is like considering the pros and cons. So in case of skin pigmentation or any bilirubin level fluctuations, does it give the correct value, or there are the variations?
Pardon, please, can you?
Yeah, when we consider pros and cons of NIRS, do you observe any changes in the values in case of any skin pigmentation or levels of bilirubin?
No, madam.
Okay.
No, there is no, even I didn't find any study on that. So yeah, so next time maybe I will go through that. But on many papers, there is no such a study described. Yeah, on my personal experience, if patient hemoglobin is on higher side, that is hematocrit near 60, on that time we don't get NS value as going on bypass because of higher hemoglobin. That is our observation. But what you are is asking.
Just study based, like I have not experienced, but I just wanted to know whether.
We didn't find any detail on
Thank you.
related to that. And I want to add one more thing for sir for MUF. So there is what we are also doing same way, but we are adding one thing is there hotline which anesthetists use for. So that hotline we connect to the MUF circuit. So that time because of theater in kids, many theaters temperature is around 22 or 20. So because of we are doing AV MUF. So because of theater temperature, our temperature may be chances to go down. So that time we are doing using that hotline. So that hotline we can pass our MUF circuit. So patient will get higher temperature blood. Okay.
One more question to Vaishali. Like, my question to all rather. So shall we warm the temperature post TCA?
Madam, can you come forward to the mic?
Post TCA, when we come off bypass, do we accept such high temperature as you mentioned 36.5 or 37? So question to all, can answer anyone.
36.6.
Yeah. Post CPB, you rewarm the patient to almost more than 36, right? So my question is post TCA, do we really warm the patient to 37?
As I mentioned in the PPT, it was a very slow rewarming, and till that we go to 36.6.
Okay, it's fine.
I would like.
This is more considering the cerebral protection I'm asking.
I just want to add a point to this, ma'am. This in pediatrics, you are talking about pediatrics. So we have studies where we say that rectal temperature is a better monitoring option for pediatrics, especially because definitely there's an after drop. And actually at 36.5, I think it is quite okay because we have other parameters to warm the patient like our blanket and our bear huggers. So I think we can maintain temperature, and it is always, instead of reaching the 37 degrees, nowadays the trend is to have between 36 and 36.5. That's quite good enough.
Thank you. And one more question to Vaishali, like while SCCP or SCP, do you monitor both right and left radial pressures to get the correct saturation and while giving antegrade cerebral perfusion.
Anterior
Yeah, as fine. Yeah, as he's mentioned about the flow, actual flow while giving SSCP or SCP, according to him, that the flow was less. So in that case, do you monitor both right and left artery pressures?
During anterior cerebral perfusion,
Yeah.
we started it at in between the TCA only. And as we complete our procedure, and when the circulation is started, just before that, we just withdraw the cannula there only towards below the innominate artery. So while perfusion, we are in while doing the perfusion of body, we just monitored left femoral and right radial.
Thank you.
And we didn't monitor because it is during TCA, so there is no need to monitor the pressure as the patient is in TCA.
Thank you.
Can I answer to sir question?
Please,
As
yeah.
sir asked what flow we are giving 50 to 60 for selective perfusion. So what, according to my experience, that's what I choose that NIRS. If our NIRS at desired temperature in normal limit, I think we no need to give higher flow, because that higher flow considered as a higher oximetry to the patient. So that's why we are coming with NIRS value. If our NIRS value is under limit, so we no need to give higher flow. So we may give little less flow than 50 or 60 ml per kilo per minute. So on NIRS we can achieve that. And sometimes in kids, flow is directly proportional to resistance from the patient. So our resistance is very high, so we cannot achieve 50 to 60 ml. That's why NIRS is important in kids when we are giving for selective perfusion. That's what according to our experience.
Absolutely fine.
But NIRS, you just consider the frontal areas. Na? What about, do you do any TCDs, transcranial Doppler?
Pardon, sir?
Transcranial Doppler, TCD.
Yeah, sir, but that's what. That is the only best thing right now available with us.
When you don't have monitoring, 90% of 95% of centers will not be having theirs. So you should not miss a chance. At least put a right radial pressure and monitor it. And if your pressure is high also, at least give 25 to 30 ml per kg. That's what we are following, at least. And if your right radial pressure also goes up, you can give some bit of isoflurane. And it is worked good for us. But like in our country, we don't have like 90 to 95%, we don't have any monitoring system. So it is better to be safe. And when there is another factor to it, if you are not cooling down the patient, then it becomes very important.
Yeah, what
The temperature of the patient is important. If we are going on at like 16 degree, then I can understand you can give 10 ml also. Some flow will be going to the brain.
No, but I think.
But most of the centers, they are not cooling nowadays, more because if we are putting 2 cannulas, so you don't have to go for a TCA also, some of the cases.
No, but
so
I think
the SACP, I think the 10 ml, I will not accept in my practice.
No,
It is my personal experience.
In our point of view, if we are going for selective perfusion, we are considering temperature is very low.
Oh, you can go up to
that is
25
thing,
also, you
that
can
is
do a SACP.
Yeah, okay. Thank you.
That is not an issue.
Hello.
I have a question.
My question to Vaishali ma'am. Can you tell me in arch repair cases in newborn, arch obstruction is severe and what little bit blood going to lower body, thoracic aorta. How to deal the temperature of lower body before clamping, before repairing the arch? Can you tell me?
Generally, we try to avoid femoral cannulation in the pediatric patient. But if it is necessary, we have to do it. For femoral gradient rewarming and temperature management, we just have to go with the proper site cannulation. It depends on the and what is the defect or anomaly. It is it is present there. According to that, we have to cannulate it. I mean to say, if it is interruption, we have to go for the TCA and distal aorta. If the patient is perfusing through the shunt from the distal to the distal aorta, so we have to make a necessary arrangement for the cannulation. Through that, we can give the proper flow, and with the proper flow, we can rewarm or cool the patient simultaneously.
No. I am asking you, if PD dependent distal thoracic circulation, in that case we are emptying the heart after going on bypass. So no flow in the PDA. So we can't cool the lower body. So how to deal? You can cannulating separately to cooling the lower body. Yeah, just waiting. Yeah, going on maintaining the partial bypass and waiting to cooling the lower body.
Before you answer, ma'am.
Particularly, if you want to manage the temperature of lower body, if your patient is perfusing through the shunt, so you can go for the repair of that shunt slightly later for the temperature management, so that circulation is going.
I think newborn is not possible, na, sir?
I have a question for Dada also. That ACT of 900, do you monitor any other blood parameters? Like ACT is enough for that? Like only ACT? Dada, Debashi. Yeah, yes.
What is the question? Sorry?
Only, whether you only monitor ACT or you do any other tests also? For
No, we checked only ACT only.
Because we on ECMO, we actually use it on ECMO, we follow APTT.
APTT, yes. APTT we didn't follow, but we gone through the ACT only. And next day morning it came down to 182 seconds. After that it was it came down further, and it was continuously, it was all right.
I can
and
give
you
a
didn't monitor APTT?
Yeah.
APTT, I don't see APTT. I think they have done from the ITU.
Okay.
But what I have seen and what I have taken the things, that is only ACT.
And loading, did you give loading dose? I was a little confused. Did you give a loading dose or just an infusion?
Loading dose was 1 mg per kg. That means 4 mg. 4 mg was given loading.
Loading, okay.
After giving the loading dose, after 5 minutes or 10 minutes, they have taken the ACT, and it became more than 450.
Okay.
600, I think it was.
Just for my knowledge only.
So, and then we continuous 2.2 mg per kg per ml throughout the bypass.
That was infusion.
That is infusion.
That's it.
That is infusion. Okay. And 25 mg we have given direct to the circuit. For the circuit,
then
in our pump circuit. Yeah. In the prime, we have given. Before going on, we have given 25 mg in the pump circuit only.
So my question to you, sir.
Yes.
This was it was not anticipated, this scenario. So do you suggest, because you have given heparin, because of the heparin resistance, or it did not come up, the ACT, you thought of bivalirudin. But suppose there are centers which do not have stock of bivalirudin. So what do you suggest? Because this is not, you haven't done any hit assay or anything before, isn't it? Only on pump, you found out this situation. So what do you suggest? If we have to do any hit assay electively before itself, in case, because we did a case, it was a semi-adult, the hit assay was positive. That is why we planned for a bivalirudin anticoagulation. But in your case, you decided on the table, isn't it? That is what was your case. So how will you tackle that for any other person?
What is the question, ma'am? If bivalirudin is not available?
Yeah. Because there are centers who do not have this.
Yes.
So that is why, what do you suggest?
Yes, in case of that, then you have, we don't have any other option.
Yes.
Then we have to speak to the patient party, and we have to conclude the surgery without doing the
Because
thing.
this was on table, which you found out.
Yeah, but
And
we have to tell them the truth, what is happening. And without giving any bivalirudin or any other heparin resistance,
You cannot
anything,
do the surgery.
we cannot do this case. Then patient will going to be died. So then in that case, we have to talk to the patient party, and we have to take the decision. We have to conclude the surgery there itself.
So maybe the pre-op assay itself, you should check for some, I mean, it should be mandatory also.
Yeah, manually, see, we don't have that option that heparin resistance monitoring, how it can be done. That is this was the first case we have done in our 25 years history of our hospital in Rabindranath Tagore Hospital, NH. So this was the first time. So we didn't have any experience about. So we don't know anything about that.
Yes,
but bivalirudin we used sometimes in ECMO cases before. But when we see that nothing is happened, even after giving the FFP also, after giving the FFP we waited, then also it is not coming up more than 230 or more than 240. Then we have taken the decision, then we have to give bivalirudin and we have to do it.
Yeah, you can do APTT also because we did, because we had a case which was positive. So we anticipated this. We planned for bivalirudin. So we did an ACT bypass, on bypass, and then post-op also. So we could see the reduction. So that is one suggestion. And one more question to Sendil. He's very busy. Sendil. Start. One question. About this cannulation, of course, robotics is the trending. So how about this cannulation? Who does the cannulation? How? You didn't show any video on that.
Oh my God, that is a big thing. There are so many presentations I have done because a lot of people are fed up with the cannulation, and this is the reason I did not show because the 7-minute, 8-minute presentation. I just definitely it was a key in robotic and minimal invasive. When you are doing a cannulation, is very, very important. With the guideline nowadays, the 3D echo machine has come fantastically. We can see the guide wire and cannula position. In position, we can do much better.
Who does it? Who does it?
No, the minimal. Of course, it will be very big cannulation.
Minimally.
It cannot be, central cannulation cannot be.
Cannot
Recently, we did one DVR. It has a tricky thing, this IVC totally blocked. One DVR, recent case. This is a different case. IVC is thrombosed, fully blocked. We cannot put a femoral venous cannulation. How do we manage? That is, in the femoral arterial cannulation one, the venous, what we did there's a port in between, there's a ribs in between. No? In that, we put a robotic port. In that, you can insert the cannula. One cannula is IVC, one cannula here is SVC. I did not have picture because I'm going to present in this MIXI conference 2026 in November, the tricky case. So very interesting that was cannulation. Though even minimal invasive, the central cannulation is possible provided the person who is inserting the cannula.
But there are arguments, pump time is naturally higher, almost double. So when you weigh pros and cons, what do you say?
No. That is why the learning curve is very important, madam. For the surgeon who is starting the minimal invasive surgery, definitely is going to take a time. And then according to, we need to, my surgeon does not take a time. It doesn't mean that people who are starting, it takes time. But the perfusionist has to manage. There is no other role. We need to manage. And if the surgeon is very much confident to do any case within 2 hours or 2.5 hour bypass time, I think they can do it, a minimal invasive surgery. Otherwise, they should keep learning things and then start. This is my suggestion and my observation.
Sir, redo surgery is possible, sir? Of
course, the redo surgery was the surgery we started a minimal invasive when it's possible for the minimally invasive. In the femoral bypass, even the robotic or minimal invasive redo case very much possible. See, it depends. Suppose you take it. 2019, I presented. That time, I don't know how many people will understand. There was a redo MVR, which we redo case. The aorta was totally other shape. You can't go reach the aorta. And you cannot cannulate, femoral cannulation. And then how you manage the cardioplegia? We gave systemic cardioplegia. That is the first time I was telling about a systemic cardioplegia, which is given a potassium pushed into the oxygenator, heart block. Then went to, LA vent is there through the mitral valve. We did that way we did it. When beating mitral valve also we did it. Redo very much possible in the robotic as well as, especially robotic is very easy.
Sir, in normal days itself, some of the valve surgeries, post-surgery, they might seem some gradient. Okay. How about the robotics, sir?
No, it's absolutely, it's a gradient, and whatever the gradient, anyway, surgeons will have their own, the sizing and all is different. That definitely, it will not be undersized. See, why? Robotic is much advanced we can 3D visualization, you can see that the sizing will be very much appropriate. You can't, we have made our own sizes for the robotic size, which is very much appropriate, and you can see whether aortic or mitral or tricuspid, anything, we see it depends why when you put undersized valve, you have a gradient, correct?
Yeah,
so
exactly.
we will not have any room of that things, will not undersize the valve at all. Anything? Thank you. Okay. Is the time up? Any other question? You can call me in the person.
I'd like to remind our chairs that we have exceeded the time for questions by 300%, but it's been interesting. So, at your discretion, do we wind up the Q&A or have one more question, Chair?
I have one question. My question to Kevin, sir. Very nice presentation. And you told about that blender, electronic blender. So, what is the vacuum? Can you specify the range of that vacuum? And second thing, the electronic gas blender can be used in ECMO oxygenator also, ECMO support also?
Yes. Hello. So this electronic gas blender gives you a minimum sweep rate of 25 ml per minute, and it goes on up to 20 liters per minute. Okay? So that is one question of yours. Yes, you can use it for any CPB, whether it is ECMO, whether it is regular CPB cases, you can. It has an inbuilt vacuum controller from 0 to 110 minus. So all you have to do is just click a button and connect your tube, and you can control vacuum assist from there. So you don't need to run around and do anything. So even in routine bypass, if you feel you're not getting adequate venous drainage, just click the vacuum controller knob and control vacuum assist from there.
Thank you, Kevin.
Nice feature.
We'll run out of time, ladies and gentlemen. I'd like to now move on with the presentation of the mementos. Can we ask our...
Kevin, sir, just last question for you. I'm sorry. That auto,
Bali, sir, we have
auto going on and auto coming off, sir. Can you put a light on that? And what will be the role of perfusionist? So,
Before that happens, one more. I just had to make sorry, Kevin, a quick announcement that the poster session is starting immediately. I had to make this announcement for the last 15 minutes, but I didn't get a chance. The poster session starts immediately in the hall adjoining, on time, on schedule. So, Kevin, very briefly, thank you.
So, Bali, we have this auto modes within the ventilation system. Auto initiation of bypasses, you just put the aortic cannula, venous cannula, and you program the pump to go on full cardiac index of 2.4 or whatever within 30 seconds, 40 seconds, whatever you want, depending on how patient your surgeon is. After you have set the time that you want to achieve full CPB, just click on start mode. Automatically the roller pump will start. Automatically the venous line will open. Whatever is being coming out from the venous line, the same amount of blood will go in the arterial line. So there is no drop in pressure, there is no sudden hemodilution, there is no sudden gas flow. So automatically the gas will adjust based on the flow that is going through the oxygenator.
so this is AI. So no. Yeah,
it is, I would say, predictive analytics. So you can do that even for auto regulation of PO2, PCO2. Many a times you're doing hypothermia cases, deep hypothermia. You don't control the PCO2 levels, right? You preset this PO2, I want 200, PCO2, I want 40. Automatically, the system will adjust the gas flows depending on your blood flows. And it will deliver the exact PO2, PCO2. Same way for weaning mode. After you are ready and you're about to come off bypass, what we do, we go and just clamp. We are not, very proper in weaning the patient. You can do this by auto weaning mode, and the role of a perfusionist is definitely there. He has full control anytime he wants. This is only
we have crossed the time limit, sir. I'm sorry. So.
Thank you very much. Yeah. May I request a panel of chairs to please step forward and present mementos to our panels. Well, this question answer, which was supposed to be 10 minutes, went for over 30. So in the meantime, all the audience in typical terms, gas pe the. So now we'll get off the gas. May I please request the panel to please step forward? Yeah. One by one. All right. If you could Vijender sir, if you could please step up and present the first memento to Debashish Rai.
Sir, please, sir, 1 minute. Sir, 1 minute.
Time is over, sir, if you don't mind. It's all right. Sorry about that. My apologies. Moving on, I'd like to request Mrs. Sri Jayanti to please present a memento to Vaishali Ritesh. Pete? I'm sorry about that. I mean, it's a very interesting session and it's also about pediatric perfusion challenges, innovations, clinical successes, and of course, innovations. So it was really interesting and encompassing, but we have to stick to some sort of schedule. Moving on to the next one. Ms. Sri Jayati, if you could please step forward and present it to Vaishali Ritesh Mehte. Can we have this photograph session quickly, please? We'll also have a group photograph happening in a short while. Mr. Mehte, if you could please step up. Sir, if you'd wait for a group photograph. Thank you. Up next, I'd like to request our Judge Ajaruddin to please step forward and present a memento to Ramakrishna Marapoina. Thank you, Mr. Ajaruddin, for being very quick. Mr. Ramakrishna? He's left, all right. We'll continue to Sujit Bamne. If you could, Sujit Bamne, if you could please step up forward and present. One more time, I'd like to request Mr. Vijender Singh to please step forward after this one to present the next memento. Karthi Murugan, if you could get ready, please. Ms. Jayanti, if you could present the next one to Anil Mahore. Anil Mahore. The next one is by Mr. Azaruddin to Senthil Kumaran. Thank you, Mr. Azaruddin. That was good thinking. Once again, Vijender Singh Bali to Adhav Ilango. Ms. Ilango has left. Okay, moving on to Kevin Menezes. Thank you. May I request all our panelists to please give them a photograph with our jury? All together, group photograph. Yes, I think everyone on stage has received their mementos. Legend, this was a very interactive panel and we could have double the time but still we wouldn't complete in time. Pediatric perfusion challenges, innovations and clinical success. Well, finally we successfully ended here despite the amount of time that we are in Q&A. Thank you very much. Now that's one thing that remains is to present our chairpersons with a little memento. I'd like to request Suhas Ramchandran to please step up on stage and present one to Vijender Singh Bali. So can you give it to Suhas, please, so he can present it to quickly. Those discussions will happen all the while. May I now request Ratna Adsul to please step up on stage and present the next one to our judge, Mrs. Sri Jayanti. And I'd like to request Suresh Shinde to please be ready to present the next one. Thank you, sir, for being proactive. You're getting the most proactive judge too. Mr. Shinde, if you could step forward. Sorry. Thank you, Mr. Shinde. And now it's to Judge Azharuddin. Ladies and gentlemen, big round of applause. A fantastic session. Thank you so much for making it so very special. This was rather unique. The question answer was as long as the presentations, and memento receiving and giving was equally interesting.
One small
It's not yet over until it's over. Bowlers have.
Oh, sorry. This is a small announcement. This is going to be the big conference with 4 association, which is SMICSI, Society of Minimally Invasive Cardiac Surgery in India, and Association of Cardiothoracic, Vascular and Surgeons of India, Asia, and 12th Annual International Coronary Congress, and ISMICSI, the International Society of Minimally Invasive Cardiothoracic Surgery. They're all together, put together, going to be one conference coming November 20, 21, 22 at Delhi. And Mr. Rakesh and myself and Bali, 3 of us going to be, perfusion side which is going to taking care. And please come, and only 100 seats are available, only perfusion, and only per faculty, like no students are allowed, only perfusion can come. This is just announcement. Thank you so much for the organization giving the time.
Thank you, Senthil. I'll now move on with the next session. Thank you, gentlemen. All right, so that's something you're going to look forward to, guys and gals. But in the meantime, right now, I have to keep track, and we are slightly behind schedule once again. Congratulations. This next session is on artificial intelligence, robotics, and the future of cardiac perfusion. We have 7 to 8 presentations in this, and I'd like to request our chairpersons to please take their place on the dais. May I have the head table quickly changed? Change the water on the head table. Ladies and gentlemen, for this session, your chairpersons are your well-known Mr. Rajendra Kokane, President, ISECT, Mr. Loknath Tiwari, Secretary General of ISECT, and Mr. Ravinath Swami, who needs no introduction. Once again, to remind our presenters that the sessions are exactly 15 minutes, including when you step up on stage and set up. So in case you have any special requirements, you're not using the computer or the laptop on the podium, if you're using your own pen drive or if you're using your own Mac, then please come to the technical desk earlier so we can load and get organized for you. It'll be nice if we don't have surprises at the last moment to help things move slickly and swiftly. And also like to remind our chairs that we have a very strict question and answer window for 10 minutes. With that, I'd like to hand you over to the chairpersons to start this session, Artificial Intelligence, Robotics, and the Future of Cardiac Perfusion. All yours, gentlemen. A quick reminder, the poster sessions have started. If you're for that, please head to that.
Hello. Good afternoon. Welcome to this what I think will be a very interesting session. I would like to call upon the first speaker, Priyanka Kumari Bhagat from Narayana Institute of Cardiac Sciences, Bangalore. She'll be talking on a comparative analysis on outcomes between robotic cardiac surgery and median sternotomy with cardiopulmonary bypass, a retrospective study.
So good afternoon, everybody. I am Priyanka. I'm from Narayana Hridayalaya from Bangalore. So I'll be talking about a comparative analysis on the outcome between the robotic and the median sternotomy, including CPV. So as everybody knows, the robotic cardiac surgery is a form of minimally invasive surgery which is using the robotic systems which has high precision and control. So with the help of the robotic surgery, through small incisions, we can control, and with minimum bleedings, we can have a full robotic surgery. So this is the Da Vinci robotic surgical system that we are using. This is the arms that you can see, and this is the console where the surgeon operates. So the patient selection criteria for the robotic surgery is that it should be, the patient should be selected, like it should be an elective case, and they should not have any emergent procedures in between. They should have a good ventricular function, and the main important thing is that the femoral arterial diameter should always be above 5 mm, so that the cannulation will be easier. The contraindications include that there are two, that is absolute as well as relative. Absolute contraindications are if the patient is having any myocardial infarction, or any cerebrovascular disease has been done, severe liver dysfunction is there, or any significant bleeding disorders are there. These patients are absolutely contraindicated for a robotic surgery. And the relative contraindication includes if any atherosclerotic, if it is less, we can use the patient, we can select that patient. For a depressed LV function also, we can use the patient. This is just the OR setup, a schematic diagram. The difference between the OT setup is that where our normal CPB machine will be there, in robotic, the Da Vinci system will be placed, and the pump will be placed on the foot and side of the patient. So this is just the setup that we have done. This is the foot and side where the perfusion is sitting with the pump, and this is the surgeon who is operating the console on the other side. So the incision and ports are minimally. So there are 4 arms of the robots, where the first one, the left arm and the right arm are for access, one camera port, and the one is the atrial retractor. The incision, this is for cardioplegic venting as well as root. This is for left ventricular venting, and this is the Chitwood clamp that we use for aortic cross clamp. So this is the cannulation. Cannulation can be femoral artery, femoral vein, including in our institute we also do a IJV cannulation for SVC, and others are the same, axillary femoral vein or jugular. There is a video of this is a small video of the peripheral artery cannulation. The arterial and the venous cannulas are inserted. First they have inserted the arterial cannula. Next, they are dilating the vessels for the femoral vein. What they do is they measure the cannula size first, and then they insert it. And the next is the cannula selection. Basically, it is depending on the BSA and the patient weight. If the BSA is less than 1.6, we prefer a 15 biomedicus cannula. If it is 1.7 to 2.1, we prefer 17. And if it is greater than 2.1, then we use a 19 French femoral arterial cannula. For femoral vein, if the patient's height is adequate, we use a 25 French, which is standard in most cases where what we are doing. And the other, if the patient's height is comparatively less, we can use a 21 or 23 French. So in the phases of robotic surgery is a little different than the sternotomy, where the first patient positioning is done, then the port is placed, then the cannulation is done, then we go on bypass, then the pericardectomy is done, then we create an exposure for cardioplegic and aortic root venting, then the Chitwood clamp is applied for the aortic occlusion, then left atriotomy and the LV vent is placed, then we deliver the plegia, the repair is done. Once the repair is completed, we will de-air and wean off bypass and decannulate. So difference between the conduct of CPB that we have seen is the robotic is normally peripheral cannulation, which requires a VAVD, up to a limit of minus 20 to minus 40. Since it is retrograde perfusion through the femoral artery, we have to be very careful about the line pressures, because if it is not acceptable, there are chances that it might lead to dissections. The cardiac index that we maintained is like 2 to 2.4, moderate hypothermia up to 32 degree, dylnidocardioplasia, and PCO2 is insufflated into the field so that the surgeons can have a good view. And the other difficulty is the distension has to be appropriate. We have to maintain, see that the distension is not there with adequate LV venting. And the sternotomy, as everybody knows, it is central cannulation. VAVD is not required mostly. With a cardiac index of 2.4 all throughout the case with normothermia and dylnidocardioplasia, it has an easy access as well as clear visualization. So in this comparison, I have taken a group of 60 patients into two groups, where the 30 had undergone robotic and the other had undergone sternotomy. These cases include ASD, VSD, myxoma, repairs and replacement mitral. So the comparison is basically on the total bypass time, clamp time, ventilation time, blood products, re-exploration rate, post-op infection, and the length of hospital stay, creatinine and lactate levels. So this is just a graph representing the total bypass time of both the groups. So initially when we started the robotic cases, since it was a learning time, comparatively the CPB time was more, and further it has come down with time. But still, as you can see, it is little more higher than the sternotomy. The same goes to the clamp time as well. Initially it was higher, it has further come down. And this is the lactate levels that were like post-protamine levels. This shows that initially the robotic lactate levels were still high. It has gone up to 10.3 compared to the sternotomy. And this is a post-POD, 0th. The maximum lactate which has gone in the ICU, which is still higher in robotic. The advantage of the robotic system is that in the robotic patients, all have gotten extubated in the POD 1. And one patient got extubated in the same POD when they were operated. The maximum, this one patient for the sternotomy had some issues with the continuous VT. It had re-explorations. Due to that, the ventilation support time was more. The same goes to the ICU time. The ICU patients, the robotic patients were comparatively less in the ICU. And the duration of the hospital stay is also less for the robotic cases compared to the sternotomy. The post-op creatinine levels is far better and less in the robotic cases when we compare it to the sternotomy, since it is lower scars and everything. This is just a different comparison between the baseline EGFR and the EGFR post-surgery in the robotic. And there is not much difference in both sternotomy and robotic, because both have increased further after the cases. The results for this is the robotic comparatively, initially it was pump time and clamp times were higher, lactates were still high. The only advantage was that intubation time was less, there were no re-explorations. Blood loss and post-op blood products usage was very low, and the hospital stay was low, and post-op creatinine levels was very less in the robotic. While in the sternotomy, it was pump time and clamp time was less, lactates were either low or moderately high. The intubation time is slightly higher because of some infections or something. One patient had a re-exploration because of the continuous VT. He had to stay for almost 20 to 22 days in the hospital. Blood loss is more because of sternotomy and other issues. With the blood products usage is more. The stay is also more, and the post-op creatinine levels has gone up to 2 in this sternotomy cases. 2.4 is the peak. And this is just the difference between it. The incision in the robotic is 2 to 3 centimeters, while the sternotomy, median sternotomy is 10 to 15. The post-op bleeding is less in robotic, and it is moderate to severe in sternotomy. Cross-clamp time and CPB time, initially it was longer, while in sternotomy it is less because it is easy access. ICU stay is less for robotic, and it is more for sternotomy. Post-operative pain is minimal due to port access, and in sternotomy it is severe because of the incision. And blood transfusion and blood loss was lower in robotic and slightly higher or severe in some cases during sternotomy. The infection rate is also very low in robotic. Re-explorations are rare, but if at all it is there, it is a bit difficult for them to open it. the cosmetic satisfaction is more in robotic. And the main advantage is that the return to the work or activity is just 2 to 3 weeks, while the sternotomy cases requires 1 to 2 months to return for the normal activities. And extubation is far early in robotic cases. To conclude, the advantage is that in port access, sternotomy is not required, pain is less, blood loss is less, cosmetic outcomes are better, smaller incisions. It is faster to return to the daily activities, and comparatively infection risks are less. So both the sternotomy and robotic cases has its own merits and demerits. So most of the time it depends on the patient's wish as well as the surgeon, if they prefer robotic or sternotomy. This is just a small video of the mitral valve repair in this thing. Thank you.
Hello. Thank you, Priyanka. And the next presenter, who is Mr. Dipan Chakravarti from Manipal Hospital, Kolkata. His topic is the new smart perfusion paradigm, robotics and artificial intelligence integrations in extracorporeal circulations, CPB and ECMO.
इधर से स्टार्ट होगा स्लाइड चेंज इधर से ना हाँ स्लाइड चेंज इधर से
Good afternoon, everyone. I am very much grateful to ISACCON 2026 for giving me this opportunity to present in such an intense, electrifying and vibrant scientific meet in the City of Dreams. First of all, I express my gratitude to the core of my heart, to all my respected honorable chairpersons, the governing body, the organizers, all the dignitaries, and all my senior mentors and dear colleagues. Today I overview over the discussion from conventional perfusion towards new smart perfusion by integrating AI and robotics in the field of extracorporeal circulation in recent CPB and ECMO practices. It is not science fiction. It is reality in the coming situations where this new AI-integrated perfusion not replaces the perfusionist, it refines the perfusionist's work more efficiently for precision-based perfusions. If we see the great painting of the French painters Paul Gauguin, where there is some relentless questions, 3 important questions asked in our field of perfusion, we also ask the same questions. And it is the algorithm is not the new things. From the Aryabhata's mathematical foundation to Muhammad Ibn Musa's algebra, and then forward to John McCarthy, who is the father of AI, and he was an American cognitive scientist also. It's moved forwards to the evolution by Hopfield and Hinton, the neural memory and deep learning revolution. And the Nobel Prize of 2024, it shows that the AI in perfusion and in healthcare is no other than only thinking, it is already happening. What is AI? AI is the human intelligence simulation by using machine. It is acquired in every sector now, from the industries to healthcare, everything, everywhere the use of AI is now coming. Basically, if we see in healthcare, there is infrastructure
and efficiency increasing. Also patient data, lots of data, and these all maintaining by the AI. In recent situation, a multi-burden system, a perfusionist have to handle lots of data, acquiring all the hemodynamics, all the managing, all oxygenations, everything with his shoulder, and also managing the surgeons also. And every burden, it is a full of burden. Why is AI booming now? If we see every countries on the world, there is AI booming. United States 100%. In India also 84% in various sectors. So the purpose of this presentation explores how AI can be integrated into the CPB and ECMO services to address the existing challenges and improve efficiency by precision-based perfusion. In treatment, diagnostic, and training, early detection, everywhere AI works. So this is a graph where India have lots of thousands to lakhs of cases yearly done, but there is lakhs of and fragmented data. So AI cannot work without data. There is garbage in and garbage out. In this picture, we see before in Mumbai, in the monsoon, in the flooding situation, there is water everywhere, but no water for drinking. Like this is in the present situation in AI infrastructure crisis. So in our hospital in Manipal, EM Bypass Kolkata already acquired the patient data all in track care, cow and computer on wheels are there. And huge scope of improvement as there is standardization, communication between different systems. And also we used distance monitoring by webcam. The use of new generation AI in queries and diagnostic is already happening. This is not so much discussing detailing. These are already happening in heart failure and to predict heart failure outcomes. All the things, international papers are there. In our perfusion, AI in action, data interpretation, and predictive analysis for precision perfusion. We all know the all new era heart-lung machines are there. Kevin sir and Senthi sir already discussed all about this. And we also, in our institution, also used optimizing venous drainage by using ultrasonic flow probe on the venous line. We have lots of CentriMac consoles in our unit. It used mainly for some redo cases, MICS cases. We regularly use and long-term complex cases also for detecting the venous drainage in each limb. It prevents to lower venous drainage and kinking of the lines and all things we have to overlook by this system. And this is the elevated perfusion into a new era by AI integrated heart-lung machines. We all know that Ascent perfusion system and quantum perfusion systems have all in this. By this elevating perfusion into a new era with the technology. New technology we have to gather, and there is a cockpit visualization, every data in your eyes, in front of your eyes, in one cockpit. This is very much important, and now the goal-directed perfusion is going towards data-directed precision perfusion by acquiring these new generation heart-lung machines. These are already integrated. Ascent heart-lung machines in our institute. And there is lots of flow sensors are there that works very well during the precision perfusion. And also electronic automated venous occluders and arterial clamp are also there for safety purposes. These are the cockpits and workstations. And inline blood monitoring during the procedures of long-term bypass cases, all the necessary hematocrit, hemoglobin, all are there. And according to temperature decreasing, we also set this by preactive measures. And this is also very important and crucial electronic gas blender now uses. We move from our previous using manual blender towards this new coming electronic gas blender. This is our institution pictures. And this is the automated perfusion letting AI take the wheel. Imagine a hard lung machine that adjusts itself automatically. When there is any catastrophic event, sometimes the level is very low, automatically adjust the venous flow, and according to this, the flow is decreasing and save the patients at the time. And this is very important. And all the alerts we have to set previously. And this is the picture you see. Previously, we managed somehow by perception, experience, and some jugaad method, but now it is technology based. This is the Spectrum Quantum hard lung machines integration, AI integrations. And AI in ECMO also very important for early detection of clot. It is now reduces the chances of circuit changes frequently, and it is very important to adjust the sweep gas according to the flow. We have to manage this and by AI integrating in ECMO. And also this is maintaining the mortality prediction and survival chances. This is an international journal showing the detection of thrombi in extracorporeal membrane oxygenation circuit. And this is the various advanced monitoring development for goal-directed perfusion and perfusion also, inline monitoring. They are also very useful. And this is a new thing for long-term peripheral VA ECMO and some MICS cases also. Biflow venous cannula, there is no necessary of extra cannula putting for distal perfusions and any sheath. This is very helpful. We regularly use in our various cases. And this is also new things coming, the smart cannula, smart venous cannula. This is also very useful, and this is auto-adjustable according to the silicon-based spring-like things, and this is very useful in coming days. These are the biflow femoral arterial cannula after distal flow checking. This is the international patients where the ELSO registry data showing the ECMO PAL, and this is the AI integration, how the comorbidities and mortality detection previously in VA ECMO. Internationally, these are very upcoming. And these are the robotics in our institution. We are just starting the robotics program in our institution, not so much cases. This is as barriers, not so much, but very little international papers are there regarding the AI integrations in perfusion. And this is the remote perfusion in telesurgery, where the remote places we also cloud-based AI systems by using, we have to maintain the expertise of the perfusion systems and move forward. This is the ethical consideration. Decision making, always perfusionist, not by the AI. And sometimes the emergency situation they are not handling. At that time, the catastrophic events, absolutely perfusionist needs. In the India, like the most burdened organization have to undertake the AI balance systems. India has to seize the opportunity to its chances now. So manpower never curtail, perfusionist job never gone. By acquiring AI, they have to adjust the situations more efficiently. AI is not replacing the perfusionist, enhancing the roles and training and simulation and augmentation their jobs, supporting the complex cases, precision and predictability, they all by acquiring skill development. Perfusionists will continue to play a vital role in there. And there are some errors in AI hallucinations, there are biasness, and sometimes medical legal issues and data securities are there, cyber security. So be care of this. And future of AI is nanorobotics, micro-robotics, everything is there. And cost is a thing. But if we acquire the indigenous system by India, and I would request the ISECT, they have a major role to do the AI in Indian system for Indian patients. And this is the limitations, lack of large RCTs are there, data privacy concerns are there, high initial cost, need for regulatory validation, simulation, and training is very necessary. AI is never-ending adaptation implementation process. India-China gap is there. We have to, lots of infrastructure development in AI. This is our institutional statistics. And this is the Viksit Bharat. In the Katha Upanishad, if we see the Vivekananda's quotation, the Uttishito Jagrata Prappo Varaha Nibodhato, we have to look forward this and the future of AI. This is the conclusions. And the warrior is going on. Welcome all to next year. ISECCON Kolkata. Thank you very much. So I conclude. शुभ सुख चैन की बरखा बरसे भारत नाम सुभागा पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंगा all come together and integrating AI, we have to, for better patient outcome, move forward a beautiful perfusion next day. Thank you.
Hello. Thank you, Dipan. The next presentation is Kinnari Chodasama, Lilavati Hospital, Mumbai. From support to precision therapy, contemporary advance in perfusion science and organ protection.
Thank you. Good afternoon, everyone. So today I will discuss the recent advances in perfusion practices, focusing on how modern innovations in CPB and organ perfusion are transforming perioperative and transplant outcomes. Perfusion is no longer simply a mechanical support. It has evolved into a precision-based, physiology-driven therapy and outcome optimization. Why it moves automatically? Okay. Traditional CPB relied on standardized flows and pressures. However, we now recognize that inadequate oxygen delivery, inflammation, and microcirculatory dysfunction significantly impacts the outcome. So, what modern CPB integrates? It is indexed oxygen delivery, that is DO2I, temperature optimization, redefined anticoagulation strategies, reduced hemodilution. For example, DO2 above approximately 280 to 300 ml per minute meter square has been associated with reduced postoperative acute kidney injuries. How do I stay? Okay. Thus, perfusion has shifted from fixed protocols to metabolic guided managements. Now we'll go on to the miniaturized extracorporeal circuit, that is MIECC, we usually call it as. MIECC systems are closed loop circuits designed to minimize blood-air interface and surface contact activation. Mechanistically, they reduce the complement activation, cytokine release, and hemodilution. And it gives us the good outcomes which includes reduced transfusion requirements, lower inflammatory markers, decreased postoperative atrial fibrillation, potential reduction in the morbidity and mortality. This represents a structural engineering solution to biologic injuries. Goal-directed perfusion. This we are talking from morning about goal-directed perfusion. These are the miniaturized circuits starting from using a SANS pump where we used to have oxygenator with VAVR. We tried ourselves having an Indian jugaad to minimize the tubing length and hemodilution. From there, now we have advanced perfusion machines, which Kevin sir already discussed about, and other companies also. Yeah. Okay? Yeah, from this to now the smaller circuits where you can use ECMO circuit for routine CPB cases with the use of cell savers. So whatever the blood is getting sucked, instead of putting it in the reservoir, there is no reservoir, it is ECMO plus the cell saver which will give you better outcomes. Less priming volume and all those things we discussed. These are the other advanced machines. Here I can show you the newer trends in venous reservoir. This reservoir has collapsible bag as well as the hard cell reservoir, so that decreases the chances of air embolism. GDP, goal directed perfusion, this we are talking about from so many years now. Goal directed perfusion individualizes pump flow based on the metabolic demand. Instead of relying solely on body surface area calculation, which we used to do from so many years, now we continuously assess DO2, that is oxygen delivery, venous oxygen saturation, oxygen extraction ratio, hematocrit. So when DO2 falls below the critical threshold, renal medullary hypoxia occurs, predisposing to AKI. Studies shows that GDP protocols reduce incidence of renal injury and neurological complication. This is especially impactful in high-risk elderly patients, pediatric populations, long CPB duration cases. So these are the monitorings available where we continuously monitoring. First one you can see 319 is a DO2, and according to that we can adjust our flows and the temperature. This is, Kevin sir already spoke about quantum blender, automatic blender. This is the newer technology, ex vivo lung perfusion, that is EVLP. So what is EVLP? EVLP represents a paradigm shift in the lung transplantation. The donor lungs are perfused and ventilated under normothermic condition outside the body, allowing functional assessment, pulmonary vascular resistance measurement, gas exchange evaluation, and therapeutic interventions. For example, lung previously rejected due to poor PaO2, FiO2 ratios can improve during EVLP and become transplantable. So you are having a increase in the donor lung pool. This is how the donor lungs are getting perfused continuously. Still time for us to go ahead with this, but this is happening. The next is organ machine perfusion for liver and kidney, same thing. You can have machine organ, and it maintains the hemodynamic condition of the liver and kidney as well, which increases the shelf life and less chances of rejection. AI and automation in perfusion. Here, artificial intelligence integrates multiple perfusion parameters simultaneously. AI system can detect declining oxygen delivery, predict hemodynamic instability, provide early warning alerts. Machine learning models trained on registry data may eventually personalize perfusion targets. As we'll keep on using more of AI and the data system, slowly we'll come out with the hospital protocols as well. Machine learning models trained on registry data may eventually personalize the perfusion strategy. Importantly, AI does not replace perfusionists. It augments clinical judgment and enhances safety. That we keep on having a debate. AI will replace our work, so it is not possible. It augments the clinical judgment and enhances the safety. We have to feed program in the AI, and AI does not take or decisions by itself or manage anything by itself. We have to feed what we require, and it works accordingly. What are the challenges faced? Despite the advancement, the barrier includes our high cost of advanced systems, limited accessibility and low resource settings, need for standardized training, and requirement for robust randomized trials. Implementation science will determine widespread adoptions. As the cost and all is not in our hand, but definitely we will try to adapt the situation, and we need to make ourselves also smart for using the AI technology. Which are the future directions? The future includes the closed loop automated perfusion systems, expanded EVLP and normothermic perfusion even for heart, integration of microcirculatory monitorings, AI-driven precision protocols, emerging technologies like organ-on-chip platforms may enable personalized perfusion modeling. So there will be, this is the future, organ on the chip. study of ischemia, reperfusion injury, drug testing, perfusate optimization, development of personalized strategies. They bridge translational research and clinical perfusion, and that is how we will go ahead with the organ-on-chip technology. In conclusion, perfusion science has evolved into a precision-based organ protective discipline. From MIECC to AI and to organ-machine perfusion, we are redefining how we support patients during surgery and transplantation. The next decade will likely see further integration and automation, data science, and personalized physiology. Thank you.
Thank you, Kinnari.
Yeah.
We move on. Yeah. Okay, a slight change in the program schedule. We now call Dr. Swarnika Srivastava from Medanta, the Medicity Hospital, Gurgaon. Dr. Swarnika will be speaking on tips and tricks of ECMO cannulation in heart failure and transplant.
While it's being set up, it'll give me a brief moment or two to introduce Dr. Swarnika to you. She's among India's pioneering female cardiac surgeons with expertise in heart and lung transplantation, advanced heart failure surgery, mechanical circulatory support devices, ventricular assist devices, and extracorporeal membrane oxygenation, and complex cardiac procedures. An alumni of Maulana Azad Medical College and GB Pant Hospital, she is ECFMG certified and has received advanced training in heart transplantation at Toronto General Hospital. She also completed an observership in cardiac surgery at Miami Valley Hospital. At Medanta, she leads the Advanced Surgical Heart Failure Clinic, combining surgical precision with patient-centric compassionate care. That is Dr. Swarnika Srivastava.
Thank you, sir, for that kind introduction. Hi, I'm Dr. Swarnika. I'm going to present on tips and tricks of cannulation in heart failure and heart transplant, which means mostly I'm going to speak about the VA kind of ECMO. So our focus will be, slide is not projected, next. No, next. I have already. No, it's not doing.
Let's see forward's next slide for you to read.
Yeah. Okay, so we'll focus mostly on the cannulation, which is the peripheral and the central ECMO, the cannula size, how do we decide, the flows, the distal perfusion strategies, the venting strategies in brief, how many cannulas are enough, is 2 enough, or we need to add more cannulas to our system, decannulation and method of monitoring these cannulas. So what is the central cannulation? Central cannulation is basically when we put the arterial cannula or the inflow cannula into the aorta. The venous can be anywhere in the femorals, in the IJV, or in the RA itself. It can be by a direct cannulation to the aorta, as we do in our normal cardiac surgeries, or it can be a indirect via a graft, or through a second intercostal space on the right, as we do in a minimally invasive surgery. So in an indirect central cannulation is mostly done when we have peripheral vascular disease. We need LV to be empty for venting. There is differential hypoxia. Then this method is good, as well as if you want to convert it to a temporary VAD. In this, we sew a graft of 8 or 10 mm. We generally use a woven graft. We don't prefer a knitted graft because it has a lot of weeping in it. So 10 mm graft is sewn, and then we put this cannula through as we put our drains. So the cannula is introduced. We put a 36 French drain and pull the tip through it so that we don't injure the tip. It is seen that as compared to the direct cannulation, it has survival benefits, is easier to decannulate, and the chances of bleeding are less. Then comes the thoracotomy approach, which is through the second intercostal space mainly. We can put both our RA as well as aorta through it. So if we see that we give a second intercostal space is open, the internal mammary artery is clipped and open, then we dismantle the maneuvrosterni joint at that area. The lungs are pushed back. Then we open the pericardium. We make sure we don't hit the phrenic. We have a good vision of the RA as well as the aorta when we take the stays. The RA purse string is taken. Mostly we take a angle cannula because it is easier to place. We can go through another incision and push this cannula. Similarly, an aortic cannula can be pushed in. With it, we use Ethibond in this so that, not Prolene, so that we have to keep for a longer time. So it can be used this way. Now the direct cannulation is mostly post-cardiotomy. It allows, as we do an aortic cannulation and RA cannulation, and if we need a venting, we can put a right superior pulmonary vein cannula. It has more of bleeding, but it gives a very good flows. The important thing is the Indian jugaad to it. We do not have those snaps which can be kept inside and we can close the chest. So we have a jugaad of putting the red rubber tube, crossing it and tying it over it so that we can close this chest. But always we'll have to open the chest to decannulate. That's the difference from indirect cannulation. Now coming on to peripheral cannulation, peripheral always doesn't mean that we are going to do a percutaneous. Only percutaneous can be done mostly on the femorals and semi-Seldinger technique, both on the femorals. Surgical can be either a femorals, axillary or the carotid. Similarly, venous can be femoral as well as IJV. That can be percutaneous. So coming on to the femoral, which is the most common one, as I said, it can be direct, either percutaneous or a semi-Selginger's method. Semi-Selginger's is open as well as percutaneously done. So we prefer that method only in emergencies. Do we prefer when we have ECPR or we are at a site where we cannot open and do? We prefer a percutaneous one. So the landmarks, when we see the landmarks, you mark from the anterior superior iliac spine to the pubic symphysis, go right in mid of this point, and almost 5 centimeters below, you will find your common femoral artery, or from the crease, it will be 2 to 3 centimeter. Mostly it is ultrasound guided if you have enough time. We prefer a common femoral because it has lesser atherosclerosis, as well as the common head of the femur is just behind it. So if you have to give a compression, it is easier to do that. When we poke a needle sewing it, we have to put it in a horizontal plane to see that we go inside a common femoral artery, not on profunda or the superior femoral. Firstly, it is larger. Then there will be no kink. We have to go almost at a 45 degrees angle to it, vertically in. When we see the good flow, then only we put ahead our guide wire, and the guide wire can be seen through TE or a transthoracic. That's a better method. Here you can see on the left, you can see the 3 guide wires are being placed. One is for the femoral vein, femoral artery, and the above one is on the common femoral vein for distal perfusion. Generally, we put the distal perfusion cannula before we put the cannula if we have enough time, because once we put our cannula, the pulsatile flow won't be there and it will be difficult to put in this distal perfusion cannula. So what are the tricks in it? Tricks in it is that we use a stiff wire. Amplizer stiff wire is what we use, because when we put in the cannula, it will kink and it will go out. Secondly, you have to have your TE or a transthoracic to exactly know, especially your venous cannulas. Arterial also you can see, but the venous cannulas, it is the most important thing. Then comes the dilatation of it. So you have a set of dilators, and it is a sequential dilatation to be done. Like if you have to put a 27 cannula, you go ahead till 26 of dilatation. Now if you see, the dilators are tapered, so only till the tapered part, not the more than that, is put. And you have to put in and out of that part so that the track is made and your guide wire doesn't get kinked when you push in your cannulas. Coming on to semi-Selginger's method, it's almost the same. It's just that you expose your femoral artery especially, if not the vein, because then it's easier to decannulate it, because you can surgically take out the cannula. Semi-Selginger's technique, the thing is that you expose the vein, then we go percutaneously in this. Generally, when we do in a cardiac surgery, we put a horizontal incision. In this technique, we prefer to putting a longitudinal incision so that another skin incision can be given and the cannulas will not be kinked or at a right angle to get into these arteries or veins. And then you can easily repair it later on. And distal perfusion cannula can also be there. Axillary cannulations are now for ambulatory ECMOs, it is a very good method. It is seen that even the stroke rates are less, wound infections are less, you can go through this. In this, we go just 1 finger breadth below the your clavicle and then open the pectoralis major. Pectoralis minor is pulled down. We have axillary vein. Just beneath it or just above it, you can find the axillary artery. Preferable in this, latest guidelines have come in Feb 2026 only, where they have seen that it's preferable to put a graft and on this artery and then put a cannula in. What happens is this, there is lesser, though the chances of bleeding is more, but there is lesser chance of hyperperfusion in this, as well as ischemia to the limb. We can put this cannula, generally you have to use a glue. Either it can be taken out from the same incision or you can take it out from another incision in the skin. But the angulation of the cannula is always better to be at 45 degrees. Otherwise, it will hit back and you will have hyperperfusion of the limb. To prevent this hyperperfusion of the limb, you have to make sure either there is constricting bands or at least an arterial line to know, or you can just keep the limb up so that there is downwards, there is not much of perfusion in this. Coming on to the carotids, carotids have higher rate of stroke in adults, but in pediatrics it is seen that it's similar to the femorals. So we do in neonates and pediatrics less than 10 kgs, we can do a carotid and IJV cannulation even for a VV ECMO. In this, above the clavicle, 1 finger breadth above it, you give a horizontal incision. Going through an horizontal incision, you will find sternocleidomastoid. You just divide the spread the sternocleidomastoid. Then the carotid sheet is open. Make sure the vagus is not hit. Now, the important point in this cannulation is that you have to know that your IJV of the other side is not blocked by any cannulas, because otherwise the patient will have venous hypertension in the brain. So, when we do that, we do tie the arterial distal end first, and then the venous end is tied. Then we open the open aortotomy, transverse aortotomy is done, and the cannulas are put in. When we tie these cannulas, we generally use a celestial tape so that later on if we open, these arteries are not hit. In adults, it's rarely used, but can be used. But the chances of stroke are the highest in that. So when we compare these cannulation methods, as seen in emergency, a femoral percutaneous is best. If you are in an ICU and you want to go ahead and do, especially in a failing heart, it's not a post-transplant, it's a pre-transplant, and you think it's not going to recover, then just definitely semi-self-genius femoral is better. For ambulation, axillary is a good option to do. In neonates, or carotid is a good option. Central, when it's post-cardiotomy or you need a lot of flow. The limb perfusion problems are maximum with the femoral. The wound infection is also maximum with the femorals. How to select size? Definitely with the weight we do in neonates, it's around 100 ml per kg into the weight. In pediatric, less than 10 kgs is 150 ml. Otherwise, as usual, we do in our daily routine, it's through the BSA. We generally, and even in the West, they prefer that below 20 kgs, neck cannulations are done, femorals are not used. Rest, 13 French Avalon can be used, but it's not available in India for a VV. Different types of arterial cannula, there are many types which we use in our general cardiac surgery. In ECMO cannulation, especially the central ones, we prefer the lighthouse ones because they are wider. Once we put a ethibond, it will stay in, and it has multiple holes. So any hole gets blocked, still our flows will be okay. Otherwise, EOPA and axillary has worked out really well for us. Venous cannulas can be of different types, single stage, multi-stage. Multi-hole, long ones are what is preferred. Now the newer cannulas have also come, though we have not used and I don't have that experience of it, but smart cannulas, they say that if you put in a stillet and put it, it's around 20 French to go in. It says that it gives a better flow because it has a mesh which gets open into the femorals, venous. So the flows are better in it. It's said that. We mostly use multi-stage cannulas only. So the priming solutions in neonates and low pediatric cases, we do add blood or albumin, otherwise there will be hemodilation. In adults or above 10 kgs, normal prime can also be used. Now, distal perfusion strategies are very important. They can be antegrade, they can be retrograde, or you can indirectly cannulate via a graft, so there can be flow on both the sides. Or when you do a semi-self-gangers, you can put an aortic cannula, or newer cannulas have come, the bi-flow, bidirectional cannulas. So when you put an antegrade distal perfusion, it has to be generally done before, as I said, before we put in our cannulas. And it has to be put, 2 operators have to be there, and it has to be put in a longitudinal fashion so that you see the common femoral as well as superficial femoral or the profunda. So your cannula has to be in a common femoral. Your distal perfusion cannula has to go in the superficial femoral. But the gap between the two should not be much when we go in, because that will be the area of stasis and clots can form there. So it is done under ultrasound guidance. Now, using 3 mm or 1/4 tubing, it's better to use a 3 mm tubing to connect, because their diameter is less, because the flow is just 250 ml per minute. So only the clot chances are more in half tubing. Monitoring can be done if you're putting later on, just flush in and see a transient increase in popliteal artery. Retrograde is done through a 5 French sheet can be put through the posterior tibial artery in this. Semi-Sellinger's technique, aortic cannula for the pediatric, you can put in that if you don't want to put a hard sheet in that, it gives an amazing flow. Because you have opened, you can just put a purse string and take this. 6 French for 15-17, 8 French for 19-21. Indirect cannulation, as I said, in an axillary, by putting that, there will be unregulated flow down, so you will have to keep the limb up so that there is no hyperperfusion kind of issue. Now, this is the newer cannula. I haven't used it, but biflow, bidirectional cannula. It has a hump inside. You put it in by a open method, pull it back. You'll see there's a normal cannula, it is pushing that in. They say they have a port this side and the flow goes down, so you don't have to put a distal perfusion cannula in this. So venting strategies, then ECMO fixation is important. Fixation, suture fixation, we do not prefer a multiplated like silk. Nylon is preferred. We don't prefer a purse string. Necrosis signs are more. Then you can have another port to take it out, tunnel, because infections are less. Head can be done. Here you can see we are using the loop of the ECMO cannula circuit itself, because it helps, it does not kink over there. So we regularly use it when you do our neck cannulation. So as a shortage of time, I just want to show if we have to put a VVA, we have a north-south syndrome and the hypoperfusion of the coronaries and brain is there. The VVA is the most common one we do. In this, I just wanted to show that this Hoffman clamps, because the flows, low flow will be in at the IJV. It is less, because there is less of against arterial flow, it has to go, and against venous, blood will flow in the venous. So we have to put a clamp so that only 30 to 35% flow goes over there. Then comes the decannulation. It can be in venous. We can just take it out and put a U-stick stitch and just tie it off. In arterial, preferably still, it is the surgical stitching of it to take it out. Otherwise, we have multiple percutaneous devices like ProGlide, which is suture devices, or collagen base, which have come up, or even patch base. Collagen base is the mantra which they are using. We generally do a surgical closure. Now, limb assessment, when you do, you have to see there is no infection, secure fixation. Only point I want to prefer is that we generally put a scale and see. We mark it and put a scale and see daily that the cannula has not migrated. And we use NIRS in both the limbs. Any limb, it is less than 40 or the difference is more than 20, then we are worried about limb ischemia. So in brief, this is what I wanted to present. Thank you.
Thank you, ma'am. With the permission of the chair, because Dr. Srivastava has to leave, can we take a couple of questions? Is there any in the audience? Please step forward. If there are no questions, then I would like to request the President, ISEC, to please step forward, Mr. Kokane, and present a memento to Dr. Srivastava. This is a break in protocol because Dr. Srivastava has flight, and we thank you, ma'am, for your time here and for that wonderful presentation.
Thank you so much, sir.
Thank you once again, ma'am. And ladies and gentlemen, we continue with our presentations. Up next, I take the opportunity and advance and request Sudeepa Sinha of Narayana Health to please step forward to the podium.
A very good afternoon to all. In robotic mitral valve replacement, surgical precision is important, but optimal outcome depends equally on perfusion strategy, meticulous CO2 management, and controlled cardiopulmonary bypass. As a perfusionist, our role is directly influence organ protection, neurological outcome, and myocardial protection. So, what are the primary objectives of robotic mitral valve replacement? Minimize surgical trauma, reduce postoperative pain, maintain optimal myocardial protection, and ensure surgical excellent surgical visualization. So, ideal candidate for robotic mitral valve is BMI with acceptable range, adequate peripheral vessel size, no peripheral disease, suitable cardiac anatomies. So I'll not explain this cannulation. You all of know the cannulation strategy for minimally invasive, I think. So this is our perfusion circuit modification for robotic surgery, extended tubing configuration, utilizing longer arterial and venous line to accommodate peripheral cannulation sites while maintaining circuit integrity. Suction and cell level integration, implement of separate cardiotomy suction system, optimized for minimally invasive field, and consider integrating cell salvage technology to minimize allogenic blood product requirements and reduce the overall transfusion cost. And emergency conversation, maintain immediately available backup equipment including central cannulation supplies and rapid sternotomy sets, conduct routine emergency drill protocol with the entire surgical teams. So this is the surgical ports for robotic mitral valve replacement, as you can see. So strategic pump position for robotic procedures. Place the pump console on the on patient left side to optimize perfusionist access and allow unobstructed robotic arm movement through the operative field, and ensure clear access to groin cannulation sites for monitoring and interventions. Maintain visual contact with surgical fields and TE display, and position for rapid conversion to sternotomy if needed. So what are the pre-procedure setup? Coordinate with surgical and anesthesia teams on equipment placement before patient arrival, ensure optimal workflow and tubing management, as I told you before. So then emergency protocols. So cardioplegia delivery, we are delivering antegrade cardioplegia through Medtronic cannula, direct aortic root administration via specialized catheter provide uniform myocardial distribution through coronary ostia. Approach requires precise aortic cross-clamping through limited minimally invasive access. So this is our CO2 management protocol. We started CO2 when LA is opening, after when valve work is going on and LA closure and uncoupling time, that's all. So interpretive monitoring and troubleshooting, pump flow rates calculated and perfusion indicators 2.2 to 2.6 liter per minute per meter square. Activated clotting time more than 480 seconds. Venous drainage and mixed venous saturation should be more than 70. Temperature to 28 to 32. Arterial line pressure less than 300 mmHg, and blood gas analysis every 20 and 30 minutes for metabolic surveillance. So most common challenges in minimally invasive surgery, as you know, inadequate venous drainage, high arterial line pressures, poor myocardial protection, and emergency protocols. So this is our 5 cases pre-op diagnosis with all our MR. We all do mechanical valve. This is our mean CPB time and cross-clamp time, and no conversion to sternotomy. So outcomes of robotic MVR versus endoscopic MVR. As you can see in robotic MVR, hospital stay is short, and ICU length is shorter, and mechanical ventilation time should be shorter. So this is our outcomes. All the patients are doing absolutely well. So what are the key takeaways for best practice? Meticulous planning, vigilant monitoring, CO2 insufflation protocol, and most common is team communications. Thank you.
Hello. Thank you.
Yes, sir.
Thank you, Sudipto. Very nice presentations. I would like to call Mr. Senthil Kumaran Dankutti. After the sessions, do the question and answer. Okay. This topic is advanced perfusion strategies with Essence.
Thank you once again, the organizing committee and respected chairperson. And I'm here talk about the advance with Sudipto talk about the mitral robotic surgeries. But I wanted to emphasize on how this advanced perfusion system, the Heart-Lung machine, helps in supporting our robotic cardiac surgery forum. The advanced perfusion strategy powering robotic cardiac surgery outcomes. Very, very important. See, this introduction is very, I just want to tell you, the 2 decades ago, the 20 years ago, there was a presentation in the US. There is the latest advanced technique. There was a time 20 years back, the latest advanced technique, robotic surgery. Today is a current technology. The robotic cardiac surgery is a current, which we do. Today is going to be, across India, is going to be every surgeon wanted to do robotic surgery very soon. But right now, India is leading and doing much better work. And especially the Apollo Hospital where I work, we are doing across South Asia and giving a fractureship for the robotic cardiac surgery. The basic thing is robot means robot will not do anything. And robot will be a robot is extension of surgeon's hand, and through surgeons, and it is operating. The robot will move with surgeon's commands. That is the simple way of taking it to the understanding the robotic surgery. Okay, this robotic surgery is nothing but this is advanced minimally invasive cardiac surgery. What is the role of robotic cardiac procedure? What is the perfusionist role? basically, I need not tell what is the role of perfusion because you all know what is the role of perfusion. But what is the role of perfusion for the robotic is very important. You need to be facilitating the surgeon and efficiently to adopt their approach, whatever the approach, whatever the approach means, the minimal invasive, there are many approaches except sternotomy. Apart from the sternotomy, anything they are approaching the heart to do a surgery, it is a minimal invasive surgery. So to adopt approaches for the minimal invasive and robotic surgery, create an environment that enables the surgeon to operate quick and effectively. That is a perfusionist's very biggest role. Choosing the appropriate instrument means in the perfusion side as well as the techniques properly, controlling the patient's degree of hemostasis and team approach. The responsibility of managing specialized equipment for the robotic, the collaborating closely with the surgical team and anticipate the addressing challenges. Anything can go wrong. If you initially when I started, there many things went wrong and we could able to adapt it and address it and could be able to manage it. So there is, when you're starting stage, you will have problems. Of course, you predict the problem, you will have solutions ready. The perfusion should be adapt and flexible to the robotic environment. So why the preferred advanced perfusion? This is a two setup. You can see one setup, the other side, this is the other setup. See, this Essence with this, which I am sitting with the pump with the Essence. The other one, which one of my friend who's sitting there and running pump in the Kerala. And there's a different setup there. And see, same robotic surgery. When you have an advanced robotic surgery, when advanced perfusion system, it makes sense. With all the parameters in front of you, anything goes down, anything goes up, we'll know right front. So therefore, you can contribute your surgeon much better way to the patient outcome. And what are the cardiac bypass, as this is a main important thing, especially the robotic concern. The venous drainage is very important, venous cannulation is important, therefore the venous drainage is very important. The flow maintenance, how much flow you maintain, whether you're 2.2 or 1.2, what is the cardiac interest you are going to maintain. When the perfusionist who run the pump will know much better. The inline monitor, which I'm talking about, the Essence machine, the inline monitor is very, very important to, accurately in current time, whatever the inline means, whatever the time in there, you are supporting it. And line pressures, of course, the line pressures, if all the machine will be there, and it has HCU control. Even Essence have HCU control. You can keep the HCU somewhere, in a heater cooler unit somewhere, you can control with the Essence machine itself. The bypass time is very important, which I was telling in the morning. Of course, it's about 2 hours of cardiac bypass. It really makes little tricky things, and cross-clamp time is more than important. The lactate level, definitely very, very important. Therefore, the machine does not show any lactate level, but when you take care of this, all the parameters, which is Essence giving, it definitely lactate will not go high. That is what I'm trying to tell you. But that's 100 case we have taken it to do an analyzation. We have done a 100 case of analyzation with how much blood flow we can give. With the robotic case, we did not flow according to the body surface area, we did not flow, we have flow what is required, what is a safe perfusion. We did it, see, we can see that with the 2.2, 3.5 liter per minute only we have flow. The flow is like that. And then if you cross-clamp time, the cross-clamp time is never increased more than 60 minutes. Then if you see the other day, the lactate never gone up more than 3 to 5. It does not go. And it is the under case of statistics. The HB, see, I have maintained the HB about 10, below 12. This is my range of accepting the hemoglobin during cardiac bypass of robotic surgery. And this is a setup which I do. See, Essence heart-lung machine 3T, which is their heart-lung machine, and the Medistem MiraQ, which is, we can see the patency. If you're doing a robotic CABG, we can see there whether robotic anastomosis are clearly or anastomosis are very good or not. The MiraQ imaging will show well. So that also from the Livanova machine, which everything setup is there. So as a perfusionist, we'll take care of all the machines control during cardiac bypass. So as I wanted to emphasize on the inline monitoring, what is inline? As a cardiopulmonary perfusionist, everything everybody knows. And we need to know about the Essence machine is hematocrit online. We can see hemoglobin, venous saturation, temperature we can see, arterial saturation, PO2, PCO2, temperature. This is a very important parameter we can see on online every movement, every second. It keep changes. Even reduce 2 seconds of flow down, up, flow up, will, accurately it shows that therefore the perfusion will have much idea to, what to do, what not to do. And I just want a curiosity whether the ABG and whether the online monitor shows very good, correct value or same value. I took same level, same time in the ABG machine and same level of photography I took. And then I compared it, it is almost same. There is nothing, not even 0.1, 0.2. There is no much difference in the ABG and then inline monitoring of Essence machine. And what I want to do is optical-based technology provides a high level of accuracy, reliability, even long and complex cardiopulmonary bypass, real-time continuous measurement of HB, PCO2, SVO2, hematocrit, DO2, VO2, everything, it gives you so much idea, how to handle the cardiopulmonary bypass. Eliminate the intermediate sampling, error delay. Keep taking sample. It will always, makes you some, blood, when you're doing this kind of cases, should not, at the high correlation with the laboratory blood report, which I did, immediate detection of rapid physiology. This is very important. Immediately, suppose you have some issue with the PCO2, PO2, immediately you will aware of it, you can do correction well, integrated and enable the data-driven perfusion. Everything is saved in the system. You can't do anything. You can take the printout and keep it with your statistics or for any evidence-based perfusion. Integrated warning, the warning system visual, anything you have goes wrong, it will give you visualization of things. And this ILM benefit of patient's outcome. So what transfusion rate, definitely when you look at it, the HB is low, start hemofilter. All the robotic surgery, I do hemofiltration and I start early. As soon as you give, I'll not wait for till, go and give a adenoidocardioplasia, dilute and then start filtering. No, I will start. As soon as go on bypass, I will know that 2.5 liter in my reservoir because I'm not going to flow 2.4 cardiac index where I'm flowing 1.5, 1.75, 1.8 in the cardiac index. So my reservoir will be definitely full. So I'll start filtering accordingly. And that ABG, if you see 7, 8 AB, the machine, if you see 8 AB hemoglobin, we can start filtering, hemoglobin will go up. And the transfusion rate, therefore, transfusion rates goes down. AKI 2.5% only. ICU stay, of course, the only 1 day. Robotic surgery, there's no problem with this. That hospital-acquired infection is very, very low due to robotic cardiac surgery. And when you're conducting with the Essence machine, especially the perfusion side only, we give, when a sternotomy, cannulation, everything gets into there. And reduce transfusion, as I said, everything. And the lactate level only, early intervention before the anaerobic metabolic development. See, what our Sam was telling, it is not a matter of a cost, it is a matter of value of contribution. How much value you contributing to the surgery. Doesn't matter. The life is nothing comparable, no cost is involved. So as long as you do perfect work with the safety work, you need not be talk about cash, especially our level, surgeons and the other management, okay. Perfusion side, we should have proper things, should not talk about the cost. The management flow, managing a flow in robotic surgery. Do you think that we can flow? As I said, we cannot flow 2.4 cardiac index. So it is what I wanted to tell you is a balance between the perfusion, optimal condition for the surgery, cardiopulmonary bypass strategy. This is my strategy for cardiopulmonary bypass for the robotic surgery. This ILBM enables the low flow management and continues HB. This is what again I'm repeating it. The DO2 is very important. Real-time monitoring, where Mr. Prakash sir and our Pradeep also was talking about DO2 morning, and absolutely I agree with the DO2 is very, very important than what you want to do flow with the 2.4 cardiac index. The HB is very good, need not be worried about it. And this is a robotic case discharge within the maximum 40 hours, where you 20 hours we discharge. Is in hours, not in the days. Within more than 20 hours, below 40 hours, maximum 1 or 2 patient goes 2-3 days in the house and then discharge. This is what we do it. And what I wanted to make a conclusion is the MICS number of surgery in everywhere is growing faster, including large spectrum of procedures. Even I was very happy that Sudipta talked about the mitral valve, and many people are want to do LA aneurysm, doing robotic surgery. The things are developing and well. And even TCAP, totally endoscopic coronary artery bypass, is going to come very soon. A lot of people will be going to do the cases and require fast analysis in all the variable information and timely reaction in order to balance safe perfusion, provide the optimal condition for the surgeon operate. The Heart-Lung machine, which is Essence, repeats the next generation perfusion platform. It is the next generation platform for the robotic surgeons. We take at high level of problem robotic is our level of next gen platform is our Essence machine, minimally invasive robotic cardiac procedure, and our analysis indicate that maintaining a blood flow within the range along with the good hemoglobin level does not significantly impact the lactate level, urine output, metabolic respiratory acidosis. The advanced perfusion strategy powering robotic cardiac surgery achieve the best outcome. That is we found it with under cases with the Essence machine. Thank you so much. Here I finish. Any questions?
I think we can have the Q&A session.
Wonderful. May I request the speakers to please step up on stage to answer the questions, and if anybody has questions, please use the mic provided. Of course, the Q&A session will be moderated by our chairpersons, so. Right, gentlemen, ladies, the forum is open for Q&As for this session.
Hello. My questions to Priyanka. Have you find out why the lactate level in your cases are high? In a minimal invasive or the robotics?
Yeah, sir. Actually, good afternoon, sir. So initially, it was a setup like surgeon was coming, induce the patient, and it used to take a little longer time when he comes to do the cases. So because of that, there was a higher lactate levels pre-op itself. Whenever the robotic cases, whatever I have seen, the pre-op lactate was already, before going CPB, it was 3.6, 3.7. So after that, post-bypass, it went up to 5 to 8. Then in the post POD 0, the same day, the highest peak in most of the cases was 13 to 15. But the next POD 1, it has come down drastically. It has dropped to at least to 1.5, 1.
So what are the basic reasons you have find out that why this?
What I think is that it was the duration of the setup, what it took, because they were just started to do robotic cases. So the time of cannulation, the time to take everything to placement, because of that, I guess.
So in that aspects, do you think that the cardiac output is impacted?
No, sir.
Because what are the main pressure on that time you are maintaining? And we seen, because even of the longer durations, why the lactate level will go high up to 10?
So initially it was high, but starting stages, whenever we started doing robotic cases, the initial CPB times was high. Because of that, the lactate levels came up. But after, once they were thorough with the procedure, timings, when it came down, the lactate levels had dropped. The initial stages only. Because of the learning curve, it was high during that time.
Okay, thank you.
Thank you, sir.
The questions from the audience?
Alok, because Priyanka is from my center,
Okay,
I just wanted to add one more point to what she said. So initially what happened when we started cannulating, the IVC cannula, we were leaving it below the IVC and IJV was above on the SVC. And after that, our surgeons visited a US hospital where they learned the technique where they push the femoral IVC cannula to upper part of the SVC, and the SVC is also there. So 80% or 90% of the drainage is from the IVC cannula. And this technique helped to have a better drainage the heart was totally collapsed during robotic surgery, and the results and everything improved. As she said, initially we had higher lactate levels, longer duration of pump time, and the surgeon was shouting at us to reduce the flow because the heart was getting filled up. This is one technique I think many people are following, and maybe we will be able to even do the whole surgery with a single venous cannula, that is femoral venous cannula. I just wanted to add it. Thank you, Alok.
Yeah, I have attended his lecture. In that, he is preferably putting that cannula from that femoral to that reaching up to the SBC.
Yes. They are pushing it little more.
Yeah, pushing it a little more. That's good.
Yeah.
Okay, thank you.
Yeah, thank you.
Question from the audience?
Hello. Yeah, it's a nice presentation by all of you. My first question to Sudipto.
Yes.
How do you manage the higher line pressure, arterial line pressures? As you said, the line pressure was high, arterial line pressures. Yeah, how do you manage in case the line pressure is high?
In case line pressure
Line
was
pressure is high. Yeah.
Okay,
So, any cannulation strategy you use?
Cannulation strategy we are doing as per BSA, as per the guideline, and SAR says we are seeing the DO2 monitoring. So we are not having any problem. But as per DO2, we are giving flow 1.5, 1.8 as per requirement. We are giving flow. So till now, I didn't have face any line pressure high.
Okay, whenever the arterial, do you measure the arterial line, artery size for particular size of cannula?
Yes.
Like a
Yes.
color Doppler and all?
Yes.
Yeah, okay,
Yeah,
thank you. Yeah, thank you. And another one question for Senthil. Yeah. As you suggest that the prolong your pump time, pump system time due to the robotic cases. Yeah. Do you face the, whenever the prolong time of the CPB time, the ICU stay is 1 day, as you said, and some patients 2 to 3 days. I don't know, you did not mention which patients for 2 to 3 days. So, any morbidity, due to morbidity and prolonged time, the ICU stay increases? Because only 1 day you mentioned, and some 2 to 3 patients you mentioned to 2 to 3 days. Please elaborate which patients use of.
See, we never crossed more than 4 hours. There's a 2 case which we did it. The cardiopulmonary bypass time was 4 hours. But definitely there is an impact will be there when the patient who runs for 1 hour pump time and 4 hour pump, there will definitely be there. That case, what we do is we don't extubate the patient. Electively, we don't extubate it because the complex is not related to the perfusion that we delay the perfusion. It is more hour went on. It is a difficulty of surgical procedure, the pump time increased.
Definitely.
So the surgical complexity, it will make the patient ventilation to overnight or 2 days, and then obviously the consequences of this ventilation, and it remains same. It will delay the post-operative recovery. Definitely it will recover. It will be little delay than regular robotic cardiac surgery. Definitely, there is no question. All the case will not see same. There is the impact you will know in the theater itself. The patient is, surgeon itself will tell, patient will not getting extubated unless until I'll tell you. You will give the clear instruction to the ICU people. Yes.
Yeah.
There's one more thing. All of you asking me question. I would like to ask you a question when you all of you, because this is all learning give and take policy, and you have went on bypass. There is in the femoral bypass you went on bypass, and obviously I have a Essence machine. Somebody will not have Essence machine, and we do femoral bypass. The left femoral. We don't measure femoral artery pressure. Okay. We put a radial artery. So the radial, very bad thing in the radial, when you reduce the flow for some extent, because the robotic surgery insists we reduce the flow, even permissive reducive flow is out there. That therefore you will reduce the flow. This radial artery will go in the patient. So pressure will not know. Okay, but you have a written very good, and pressure will not know. So that condition, what is as a perfusionist, this people will look at the pressure only. The anesthetists will look at the pressure. Surgeons once in a while look at the pressure only. There is no pressure in the monitor. And 30, 20, it shows go something like that. What is our role? How to manage this? How give the confidence to the surgeon that no, nothing to worry. So therefore, here we, in the essence, this really big role, and the NIRS monitoring also there, no?
Yeah,
That the NIRS monitor will have there. So when your NIRS shows more than 60, on both lobes, both the right side and left side, more than, we always use NIRS for all the robotic surgery. When you have more than 60 and the line pressure, there is nothing problem. Written, there is no problem. And your all the parameters, essence shows everything, no problem. Then whether the pressure is there or not, you believe it or not, whole case I did not I bother about the pressure and did the case. And it went very well. Then next day we extubated, patient went very well. Because these are the small panic things will happen during minimal invasive. You need to be patiently adapt to the situation and control it. That is very important.
Yeah, thank you.
Thank you.
Yeah, thank you.
Next questions. Oh my God.
Central.
Yes, sir.
How are you?
Thank you, sir. Thank you, sir. Please.
Nice to see you, actually.
Thank you, sir.
Central, you asked the radial is going spasm and etc. So you are right, actually. But in that case, you must put a femoral artery. It must be a femoral artery. Oximetry will not judge the lower limbs pressure. Oximetry gives only the cerebral. Okay, so you are saying if it is oximetry is there, it only gives you what exactly the oxygen into your brain. Okay, whether your flow is adequate or not, to have the oximetry more than 60 in the brain. But pressure, radial pressure is spasm, you must have a femoral artery, and that is what exactly debated and recorded always in the book. Okay, thank you.
Shall I tell you sir, one thing? When you have a femoral artery bypass, you all know that femoral bypass will have a right femoral pressure. It show the line, approximately it will show the line pressure only. It will not show the pressure, of course. This is what I understanding. When you put a cannula in a femoral artery, in the left femoral artery, the right femoral artery will show the line pressure. Moreover, nearby line pressure, it will not show the patient's, actual pressure. That is what I understanding. And that in sir, I think it may be correct. But when you try to put that condition is not positioned to robot arm already dog. Already dog, sir. The
See,
robot
having a 10 pressure on a radial is much worse than having a 30 pressure, line pressure on a femoral. Okay, that itself shows there is actually pulsation.
Okay, you're right, sir. Anything else?
Hi, Sendil. What you said is practically correct. When the radial pressure goes on spasm, we have that maximum oximetry, that NIS. So that will give perfusion. What about the distal? What I do is usually, as soon as go on bypass, I take a mean radial pressure and the line pressure. Usually line pressure will go between 260 to 320. And the radial pressure will be 60 to 80. So the difference will be almost 180 to 160, 180. I take this as in the primary as soon as go on bypass. When it goes on, as you reduce the temperature, it will goes on spasm. And when you come down on flow also, because it's impossible to give at 2.4, you may be giving 1.8 to 2 liters when it comes down to 30. So usually I try to maintain the same line pressure, okay, when it goes on spasm, and take the urine output as a distal perfusion, as an indicator. That's it. But usually when we do these things, almost all comes up in a good position as we come off on bypass.
No, that is what I am trying to tell. See, when a radial, all the perfusion who are doing a minimal invasive surgery, they don't put a femoral artery. I think as per pressure monitoring, we don't do it. Because one more prick and the infection, this and all. So radial artery is enough. When this kind of happens, once in a while this kind of situation happens, So of course we cannot go and do pricking. You know, heparin is in patient.
No, that's
you can't
impossible.
keep pricking the
Yeah,
femoral
yeah.
artery. Okay, one thing. So after doffing and everything, then we can put a femoral artery and check it. By the time the spasm would have released, by the time both pressure would have been there. There's nothing problem. But what I tell you is that this situation can come when people who started doing minimally invasive or robotic surgery. This situation can arise for them also. So they have to understand this thing. That is what my experience. I'm just sharing.
Yes.
As long as urine output is coming, no need to worry about the radial pressure. So we need
No,
to
again,
understand.
No, here-
absolutely
here-
no. I will not agree with this. The
No.
urine put alone, see, we had a patient, we have lost the patient. In fact, we lost the patient. When you have a cannulated, see that the anatomy of in femoral artery anatomy is very, very important. When a femoral artery, it is not that it's all straight. See, when you have a femoral artery,
Santosh sir, I want to add-
just 2 minutes. After that, I'll talk to you. The femoral artery pushing into directly hitting on the other common this and no. We had a case when we went on bypass, there was no problem. Slowly it went a line pressure high and it was distal portion, only distal flow was there. There was no flow on the top. It went dissected. It went and dissected because of cannulation. The cannula was so high in level. It went to some other level. I mean, you understand, no? So it did not go towards ascending aorta. It went. So the urine output is very good. That is not urine output alone will not give you especially the minimally invasive. But of course, urine output also as a orthodox perfusion, urine output also will make matter.
I'll give one example only. I had a condition in small children where they were not, anesthetists were not able to put an arterial line, venous line. So we went ahead and did cases without monitoring any pressure.
Okay.
So patient was all right.
Yeah,
So there are conditions we have to, so that is our,
Yes,
this
that
thing.
means God is
Now we
there.
have to-
God is there.
That is perfusion skill.
Thank you.
So you are worried about radial pressure. At least you had pressure. I'm telling. At least you had something
so
20, 30.
why-
I didn't have number only, man.
Can we have a protocol like we do it for VA ECMO? Connect the SpO2 probes in both the toes. You cannot keep on monitoring all the SpO2s, obviously, but you keep it connected and keep it on the side, and whenever you want to see the distal perfusion, just check the SpO2 of both the legs. As simple as that. That we do on VA ECMO usually. So that you can do it in the robotics as well.
Again, you're telling the long bypass femoral, of course, we do a lot of things. When you
But
have
we
a
can
1
have
hour,
this in
1.5 hour
guidelines,
bypass
right?
time, why do you want to do this? When you 1.5 hour bypass
Hello.
maximum, what do you want to
It's all depends on how you are checking everything. Do not go for that. Whatever things makes you acceptance, you can go for that only. So winding up this session.
Well, we can start a whole new conference with Levan over.
I think it will be next.
Senthil, I want to ask one question to Senthil. Senthil, in the morning you said that in the robotic DVR, lactate was 1.9, even a post-operative. Barabar? My question is here, 1.9 is high, definitely. My question is that, have we done the lactate on pre-bypass patient? Yeah.
Chair, I would request you to conclude.
No, that's okay. He has noticed 1.9, but I also said many dialogue. There's if you see the preoperative lactate is whatever it is a 2, 3, 4, 5, minus 2, minus plus 2 is acceptable, I said. It is not, some patient with a sick heart will have a lactate preoperatively 10 also.
Yeah.
So we cannot, we cannot say, I will bring it to 2. No, it may be 12,
No,
it may be 8 possible.
I did not
Sir,
ask
today's ABG is interpreting everything before, intra and the post also. So pre-CPB, ABG shows how much lactate is
Pre-op
there.
lactate is very, very important. Sometimes some patients pre-op 2, 2.3, 3, up to common, that is common. Regularly we are seeing if you do pre-op ABG. So for that we cannot maintain.
And sometimes
And
you
next
got the
thing-
pre-op lactate was high
next thing,
due to
in
failure.
our
And
center,
then when we went on the
our
bypass,
practice
it is okay.
For every mixed
So
cases.
it's all depend on the different cases, sir.
Yeah.
So winding up this session, sir.
Yeah, one question. In my center, every mixed case, we do all Bentals, everything, mixed Bentals and all. We did highest 83 number mixed Bentals in my center. For every case, it mandatory to femoral artery and radial artery. Must. See, as you said, it's going, yeah. You know that the trace is in femoral, it's spiky like that. So where you have to take it mean. So if you continuously monitor radial and femoral, not much different. Sometimes some patients is maybe a little bit different. So we are in our center, that's a mandatory, femoral and radial. All mixed cases. You said no, one patient radial gone to 0. We all also have that one bad experience. We lost that patient. For that, one thing, guide wire, TE guide wire is very, very important. From that patient onwards, we are putting every patient, radial artery, femoral artery also through echo, TE. Thank you.
I think
I'll inform to my anesthetist.
Senthil, I think we'll conclude the session. We can have a discussion later on more informally because I'm sure this is very interesting and there will be a lot more points to discuss. Alaric?
Yeah, it's good discussion, Senthil. Very good.
Thank you, Mr. Swami. Thank you, Chair. Wonderfully executed program, I must say, and lots of information and interaction from the audience. We reached a sort of temperate point right here, but that's what it's all about, exchange of information. May I please request the Honorable Chairs to please step forward, and we will quickly start with the presenting of mementos. The first one, may I please request President ISECT, Raju Kokane, to please step forward and present one to Priyanka Kumari Bhagat. Priyanka, if you could please step forward. Getting ready in the wings is the General Secretary who will present the next memento. This next one will go to Dipayan Chakraborty. I'd like to request Ravinath Swami to please present a memento to Kinari Natwarlal Chudasma. Mr. Kokane, can you please step forward and present one to Sudipta Sinha. And Mr. Tiwari, who does the honors for Senthil Kumaran. I'd like to request all our presenters also to please join up for a group photograph. Ladies and gentlemen, a big round of applause for this panel. There were points, viewpoints and counterpoints, and that's what we like. Thank you very much, gentlemen. And now all that remains is to thank the preeminent chair panel that we have as chairs. And for that, I'd like to request Naveen Waghela to please step forward and present a memento to President ISECT, Raju Kokane. Mr. Waghela, are you here? Thank you. Request Vishwas Rambadi to please get ready in the wings. To Raju Kokane, sir. Mr. Rambadi, if you could do us the honors, to General Secretary ISECT, Mr. Loknath Tiwari. I'd like to request KK Sharma to please get ready to step forward. And I request Mr. KK Sharma to do us the honors for Ravinath Swami. Once again, ladies and gentlemen, a big round of applause for a very preeminent chairs. Thank you, gentlemen. That was indeed a wonderful session. Coming up is a session that's going to be equally as interactive, but it's a session that's designed to be so. There's going to be proponents and there's going to be opponents. There's a pro and con debate coming right up, and we have several participants. The debate topic is evidence versus experience, and for this one, ladies and gentlemen, I'd like to invite the session convener. Before the convener steps up on stage, just got to remind you that if you're in the hall, please ensure mobiles and connected devices are on silent. And for some time, some presenters might think there are very few people in the hall. They are, but they're listening to you all over the place because there are cameras and there are television screens, and you can be heard all over. I'm sometimes a little happy that many people are out of the hall, otherwise we'd have many more questions right here. Now, ladies and gentlemen, without further ado, and this session is going to be convened by Sam Emanuel, and the debate is going to be on evidence and experience. Ladies and gentlemen, to start off this debate, please welcome your convener, and he's going to invite also your participants. Sam Emanuel coming up on stage. I think it's time to move this.
Hi, Sam. Again, you don't have your mic, please? And can I have the clicker? Can I have your mic and clicker? Because I used to...
Good afternoon, friends. Today's debate session is the heart of clinical decision making, which we come across every day in our routine practice, where evidence and experience is a very solid knowledge which always compete with each other in our day-to-day practice in the OR and also in everyday clinical practice. So without much delay, I would like to call and listen to the experts whom we have. So let's welcome the experienced panel, Mr. PVS Prakash and Mr. Ravinath, who have bundled more than 3 decades of experience, and they have many untold stories for us. Please, sir. Yeah, wherever you want. Left is right and right is left. You're right. Perfect. Okay. And joining the panel to advocate on evidence, we still have a wonderful panelist to advocate towards evidence. It's Mr. Emmanuel Raja Singh and Pradeep. And to make this debate session more interactive, before I hand over the dais to them, I just wanted to make you also to get involved. So for that, I may request you to scan the QR code and respond to the question. Please take your phones, scan the QR code, and you can send your response. In your view, which plays more important role in effective decision making? Please scan and you can answer the questions. Are you doing it? I hope everybody understands English, right? I'm requesting all of you to scan the QR code and answer. I've got only one response. You can see on the screen. I'm not going to do anything. We are not going to proceed until unless you scan and you respond. This is a debate, right? Thank you. Sorry? It is not active? Maybe your internet is... Okay, perfect. So I have got few responses which tells that 40% to evidence and 40% to experience. You can answer it to make it more interactive. Yeah. So few are saying that, depends on the context of situation, which means they don't know, they are blank now. So now I hand over the panel to the experts here. Let us see what is going to be the best in clinical decision making in 2026. Without much delay, experience is getting more now. Okay, let's think. So I would request, there's a second question also, which tells that all values are right within target, but lactate is rising. What do you do? Increase the flows. So everybody thinks that increasing the flows is going to solve the situation without having, so all the talks on GDP seems to be not accurate. So without further much delay, I would like to hand over the dais to Experience from Experience team, who is going to come to talk.
Good afternoon, everybody. So, it is Experience all the way. Sorry, Emmanuel and Pradeep. Though figuratively you look much stronger than us, both we are little lean. Still, CPB and ECMO are not prescribed. They are conducted actually. So it is not a prescription. That is what I want to start the argument with. And we are not, as a perfusionist, we are not treating the disease. We are trying to keep the organ safe till the surgeon identifies the disease and he corrects the problem. So conduction will definitely demand experience. That is my first this thing. And if you see the history of cardiopulmonary bypass also, this machine which you see on the left side was manufactured by, if I remember correct, it is a car manufacturing company, GE, which manufactured the first heart-lung machine. So where was the experience there? There was no evidence also that cardiopulmonary bypass will work. We just went on, put some plastic tubes, took the blood out, circulated outside the body, and after that we gained a lot of experience, right? There was initially animal experiments, we cannot say. Still the patients, we had a lot of things to go. We don't know what was the correct anticoagulation to target. It all took a lot of time. By experience only we learned that, and look where we have reached. Experience has led to modern heart-lung machines with the latest technology, whatever we talked about morning DO2 and GO2. Emmanuel and Pradeep, you still think evidence is better? I think experience is much better. Okay? So, coming to the next slide. Perfusion is real-time physiology. It is not a static protocol. Okay, evidence will just give us numbers. You can have a target mean arterial pressure, say you maintain 60 to 70, target cardiac index, this is the flow you have to maintain, the DO2 thresholds and ACT ranges and all that. But experience will only teach you when normal mean arterial pressure is inadequate like that. Many of the time, we cannot fight with the surgeons. At the end of the day, the aim of perfusion is to help the surgeon to do the surgery. So if I go and tell him, sir, I want to maintain a DO2, I cannot reduce the flow, the surgeon will yell at me. I am not able to see anything, the field is flooded with blood, you do something like that. So always perfusion is a compromise actually. Everything is not perfect. You will have to improvise during the case actually. So it is only the experienced perfusionists who will know when I can reduce the flow, how long I can reduce the flow without irritating the surgeon, without compromising on the physiology and all that. And there will be a lot of things like venous cannula malposition, aortic cannula malposition, so many things will be there. And only an experienced perfusionist can find out. Ravi, would you like to add something, sir?
Yeah, that's right.
Next slide. Continue in that hemodilution.
Yeah, and things like hemodilution, how much the patient can tolerate. Again, you can have a figure that you should have a minimum hematocrit of 25 or 30 or whatever, but sometimes maybe you have to go for a hemodilution. So that all depends on the experience. Patient to patient, you decide on the spot what is to be done. Similarly, temperature shifts, risk of microemboli. There are so many factors. During CPB, it is not only the numbers on the screen which come, but there are so many factors which run at the back of our mind, and we have to conduct CPB based on all these parameters. Evidence, yes, it is definitely needed, but I would say it measures the tip of the iceberg. Experience will tell you what lies underneath, which is really the danger. So, yeah, you can say have 270 ml per minute or 300. You should have a DO2, DO2I, all that. Have the values for hematocrit, saturation flows. But what is happening at the tissue level, microcirculation, those things actually we see case to case, and then we decide what is to be done. There will be subtle variations in the circuit. We do a lot of adaptation and changes depending on the situation.
I'll add something.
Yeah, sure.
So, so nobody knows what is happening in the tissue level. That is our biggest problem. That is why morning when Pradeep was speaking, why DO2 will not work many times, that is the reason. Because at tissue level, we cannot find out what exactly is happening in the perfusion. We will maintain everything perfectly, still we will end up with a higher lactate levels, and in the patient may struggle in the ICU. All these subtle variations only the perfusionist can pick up. I mean the experienced perfusionist can pick up, and he can do the necessary changes accordingly. Because otherwise, if the experienced perfusionist can handle the surgeon also very well. Because nowadays it is very difficult. Otherwise they will say, I did everything well, but the perfusion, because perfusion is a very gray area. You can, when everything goes on well, everything is because of the surgeon, I did a great job. When things go wrong, your myocardial protection was not good. How many times we have heard about this? So many times we have heard, and it was always very difficult to prove what worked for one patient, you cannot replicate, it will not work for the other. It is only the experience hand which will pick up all these nitty-gritties of perfusion. Now, coming to the topic which we have been talking from morning, GDP and DO2, they are just numbers actually. Organs are not. You can always say 272 ml per minute per meter square, but it is the experienced perfusionists who recognize what is the problem like that. Even before this debate, Sendil was talking about radial artery pressure. He didn't have pressure at all, and still he has to maintain perfusion. How do you do this? Only the experienced perfusionists can do. Otherwise, the perfusionists who have textbook knowledge or who have done meta-analysis, he will always be worried throughout the case, and he will not have the guts to go and talk to that things are okay, still I can manage, because there are other things we can pick up. If one point is not working, in perfusion there are multiple points. Look at the color of the venous blood. If the venous blood color is very dark, the experienced perfusionist will pick up telling that something is wrong like that. So these are the things only the perfusionist can find out. Sir, you can add to this thing.
Yeah, that's right. It's just not treating the numbers. It is treating the patient and looking at all the parameters as a whole. Similarly, for as you said, poor microcirculation, and to decide on again when transfusion is needed before the threshold comes. So we anticipate. We are always alert, monitoring various parameters, looking at the changing situation, and we are thinking ahead what has to be done. So evidence, sees averages, but experience sees the individual organ. It sees the kidney, it sees the brain, it looks at the myocardium. So real patients, it's not black and white. It's a messy area with comorbidities and so many factors which the experienced perfusionist with experience will be able to pick up.
So that is the problem. Like evidence will lead to averages, but experience will treat the individual patients. Actually, you will be able to customize much better if you are having evidence. And when it comes to crisis management, it has no randomized control trial actually. And when a theatre is in crisis, whom will the surgeon call us? He'll call the most experienced perfusionist there to sort out the problem. Like that is where the experience will score. You look at the oxygenator failure. When an oxygenator is failing, everybody gets panic. And our immediate thing is to change the oxygenator. But sometimes an experienced perfusionist will decide that we can continue somehow with the oxygenation even though it is borderline, and he may not require to change the oxygenator. And experience will lead you, even you can pass oxygen through the hemofilter if you have a hemofilter, and that can act as an oxygenator for some time. And we have changed oxygenator without stopping the present pump run by taking the recirculation line and connecting an oxygenator there. So all these things which happens, you will be able to do all this if you have experience. A fresher, he will immediately start and try to jump and change the oxygenator. Sometimes you can do it without changing the oxygenator also. Same way, massive air embolism, who is the best person to handle? It will be the experienced perfusionist. A line chatter or suction overload, clot formation, Harlequin syndrome, who can pick up? Experienced perfusionist will be able to pick up. In those moments, pattern recognition saves time. This pattern recognition doesn't come when we are not experienced. It doesn't come by evidence. It comes by experience actually. And there is a muscle memory. Your inner mind or the gut feeling will tell when you have experience that something is wrong. I need to immediately adjust. This muscle memory comes just when you do more and more cases, when you are repeatedly practicing it. That is why medicine is a practice. Medicine is not just this thing actually. And calm sequencing will prevent you from making mistakes, and it will prevent mortality also. So experience is the difference between complication and a catastrophe. Many catastrophes are avoided by an experienced perfusionist.
So that's fine.
You want to add?
That's fine. That's fine. So basically, the experience will make the difference between a complication and a catastrophe, and how we sort it out.
So this I had already explained.
Yeah.
So I think we'll skip on the crisis has no guideline. True. No RCT teaches you what you do in few seconds. Only experience hand will decide about that. Okay. And now coming to the important thing, when to come off bypass. Every time we have a problem with the surgeon while coming off bypass, you overfilled it, you distended it and all. And there is no algorithm which says that how to come off bypass like that. Evidence suggests parameters, but experience is which will decide. When the heart is truly ready, you will know. And you can tell the surgeon, sir, we'll have to wait for some more time on bypass, and it is important. When filling pressures are very, very deceptive, when the heart will get filled up, how long to wait, whether ECMO is required or not. When inotropes are masking the failure, it is not the inotropes, it could be some other problem, pacing problem or potassium misuse and all that, that only an experienced perfusionist can predict, and he can get ready for that. When to delay separation to prevent disaster. So the decision to come off CPB, it is not mathematical. The CVP is 5, your pressures are 80, now you can come off. Many times, how many times you have seen after coming off, the pressure just falling rapidly and you are asked to go on bypass again. So judgment, definitely it will come with experience only. Yeah, you can talk.
Okay. Yeah, so evidence in CPB, basically randomized trials. Sorry? Okay, we'll go fast. They are ethically difficult, quite complex logistically, and not necessarily, it's sort of underpowered. So much of our practice, it depends on observational data and expert consensus and institutional experience. So if only evidence was, supreme, if we had to take that, actually CPB itself would never have stood up to the scrutiny. There are a lot of, gray areas, and you would say, no, you just cannot conduct CPB this way. So guidelines are recommendations, but they are not ultimate, commandments that you have to do it just that particular way. So many life-saving decisions happen before the evidence, can be consulted. Yeah,
so I just wanted to add that randomized control trials, they will take specific set of samples, and the number of samples will be always less, 30 patients each or 50 patients each, and it is very, very difficult. And ethically also it is difficult, like we cannot do, but experience would have taught you what we have done wrong, and from that we would have learned how to improvise on that, like that. Because these are evidence will only give the numbers, they can recommend, but what actually helps in the perfusion is experience. So evidence is intellect, but experience is physiological. There you will see in how the heart is looking, how the ECG is coming, and based on that we will be doing this. So before the closing statement, I would like to show this picture. This is a Meera Bainder flyover which came recently, which was there in this thing. This was built by an engineer who had lot of experience. They have built so many bridges, but look at the way it comes, and one Mumbai transport bus gets struck there, all the traffic will be jammed, and they give a lot of excuses that it is a future bridge and all, but look at the other side, the Victoria terminus. I don't think there were engineers when they built the Victoria terminus. It was built by a lot of people who had experience, who had the architecture, and how beautifully it stands even after 150 years. And look at the bridge which was constructed on the left side, giving lot of excuses. Doesn't it say that experience is more important than all the meta-analysis data and all the evidence, whatever they have created from the engineers? So the closing statement is, perfusion is not an algorithm. Evidence is always retrospective. You get experience only after, evidence only after getting some retrospective data. So experienced perfusionists will pick up numbers of measurable cues actually. Something is not right, his inner feeling will tell. That will come only with experience. Experience teaches what textbook don't say. So evidence is a map, but experience is the hand on the pump which runs the pump, and many cues the experienced perfusionists will get which the evidence cannot pick up. With this, we close our argument, and we would like to listen what the evidence guys are telling.
Thank you.
Thank you so much. Thank you so much. Experience seems to be very solid, right? So they have put many questions to the evidence team, starting from the HLM. So they said that the HLM was evolved just because of all the maximum. Experience is nothing, just because of evidence is nothing, but experience plays it all. And they have put some questions to the evidence. They were saying that how was HLM created? It is purely by experience. And DO2 is just a number, because sometimes we see patients which is chaotic. And only experienced person can handle crisis. Oxygenator failure, how can an evidence guys can help it off? And also, there is no guidelines for crisis management. It's all experience, experience, experience. If venous flow is poor, heart is distending, what evidence do you have? Now, evidence team, it's up to you. Let's see who's going to come and talk for evidence. Over to evidence.
Thank you, Sam. Thank you, organizers, for giving us this. My question to Prakash. See, everybody know about John Gibbon, right? Yeah? Everybody knows about John Gibbon, right? And initially, after few experiments or after few surgeries, he had to stop the surgeries. He closed his department. You know why? Because he had a lot of mortality. And just later on, the surgeons, oncoming surgeons, restarted that, and they identified what all mistakes John Gibbon did, and then they restarted it, corrected those mistakes, and then started cardiac surgery, and that made cardiac surgery up to this level right now. Okay? So, no, it's the data which helped him. It is the evidence. It is the evidence which helped him. If he doesn't have that evidence, yes, everybody is talking that evidence and experience are two different things, and we are here to explain you what it is.
Yeah. So it's a bit of a for me personally, because both Ravi sir and Prakash sir are they are mentors to all of us, and so with their permission and blessings, I would like to begin. Why evidence scores over experience? So, the evolution of evidence-based practice. It's basically a collated experience of many individuals or institutions which create a database. The database analysis has some common points of inference. Parity of results which are observed creates evidence, and this can be reproduced, which further validates the practice. And the validation of evidence leads to what is known as the creation of evidence-based guidelines of practice. Now, they have talked about why experience scores. I'll talk about the disadvantages of experience. It has number one, it has a very personal touch, a very individual touch. It narrows down approach to a particular situation, can create a high rigidity in approaching problem solving, can impact the quality of support provided to the team, and there is always a potential for conflicts. Like if you have too many experienced individuals sitting around and talking, there is always a potential for a conflict. The personal touch. How is experience created? Individual reaction to a scenario creates a memory. The repetition of memory creates an individual work style, and many episodes of expression of this individuality creates what is called as a personal experience. The drawback is it may not correlate to other thought processes. A narrowed down approach presents a very unipolar approach to problem solving. It always presents a one-sided view of the situation, can miss out potentially more efficient ways of solving the problem, and also can increase cost, time, and efforts. The rigidity of approach. It's the my way or the highway thing. Like, I have done this, you do this, or else, well, it's all up to you. That disrupts critical thinking. It resists accepting other viewpoints, and comprehensive analysis of the situation is severely lacking in such a situation. Impact on support of the team. Individualistic approach hampers team progress, obviously, because when you put the individual before the team, the whole team suffers. Team members avoid discussions because, yes, oh, that person, he doesn't listen to anything. He is so full of his own self. So it's better that I don't discuss. Interaction gets hampered. Organizational efficiency is severely reduced. Potential team conflicts. Too many experienced individuals, like they say, too many cooks spoil the broth. So there is discussion, but it is not a discussion. It is often a clash of egos, not ideas. Destroys the spirit of inquiry in junior team members, and that's a very, very destructive thing to happen. And it leads to team disintegration. It's just not a question of why, it's only a question of when it's going to happen. The advantages of evidence. It is based on thorough research and refinement of information. It provides an unambiguous display of information. That is, if there is an effect, there has to be a cause. Reproducibility of results. That is, it strengthens the veracity of the information provided. It has a strong potential for future refinement because as technology, as practice improves, you can always refine whatever evidence you have. Avoids conflicts and instills confidence in the team because you have a set pattern that will tell you what exactly you need to do in case there is a crisis. And that also creates a blueprint of a plan of action, which is definitely a support for junior team members who are trying to build up a career. Now, as results to patient care, experience can lead to results, and I firmly agree with them, but evidence can lead to repetition of results. Experience can help solve problems. Evidence can help prevent problems. Experience operates mostly from instinct. As, yes, a crisis, an instinct to come out or solve. But evidence operates from insight. And experience can be a little bit aggressive in approach, but evidence is more balanced and nuanced in approach. So to summarize, experience may be the teacher. We have always heard that experience is the best teacher. But with evidence comes knowledge. Experience can shine, but evidence always illuminates. So I would hand over to my dear friend Emmanuel for closing the remarks.
Before Emmanuel starts, there are a few questions which has been shooted against experience. They are saying that failure is not a stop. Failure is a stepping stone of success. So you are saying that failure is everything, but what do you think? A failure is a stepping stone of success. That is what they are putting forth to. The second question which they are put forth is, too many experienced people together is going to make a chaos in clinical decision. So if there should be a clinical decision, if 2 or 3 experienced people are there, it is going to be a chaos. And it will be like more egoistic approach rather than an evidence-based approach. And then, if experience alone can run a case, then what about juniors? How can a junior can handle a situation when always experienced people are going to handle a case? Then juniors, what should they do? How will they get their knowledge from? So these are the questions which evidence has put forth. If you can answer a few of it.
Prakash sir, just a minute before that. Just one more point here which I forgot to mention. That is why, since most of our practice is derived from, and terminology is derived from the aviation or the military lingo, you will find that they have operating manuals. Why? It's all based on evidence. Aircrafts have safety manuals which tell you what to do in case of, say, engine failure. There is a set protocol which needs to be followed. And that is exactly what helped the pilot of the US Airways to land his jet safely on the river Hudson, thereby saving the lives. Tom Hanks acted in the movie. I don't recollect the name of the movie. So over to you, Emmanuel.
So, okay. So regarding the ego clashes, I think one single perfusionist will be running the pump, right? There will not be 3 or 4 experienced perfusionists. Nowadays, they don't want experienced perfusionists because they have to pay more salary. So where is the ego coming when we have one perfusionist are there? And regarding the juniors, it will be the juniors who will be running the pump if I am an experienced perfusionist. And I would like to teach him by observing what is he doing and how to improve it at that time.
Yeah, but you are going to teach in your own way. You are going to teach in your own way. Which might not be
but
right.
Again, he will pick up based on overall statistics. It is my way. I am not telling that my way is the highway or the correct way.
Yes,
but he can always pick up
that is
things
my talk.
And he can pick up points from that, and based on evidence will give you numbers. I am not telling no.
But
experience can build up over that and refine the perfusionist.
Let us talk after my talk, because sure. I'll tell you what the evidence actually is.
Okay, fine.
Okay, so we must respect our elders and their experience, but we have to respect the data as well. Evidence is the great equalizer. Like you have a junior perfusionist, and he gives you an evidence the senior has to accept it and go with the change. For the senior perfusionists, they can validate their own experiences, whether what they're doing is true, what they're doing is right, or what they're doing is wrong. And if it is wrong, they have to change. And for the patient, evidence means safety. Whatever the patient is undergoing, there is a safe procedure in that. So the safety is given by the evidence. And this is a temple where the roof of the temple is the evidence, which is the foundation of the decision making. And there are 4 pillars for this. The 4 pillars are the science of it, the clinical expertise, which is the experience, the patient individual as such, and now the 4th pillar, which is the recent one, which is the critical thinking and artificial intelligence. So these are the 4 pillars of evidence. It's not only experience. My talk is just that it's not only experience, and we need to have those 4 pillars and have an evidence base, because we can't have a mortality just by like that. Because earlier days, people invented things, they were mortality, and they learned from it. So they learned from the data. So right now, we can't afford to have all this. So my argument is, experience is a part of evidence. It is not the sole thing. Okay, and we can't have science alone. So in all these 4 pillars are needed. We can't have just one pillar. I cannot just say only science, only data, only numbers, because that is against a crumbling wall. Because to have the temple to hold on together, to have the roof to hold on together, you need to have all the 4 pillars in thing. This is called the safe clinical decision. And the pillars are the science. The science provides you external evidence, what others are doing, what is your peers doing, what are your colleagues doing, and what is right. And the science gives you the truth, but there is a risk in that. It ignores the patient's content. It just treats the disease, not the patient, as Prakash said. And the second thing is the experience. It is the pillar of craftsmanship, the expert. It is the internal knowledge which we gather from our own experiences. It filters the research, and the clinician should apply this science with the experience. But again, the risks are it relies on outdated tradition or personal bias. We have always done it this way. You do the same way as we do. Don't change things. Because I have heard my seniors telling me, if you're coming here, you have to do it in this protocol. You should not do it in any other protocol. So that is where the experience is a bit troublesome. And the third pillar is the patient individuality. There might be, so I showed you 2 different patients with 2 different body mass index. And there are some patients where you have to have pregnancy, autoimmune diseases. So if you don't have experience, what will you do? If you don't have experience at all, how will you treat these patients? You have to have an evidence. You search Google, you go on to Google, you search for it. And the final pillar is the critical thinking and the AI. It is an analytical engine. It gives you data, and it avoids human error as well. So what the human eye has missed, and the weighing probabilities of the errors. So it acts as an integrator. It doesn't replace the pillars, but strengthens the relationships between them. Scanning research faster than humans. So the AI can scan research faster, the scan data faster, and it can give you an unbiased reply. It can give you an unbiased result. The personalizing the risks and all these things add on to the safety of the patients. So when we talk about evidence and why evidence wins is from you can have a survival, but what is your outcomes? What is your long-term outcomes? So based on that, you have a data and research which leads to best practice, which leads to risk reduction, and which leads to improved outcomes. Experience is a story of one. Evidence is a story of many. If your patient falls outside the narrow scope of your personal experience, where do you turn? You turn into evidence. You turn into Google. You search for it. What should I do right now? How can I correct it? So you go into the evidence. That covers the gap. So this is the great debate about the experience was, we have always done it this way, but the evidence voice says, what does the data say? What are the multicentral trials show you? In my 20 years, this works. That is what the experience says. What we do if we didn't know how it worked. You can't teach what I have seen. So all these things are the great debates between an experience and evidence, but the answer is both voices are in the same room, both voices are in the same operation theatre, only the evidence belongs at the bedside of the patient, and which is safety. And this is a quote by the father of evidence-based medicines. He said, evidence-based practice is not about replacing expertise, but about informing you that what you have done is right. You don't know what you have done is right, but the evidence tells you that your experience is correct and it can be followed. And likewise, in a debate between the surgeon and the perfusion who reads the literature can even discuss with the surgeon and tell that what I am doing is right and it is for the safety of the patient. So in the face of uncertainty, it's not the tradition or the experience that shields the patient, it's the evidence. Wherever you go, any issues, you are asked to follow. You're asked for a data sheet. Come and show me what you have done. So that is the evidence. Thank you.
Thank you so much. Thank you so much. It was indeed a, please take your seats. I may take 5 minutes to give the verdict altogether. I know it was a very tough debate session which was going on. And this was a real true place where we are seeing that evidence and experience goes hand in hand, right? So one thing which was really so powerful in 2026, we are talking on 2026, we are not talking in 1976 or so on. So the topic was clinical decision making in 2026, which one is greater or what is happening. So hearing both the panels, what I feel is this is no more a debate. It looks like what follows what. Whether evidence is pulling experience or experience is pulling evidence. Right? I think all of you will agree to it. So just wanted to say that evidence is been so powerful and they are talking with numbers and with lot of randomized control trial and they have evidence. Right? They have proof. And if you go to a lawyer for a judge or if you're filing a case, what they ask for? They don't ask for anything else, but they ask for evidence. More the evidence, more safe you are. More the evidence, more safe is the patient. I hope everybody will agree to it, right? But what else the evidence gives? It gives the targets. And it also gives the range. And it provides a safety net where you make sure the case which you are doing, the patient which you are handling is in the safer side. So the debate here is what is greater? It is not the debate. The debate is what should you and me has to follow every day's practice, whether it is experience or evidence. Patient is not a spreadsheet. Perfusion is not a spreadsheet where you can calculate with the numbers. But still, it is a real-time physiology, which is dynamic. It keeps on changing. So what I want to tell here now is there is a good mean arterial pressure, but there is no urine output. I am flowing high, but the temperature is not rising up. The temperature is not cooling down. So where is evidence? That time, experience will come inside and he will tell a suggestion to it. Right? In the same way, there is a target DO2, which was discussed before, but there is lactate going higher. Where is evidence? Evidence is always questioned in such type. Good drainage. Cannulation is perfect, but the heart is full. What can we do? So all these things have already been quoted. But what I want to tell is, evidence tells what usually works, and it is in retrospective nature. So that is evidence. Let's come to experience. I'm quitting this because of time. How many of you can identify the black block? Which is black? DEF? Yeah. This is how experience is. Experience is an individualized learning. It is individualized thought. It is how one person learns from a particular crisis. So experience is an individualized learning. It is not an fixed learning. So this is black. You may say that DEF is black. And someone will say, no, even B and C is black. Right? So everything looks black. But what can we do here? And it is where AI come inside. And this is where evidence comes inside. And this is where we are going deep inside, which tells that all black is not black. It is a gray, charcoal, mid-black, and true black. And not only that, if you go deeper, it also gives that it is a 60% black, which is called gray, 75 to 80% is charcoal black, and 85 to 90% is a mid-black, and true black is 100%. Where all these comes, which means experience is good, but experience is not enough. And also, all of you would have come across this. This is the most famous EBCP guidelines which is followed elsewhere in the world, and it was released in early 2025 or the late of 2026. I wanted to bring here, patient is the center. You and me are talking here for the better clinical decision making, where we are focusing on better patient outcome, right? So in this recommendations, if you see, it is full of evidence. Evidence class 1, evidence class 2, evidence class 3. Yes, you do. No, you don't. But it is not stopping over there. I want you to pull you here. The level C, it is a conscious of expert's opinion. What is expert's opinion? It is experience. So the guidelines is a combination of experience and evidence. And that is where I want to tell that clinical judgment in 2026 is evidence is a signboard where it helps you not to take a wrong turn, not to take a wrong decision when the patient situation is uncertain. While experience is the steering wheel which helps you to glide through, who gives us the suggestion how to glide through the situation when it is really an gray area. So what it is because of the patient's dynamic physiology, it is the clinical judgment, it should be evidence plus experience together. And that is where a true clinical decisions will be made up of. And this is where it both meet together. A patient benefit will be always balanced only if experience and evidence work together. So I would like to say that a good clinical decision is a combination of experience and evidence, and also putting your knowledge inside. And as you see, when both the teams were together, which means teamwork also plays a very important role here. So don't fight all alone. Always have your experienced people, evidence people, and also putting together with the knowledge and teamwork. This will increase in your clinical decision making. Evidence gives direction, but experience decides your journey, how to go forward. So thank you so much with the panel. The debate ends here, but the critical thinking goes on, and meet you in 2027. Thank you so much.
Thank you, Sam Emmanuel. I'd request you to do us one more small favor and present your wonderful panel with mementos on behalf of the organizers. All right? So you can choose whether you want to go pro or con. We'll just do it all together. All right, so the first one goes to PVS Prakash. Ladies, PVS Prakash. Bring the whole thing right up. That's all right. Just bring it up. I presume Mr. Prakash must have already received his memento, so a photograph will come to Mr. Prakash in a short while. To Ravinath Swami. To Emmanuel Rajasingh. To Pradeep Kumar Pillai. As you're aware, Mr. Prakash has already received the memento. But now it's time for a photograph together. And after this photograph, I have one more memento to give, but a quick photograph for the panel. Lovely. And I'd like to request Sundarajan to please step up from the audience and present a memento to Sam Emmanuel, our debater par excellence. Thank you, panel. That was wonderful. And always good to have debate amongst peers and friends, which is important. Last man standing, Sam Emmanuel. Thank you very much for that wonderful debate. Thank you, gentlemen. Ladies and gentlemen, next on the agenda is looking forward. And by looking forward, I mean we had just half of ISECTCon 2026. All right, and but although we're halfway here, ISECTCon 2026, we are looking forward to ISECTCon 2027, which is in Kolkata. For that formal invitation of the upcoming ISECTCon 2027 Kolkata, it's time to welcome Sudhakar Rao to the stage, and Sudhakar Rao will be then calling on the organizing committee of ISECTCon 2027 Kolkata. After which I presume we do have a surprise item which you will like before we move on to the inauguration ceremony. May I please request Sudhakar Rao to please step forward and unveil what's going to happen and when's going to happen ISECTCon 2027 in Kolkata. Ladies and gentlemen, the formal invitation to the upcoming ISECTCon 2027, Kolkata.
Sagar.
And it's over to Sudhakar Rao.
Can you play the video?
Yeah.
From here.
Your name, sir? Your name?
No, it is there with them. Calcutta. You just stop it. Stop.
Yeah. Corona.
No, wait. I'll. Good evening, all. Can I call upon to the stage all my Calcutta organizing team members? Debashish, Alok Tiwari Sahab, General Secretary. लाइन में खड़ा हूँ. Can you play the video?
कागज के दो पंख लेके उड़ा चला जाए रे, जहाँ नहीं जाना था ये वहीं चला हाय रे। उम्र का ये ताना बाना समझ न पाए रे, जुबां पे जो मोह माया नमक लगाए रे, के देखे न भाले न जाने न दाए रे, दिशाहारा केमन बोका मोंटा रे।
Thank you very much. This is Kolkata. My name is Sudhakar Rao. I am the organizing secretary for the conference. And on behalf of my Kolkata team, I am giving a small message, please. Respected seniors and distinguished faculty, dear colleagues and the vibrant future of perfusion, close your eyes for a moment and imagine February 2027. Imagine a city where history breathes, where intellect thrives, where culture inspires greatness. The city is Kolkata. And it is with immense pride and boundless enthusiasm and unstoppable energy that I invite you all to ISECTCon 2027 on 19th and 20th February of 2027 in the legendary city of joy. Kolkata has always had a remarkable legacy of starting new beginnings. It was here that the first independent national conference of ISECT was held, a defining milestone in our journey. And now history will rise again. ISECTCon 2027 marks the dawn of a new era, that is an international dimension within our national conference, and raising standards, expanding horizons, and strengthening global collaborations, and redefining excellence in extracorporeal science and technology. This will not just be a conference, this will be a movement of innovation, a movement of knowledge, a movement of unity in our perfusion fraternity. Expect world-class scientific sessions, inspiring global faculty, and transformative discussions, advanced technology showcases, and meaningful collaborations that shape the future of patient care. And Kolkata will once again set the stage for history, a city that begins revolutions, a city that nurtures ideas, a city that transforms vision into reality. So I call upon every perfusionist, every clinician, and every perfusion student, come with your ideas, come with your passion, come with your ambition to grow, because February 2027 is not just another date. It is the beginning of a new chapter for ISECTCon. And we are not just organizing conference, we are building the future of perfusion technology. Kolkata is ready, ISECT is ready. Now I ask you, are you ready to be part of this new era? Join us, be inspired, make history. See you at ISECTCon 2027 at Kolkata. I welcome you all. Thank you very much.
Check. Ladies, a big round of applause. We expect lots of fun and excitement in Kolkata. Do give them a large hip hip. Hip hip. Hip hip. Come on, guys. It's up to you. All right. Thank you very much. You guys are very fantastic. Thank you. And do have a great time at Kolkata. And thanks for the invite. Moving on, ladies and gentlemen, this is something that will really light up your senses in more ways than one. Because almost at the end of a fantastic full day of scientific papers, discussions, deliberations, and sometimes, talks about and the interactions between the audience and the speakers, we are now for a pleasant surprise that will literally rewire your mind. I wouldn't say blow your mind away. It will, but it will also rewire your mind and your thinking. We have with us for a few brief more minutes a lady who brings to the stage a load of talent. She's an alumni of IIT Bombay, and where she earned a postgraduate in biotechnology. After a sterling career in industry in the pharma and the clinical reference lab space, reaching great zeniths, she then moved on to explore the inner world with meditation. And that, after many years, has resulted in a book, Mind Your DNA, Fusion of Science and Meditation. And this book is a product of many, many years of research and a combined scientific training with deep insights into meditation and the relationship that DNA has with the mind, and offers theories and potential impact of cosmic meditation on DNA. So, ladies and gentlemen, your DNA is you, and you can change your DNA. And this lady stepping up on stage is going to tell you how. So, without further ado, please put your hands together. Look forward to change and welcome Anandi Ravinath. Thank you, Anandi. As she steps forward, I've got to tell you that Mind Your DNA has been covered extensively in various scientific and by very senior doctors also. Thank you.
Thank you. Thank you so much for such a nice introduction, Mr. Alaric. Firstly, thank you so much to the ISAC organizing committee. I would like to specifically thank Shri Raju Kokane, Shri Rafiq Sheikh, Shri Ravindra Savardekar and Parthiban sir, and also of course my husband Ravinath Swami for giving me this opportunity to present a little bit about some excerpts of the book Mind Your DNA, Fusion of Science and Meditation. And I hope you all will enjoy it. Yeah, sure. So this book is a product of various insights that I received during deep states of meditation as to what exactly happens inside of us at the body physiology, at the molecular level, at the DNA level, when a person starts practicing meditation regularly, which of course I have substantiated it with scientific research done by various people all over the world. So let us delve into what is mind all about. So what is mind? Till now, everybody has thought of mind as an abstract entity with no structure or form. Whereas mind is a storehouse of enormous amount of information. And what is that information? Mind stores the emotions, thoughts and memories right from our childhood. Every incident that takes place in our life is stored in the mind. Just like we use the mobile to, take a video of interesting episodes in our day-to-day life. Similarly, mind is actually video recording each and every incident that happens in our life, and it stores it for future recall. Now, if you think about it, any information, to store any kind of information, you need a format and you need a format and a medium. When I say format, for example, when you take a picture, it has got a JPEG format. When you take a video of something, it has got an MP4 format. Similarly, audio files have got an MP3 format. So any information, the thoughts and emotions that are stored in our mind has to have a format. And it has to have a medium. Like earlier days, we used to have the floppy disk and then the pen drive. Now we have the cloud storage. So there is a medium where these informations are stored. So mind, if it is storing such an enormous amount of information, it has to have a format and a medium. So what is that? So whereas mind is a huge data bank, DNA is a giant nanomolecule. Now the Swiss Federal Research Institute have been doing a lot of research on DNA as a storage medium. And they have found that 1 gram of DNA can store 455 hexabytes of information. And what is 1 hexabyte? It is 1 trillion gigabytes. And a normal adult human has got nearly 50 grams of DNA in us. So you can imagine the enormous amount of information that is stored in our DNA. So perhaps mind is in our DNA or DNA is our mind. Let's explore further. There were these two scientists, British physicist Peter Marcer and the German mathematician Walter Kemp. they in the early 70s, they did a lot of research on various mathematical equations and various algorithms, and they arrived at this, they proposed that DNA, our entire genome, is perhaps like a collection of CDs, which has got a lot of information stored in them, and that information is nothing but like a movie. Like our entire life is like a movie in the three-dimensional format. So according to them, every incident that happens in our life is already coded in the DNA, in our genome. So this is what they had proposed. There were these Russian scientists, Dr. Peter Garyev and his team. They did a different set of experiments. They took the linguistic experts, the cell biologists, the molecular biologists, the microbiologists, and they did more extensive studies, and they found that our DNA has got a language. There is a biological language stored in the DNA, and there is a kind of DNA grammar is like a blueprint for the development of human speech. And they also found out that DNA can be reprogrammed if words are modulated on correct carrier frequencies, which means when we recite a prayer or a mantra or any shloka, it has to have that particular intention that we want to achieve. So then it really works. So according to these experiments done by Dr. Peter Garyev, the intentions, our emotions, our thoughts actually gets imprinted in our DNA, and it comes alive in our day-to-day life. And meditation is a Maha Mantra because it's a silent prayer. There were also this Russian development biologist, Dr. Alexander Gurevich, who in the year 1923 found that our cells are emitting very ultra-fine biophotons. He named it as biophotons because they were photonic, that is they are like the light particle. At the same time, he gave the name biophotons because they were emanating from the DNA. And he proposed that there is a morphogenetic field around each and every cell. And this morphogenetic field stores a lot of information. There are several thousands of biochemical reactions going on inside each and every cell. And he proposed that the information that is required to carry out these thousands of biochemical reactions with proper coordination is actually stored in these biophotons. Then his work was taken further by the German scientist Dr. Fritz Albert Popp, who proposed that this morphogenetic field which is surrounding the cell is something like the aura which we all exude. And then later on, Dr. Roland van Wegijk of Netherlands, who has given a very good review for my book Mind Your DNA, he has taken this experiment a step further. So he did experiments with 3 different types of sets of people. The first were normal healthy people, and the second were people who had some health issue, and the third were who were practicing meditation regularly. And he found very distinct difference in the biophoton emissions of these 3 different categories of people. The normal people had a very coherent and a very rhythmic pattern of biophotonic emission. People having a health problem or a disease had a very incoherent and a haphazard way of biophoton emission. Whereas people who are meditative, he found that the biophoton emission is becoming negligible. So what happens is, when a person meditates, he is able to withdraw the prana, withdraw the thoughts, withdraw the emotions inside of him. And that is why he stops emitting biophotons and he starts actually radiating a different kind of a light. Now, in our Vedas and Upanishads, it is declared that we are made up of 3 types of bodies. The physical body, which is called the Sthula Sharira, the astral body or the energy body, which is called the Sukshma Sharira, and then there is a light body, which is called the Karana Sharira. So, meditation is a process to activate this light body within us, the Karana Sharira, which leads to a lot of healing and a lot of, it resolves a lot of health issues in our body. And most of the diseases that happen inside our body are because of this energy body. Energy body is made up of our thoughts and emotions. And in the recent past, there has been a lot of scientific studies where they have said that diseases have been attributed to epigenetic changes. What is epigenetic changes? It is basically DNA methylation, where the nucleotides get methylated by various, methylated at various points. So those particular points of DNA is not available for expression. It's like a knot is formed in the DNA, that portion of the genome. Then there is called acetylation of the histone proteins. DNA is wound around these histone proteins. So when there is acetylation taking place, the histone protein releases that part of the genome, and that part of the genome is available for gene expression. So in the last few decades, a lot of scientific evidence has emerged saying that epigenetic changes are caused by stress. During stress, what happens is the DNA methylation causes the suppresses the expression of the healthy proteins. And whereas meditation, there is also evidence, enough evidence and scientific literature where they have found that meditation is able to reverse the epigenetic changes. So which means the methylation which suppressed the production of healthy proteins is kind of reversed, and it gets unmethylated, and that particular part of the protein gene is available for gene expression. So this is another way of concluding that mind is in our DNA, because whatever thoughts and emotions goes on in our mind is actually getting transmitted and getting played out through the DNA. So what does meditation do? Meditation relaxes the mind and impacts the DNA positively. And what does stress do? It impacts the DNA negatively, and stress agitates the mind and impacts the DNA negatively. In fact, there has been a lot of studies where the mitochondrial efficiency seems to have improved by constant practice of meditation. It upregulates the genes to improve the immune response. Then it downregulates the genes which are causing the stress hormones to be produced. In fact, it has also been observed that there are various anti-cancerous proteins which our body can produce itself, like PAR4, LEM, TRAIL, and there are several others. So these are like the gamma knife therapy. The gamma rays are directed at the cancerous cells to target the cancer cells and kill them. Whereas our body has got an ability to produce these proteins which can target the cancer cells and kill them without harming the neighboring cells. So what does meditation do? It stimulates the internal pharmacy. So there is a whole range of medicines, medicines that can be produced by our own body to heal itself. And that's what meditation triggers. This is a tabular form of the studies done by the Harvard Medical Sciences, where they have seen several genes getting upregulated and several genes getting downregulated. So if you see long-term meditators, short-term meditators who have been practicing meditation for 8 weeks, and also control group who practice meditation only for 20 minutes before the samples were taken for studies, they have also shown this major difference in the number of proteins or genes which are getting upregulated and downregulated. So stress agitates the mind, stress causes the DNA to express stress hormones, stress agitates the DNA and causes the DNA to express stress hormones, and stress agitates the mind and impacts the DNA negatively. Reverse is true for meditation. Meditation relaxes the mind, meditation causes the DNA to express healthy hormones, and meditation relaxes the mind and impacts the DNA positively. So if you consider the mathematical Euclid's axiom, so if A is equal to B and A is equal to C, which means B has to be C, which means stress and meditation both seem to impact the DNA in the mind first before it gets seen, projected in the physical body. So mind has to be in the DNA, DNA is our mind, and this has been explained in more greater detail in my book, Mind Your DNA. So our genome is an MP4 file of a 3D movie, which is our life story. So any problem when you face in your life, if you can sit peacefully with yourself and meditate on it, you will find a solution. In fact, meditation is a highly creative activity. Whenever you feel stressed and you meditate, the problem which was causing stress, you will be able to definitely come up with a solution, and you will be able to come out of that problem. So till now, a lot of research has been done in the labs to understand the DNA. What is required now is each and every one of you have to meditate and find a solution to your own problems. And as per the Russian studies, they declared that DNA is quasi-intelligent because it has got both energy information and matter information. Matter information is the one which controls the gene expressions, and energy information is the one which is able to heal the gene expression and make your life more healthy and positive. In this note, I would like to add that when I said meditation is a highly creative activity, meditative energies are highly creative. For example, the creator of ChatGPT, the OpenAI, so the Sam Altman who created ChatGPT, OpenAI, was deeply depressed and he was going through a lot of tough time in his life. So he used to do meditation every day, and he got the idea of creating OpenAI in one of such meditative sessions. And he has said this in a podcast where he has said that meditation not only relaxes you and helps you overcome stress, it also gives you highly creative ideas. So I want each and every one of you to start meditating, even if it is just for 10 minutes, and make your life healthy and successful. That's my wish for you all. This book is available, and if anyone is interested, can approach me. And I'm also a numerologist and a tarot card reader, because I have seen that numbers play a very important role in our life. So numbers can be activated to help you the material success, and then it also helps you to relax your mind, because obviously when your material needs are satisfied, then you are able to relax your mind and go towards deep states of meditation. Thank you so much once again to the ISECT organizing committee, and that's it. Any questions anyone has, I would be happy to answer. Looks like nobody has, huh? Yeah, you can come here.
Thank you, ma'am. That was indeed a wonderful presentation, and it took you to a new dimension, which definitely needs exploring. As in, all of us can definitely improve ourselves spiritually, emotionally, materially, and all it takes is knowing and how to get to access your DNA. So I want to ask you, ma'am, since you've done so much research on the subject and you deeply explored the subject, plus of course you used your knowledge in biotechnology and field of marketing that you were so adept at, have you come across or could you relate to us some success stories that people who have used these techniques and have changed the outcomes?
Or
if you could tell us some techniques we could use, so to start the process of meditation and then enhancing DNA, that would be.
Okay. So the second question that Mr. Alaric had is, if I could suggest some techniques to help you to go into that states of meditation. Now, meditation is a process which is highly individualistic. There is no standard protocol which works for everyone. Like one technique will work for one person, whereas it may not work for other person. So meditation, going into the states of meditation is also a highly individualistic process. But what one could do, since you all are in a profession where you need to be extremely alert and extremely you have to be, on your toe while doing your job, the best thing that you should do is concentrate on your breathing. Breathe in and breathe out. And for you, in your profession, this is the best solution or the best suggestion that I have. That concentrate on your breathing in and breathing out. And when you get an opportunity to sit for meditation, then you could do the Anulom Vilom. Are you all familiar with Anulom Vilom? Breathing in from one nostril, holding it for a few seconds, and then breathing out from the other nostril. So that is half cycle. Then breathe in from the left nostril, hold it, then breathe out from the right nostril. So in this process, so this completes one entire cycle. Now, if you go to the yoga manuals or the pranayama manuals, they would say that you have to breathe in for 8 seconds, hold it for 16 seconds, and breathe out for 16 seconds. But my personal experience is, when you concentrate on the number of seconds to breathe in, hold it, and breathe out, you get more stressed, because not everyone will be able to achieve that, holding it for 16 seconds and breathing out for 16 seconds. So what I would suggest is, do a very, very relaxed breathing from one nostril, hold it for how much ever you can, how much ever seconds you can, and breathe out through the other nostril slowly and steadily with total awareness. This, if you are able to do even for 5 minutes and then close your eyes, you will be able to feel that inner silence or inner peace. So this is one technique which will work for every one of you. And this you can do before going to sleep. So your sleep pattern also will change and your sleep quality will also improve. So I'm sure this will help you all. And as far as that question of yours, can you give me life example? So I have seen in my own life a lot of changes. And I quoted about Sam Altman. He came out of his depression through meditation. And not only that, he came out of depression, he created OpenAI now, which is, taking the whole world. Yeah.
One more
Thank
thing,
you.
ma'am. Nice presentation. This is really new for us, many of us. Thank you for a nice paper. I have a question regarding how much time and how many days a week we should practice meditation.
Yeah, so as I said, don't have any rigid protocol that I have to sit at this particular time. I have to sit for 10 minutes or 20 minutes. Initially, when you start practicing meditation, don't be rigid at all. Do as per your, how much ever time you can allot, you do it. But I would think that 10 minutes at least you should spend. But in case you're not able to sit for 10 minutes, it's okay. Absolutely no problem. And one more thing which I would like to suggest is, journaling is very important. Whatever you feel after meditation, if you can, even if it is just a one-liner, you start writing it on a daily basis, something like your notes, your personal notes. You will see that there is a difference in you after 6 months. Maybe next conference we will meet and we can discuss if you start practicing regularly.
Thank you, madam. Thank you.
There's another question here. Can we pass the mic, please? Thank you.
Thank you, madam. It is really needed presentation for our profession and many people. I don't want to take more time. In the hereditary, we are hearing that hereditary, like that your grandfather or father are a short-tempered person, like that. So we believe that 20% we get the same hereditary. The reality scenario, when you get angry, you really want to control, but you are out of mood. sometime in our profession in home also, this one. So what is your suggestion to practice well to be in this, to controlling the way?
Yeah. So what happens is, many a times, highly charged people, supposing you are practicing, let us say you practiced some kind of a focused, you're talking about only anger or you're just talking about in general?
You mentioned in your presentation, when stress leading you more than your control, obviously you will lose your control.
Correct.
When you lose your control, you lose everything.
Yeah. So best is, like in our Ashtanga Yoga, there are these 8 steps. Asanas, pranayama, pratyahara. Then the second last stage is, before meditation, is dharana. Dharana is nothing but watching your thoughts, which the Westerners are coined the word called mindfulness. So dharana is mindfulness. So if you can watch your thought every moment, then it's a difficult thing. Like, it's very easy to say that, but if you start practicing it over a period of time, even before you get angry, you will be able to understand that, okay, my energies inside me are changing and I'm getting angry. I'm going to now burst out. So you will be able to get control over yourself over a period of time. And when you start practicing meditation, initially, if you don't get any experience, if you're not able to feel the inner silence or inner peace, again that can lead to frustration and anger. And it's quite possible that today you have sat for meditation for 10 minutes, nothing happened. In fact, there were more and more and more thoughts coming in. Then you go to your office, your colleague or your junior might say something and you will just burst out in anger. So this can happen when you start practicing meditation. So that is why dharana is very, very important. In fact, I would suggest that even if before you start sitting for meditation, start practicing the dharana, which is something which you can do even while you are doing your job. So it's like an open eye meditation, let's put it that way. So when you start watching your thoughts, then you will also be able to, control the inner conversation, the internal conversations that you have. So once that comes under control, then automatically your emotions and everything can be handled. I think it was quite an elaborate answer. So.
That's wonderful. Like they say, there's a time and place for everything. The time is now, the place was this room. Those who are in this room are fortunate enough to be exposed to something that is really useful and unusual. Ladies and gentlemen, I'd like you all to please give a big round of applause to Anandi. Anandi Ravinath, thank you so much. And you said the book is available. Where would it be available in case anybody reads?
If I'm able to get a small space to display, then...
You made such a big space in everybody's hearts and minds. They will definitely give you a small space or a large space to definitely. May I please request Dr. Kamala Rana to please step up on stage and present Anandi Ravinath with a small memento on behalf of the organizers. I guess that's ready. They're stepping up on stage. Thank you, ma'am, for coming up. To the center, please, for... to our photograph ladies, if you could both please come to the center. I'll just remove that chair from there. It's sort of metaphorical, an empty chair. That's like an empty mind. Good for your DNA. One more time, ladies and gentlemen, you can do it. Thank you very much, ladies. Well, ladies and gentlemen, we have a lot to think about. Meditate, how to meditate, when and where to meditate. So I'll give you about 10 or 15 minutes to do that in the privacy of your own thoughts. which actually means I need 10 or 15 minutes to reorganize the hall for the next part, which is the inauguration ceremony. So, ladies and gentlemen, we shall reconvene right here in 15 minutes where we move on with the inauguration and, of course, the Lifetime Achievement Awards. In the meantime, if you feel like it, tea and coffee is being served. Refresh, relaxed, make that phone call, do whatever you need to do. Come back in 15 minutes and we'll be here for you. If you're still here, our DJ is going to give you nice music to listen to. So, ladies and gentlemen, back in 15. Thank you very much. Ladies and gentlemen, good evening once again and thank you for your attention. We're about to start with the Lifetime Achievement Awards. May we request you all to please take your seats. We'll be starting in 2. Ladies and gentlemen, a quick announcement to all Lifetime Achievement recipients. May we request you to please take your seats. We'll be starting in a short while. Of course, time for photographs is always there, but come into the hall. Thank you. Once again, just to remind Lifetime Achievement Award recipients, please sit in the front rows. Please sit in the front rows. Thank you. Ladies and gentlemen, good evening and welcome. The Indian Society of Extracorporeal Technology, as you know it as ISECT, celebrates its annual gathering here today. You have traveled from all across the world, I would say, to be here to celebrate your profession, to celebrate your technologies, and to celebrate your achievements. Today is special because we also recognize the contributions of at least 20 stalwarts who have spent their lifetimes in the profession, polishing it, bringing it to a zenith, sharing knowledge, gaining information, and spreading health, lives, and happiness all around. These stellar personalities who step up on stage, ladies and gentlemen, need no introduction. You've known them for most of your lives, and all the lives that you've known, they have spent in the profession. They have created for themselves an aura that is commendable. They have created a legend in their names, and today we just briefly acknowledge that with a small memento or token. We have a shawl also for their appreciation, to appreciate the time, the trouble, and the effort that they have spent in bringing this profession to the heights it is now. So without further ado, ladies and gentlemen, we are gathered here for a very impactful evening today. And I'd like you all to please get involved, because these are personalities whom you've known, these are personalities you've worked with, and these are people who you look up to. So ladies and gentlemen, before we start, I'd like you all to please give a big round of applause to everybody who steps up on stage before they step up on stage. ISECT has always been fronted by personalities of great intelligence and courage who have led it from the front. This year is no different, and it's my privilege to call on stage the president for ISECT, Mr. Raju Kokane, to please step up on stage. Also, please put your hands together for the General Secretary, Mr. Loknath Tiwari. They need no introduction, ladies and gentlemen. You both know them well. There are men of many talents, and one of them is being able to lead this organization from the front. I'd request them to please take the seats, and you will notice that on each side there are vacant seats, and those are for the legends who will be stepping forward, who will be recognized today, and there are no less than 20. So, ladies and gentlemen, I have citations for each and every one of the personalities who come up on stage. What I'm going to do is I'm going to read the citation. In the meantime, there'll be an audio visual that will play on stage. And then I'll welcome the personality on stage, the gentleman on stage, and a presenter who will come up from the audience will also step forward to present jointly the citation, the memento, the shawl to the person receiving the Lifetime Achievement Award. So, ladies and gentlemen, today, Indian Society of Extracorporeal Technology, ISECT, presents Lifetime Achievement Awards. I'm going to read the first citation, and I'm going to shorten the other citations because the end signatories are the same. It's the president, it's the general secretary, it's the organizing committee, it's the members of ISECT. Ladies and gentlemen, the Indian Society of Extracorporeal Technology proudly confers the Lifetime Achievement Award upon Sri Gopal Acharya for his outstanding and pioneering contributions to cardiac surgery and perfusion technology. Beginning his journey in 1972 at Jaslok Hospital, after training at KEM Hospital, he played a vital role in developing perfusion services in India and abroad. He helped establish multiple cardiac surgery centers across India and internationally, and trained over 300 perfusionists worldwide. During his distinguished tenure at Medtronic as General Manager Cardiac Surgery Clinical, he advanced modern perfusion technologies and earned prestigious honors, including Asia Pacific President's Club Award and Star of Excellence. Founder member of IST and ISET, his lifelong dedication, leadership, and mentorship continue to inspire generations with deep respect and gratitude. President ISECT Rajendra Kokane, General Secretary ISECT Loknath Tiwari, and of course, all of Indian Society for Extracorporeal Technology. In recognition, I'd also like to request Mr. Vikas Mali to please step up on stage and help present the memento and the shawl. So the President, the General Secretary and Mr. Vikas Mali are going to all three present this Lifetime Achievement Award to Sri Gopalacharya. And when the shawl is placed, ladies and gentlemen, it's time to give another loud round of applause. Sri Gopalacharya is life number 10. So he is one of the pioneers of this organization. May I request Mr. Acharya to please take a seat right next to the gentleman on stage. Thank you, ladies and gentlemen, for that warm round of applause. We'll move on to the next recipient. Ladies and gentlemen, the Indian Society of Extracorporeal Technology proudly honors Shri Bajirao Sitaram More with a Lifetime Achievement Award for his pioneering and historic contribution to cardiac perfusion Maharashtra. Appointed in 1968 St. George's Hospital as Maharashtra's first official perfusionist, he was a true trailblazer in the field. In 1970, along with renowned cardiac surgeon Dr. B.L. Gupta, he successfully performed the state's first open heart surgery using a heart-lung machine, making a milestone in Maharashtra's cardiac history. With an extraordinary career spanning nearly 47 years, including service at Sir J.J. Hospital, he has operated the heart-lung machine in over 17,500 open heart surgeries, giving thousands of patients a new life. ISEC salutes his unmatched dedication, pioneering spirit, and lifelong service. I'd like to request Kamala Rana to please step up on stage and help our eminent President and General Secretary honor Shri Bajirao Sitaram More. Ladies and gentlemen, 17,500. That's not a small number. Truly the stuff of legend. Up next, the Indian Society of Extracorporeal Technology proudly confers the Lifetime Achievement Award upon Mr. Rafiq Muhammad Sheikh in recognition for his 38 plus years of dedicated service and outstanding contribution to the field of cardiothoracic and perfusion technology. From serving at leading institutions in India to his distinguished international tenure at King Faisal Specialist Hospital and Research Center and currently Chief Perfusionist at Asian Heart Institute, he has contributed to over 20,000 complex cardiac procedures and pioneered advances in ECMO, transplant and robotic cardiac programs. A former Vice President of ISEC, he's an inspiring mentor and his legacy is defined by clinical excellence, innovation, humility and unwavering commitment to patient care. Ladies and gentlemen, Rafiq Muhammad Sheikh, I'd like to request KK Sharma to please step up on stage and assist our President and General Secretary, Mr. KK Sharma. May I please request Subhash Sawant to please step forward. 38 years plus of experience, but he wears it lightly. Thank you. On to our next recipient. The Indian Society of Extracorporeal Technology, ISECT, proudly confers the Lifetime Achievement Award upon Mr. Praveen Janardhan Savarkar in deep recognition of his extraordinary contribution in the field of cardiac perfusion and extracorporeal technology in India. With a career spanning over more than 2 decades, extremely distinguished, Mr. Savarkar has served as chief perfusionist at leading cardiac centers including Ekvira Heart Institute, Wockhardt Heart Hospital and Viveka Hospital, Nagpur. Throughout his professional journey, he has demonstrated exceptional clinical expertise in cardiopulmonary bypass, ECMO, ECLS, IABP, and advanced mechanical circulatory support systems. He has successfully managed thousands of cardiac surgeries, including complex adult and pediatric cases, ensuring the high standards of patient safety and clinical excellence. His leadership in implementing ECMO protocols during COVID-19 pandemic reflects his dedication to innovation, courage, and service during challenging times. Beyond his clinical achievements, he's played a pivotal role in mentoring and training young professionals, strengthening professional competencies, and upholding ethical standards within the perfusion community. And of course, ladies and gentlemen, his commitment to education, discipline, and teamwork has significantly contributed to the advancement of perfusion practice in India. May I request Ravinder Pal Singh to please step on stage and join in felicitating Praveen Janardhan Savarkar. May I please request Ravinder Savadekar to please step up on stage. The next Lifetime Achievement Award, conferred by ISECT, goes to Shashank Keni Lotlikar in recognition of his exceptional dedication and outstanding contributions to the field of perfusion technology. Beginning his journey in early 1980s, he played a pioneering role in establishing open heart surgery services in central India and later brought global recognition to the profession through his distinguished service in leading NHS hospitals in the United Kingdom, rising to the position of chief perfusionist. A clinician, mentor and visionary, Mr. Lotlikar's lifelong commitment to excellence, education and patient care has inspired generations of perfusionists in India and abroad. ISECT honors his remarkable legacy and expresses profound gratitude for his invaluable service to the profession. For this one, I'd like to request the President of ISECT to please step forward, Mr. Raju Kokane, and do us the honors. Ladies and gentlemen, I don't have to remind you, these are stellar contributions by the gentlemen and the recipients today. A memorable lifetime made even more memorable by you being here as they receive this recognition. ISECT proudly confers the Lifetime Achievement Award to Mr. Hemant Kumar in recognition of his outstanding and dedicated service in the field of perfusion technology. Mr. Kumar began his distinguished career as a perfusionist in 1990 at Apollo Hospital, Chennai. Over the past 3.5 decades, he has rendered exemplary service at premier institutions including Apollo Hospitals in Chennai and Bangalore and Fortis Hospitals in Bangalore and Chennai. Currently the chief perfusionist at Apollo Hospitals, Vanagram, he has been a pillar of excellence, clinical expertise and leadership. His commitment to patient care, technical mastery in extracorporeal circulation and mentorship of young perfusionists have significantly contributed to the advancement of cardiovascular surgical outcomes in India. Through his dedication, integrity and professional excellence, Mr. Hemant Kumar has inspired generations of perfusionists and upheld the highest standards of this noble profession. May I please request Emmanuel Rajasingh to please step up on stage and help present this recognition. It always happens. Sometimes time is not. कहते हैं ना कभी वक्त हमारे साथ नहीं होता है, ऐसा भी होता है कि वक्त आपका साथ नहीं दे रहा है. Thank you so much. All right. Amongst all these stellar gentlemen, there's also a stellar lady who is now going to be felicitated. The Indian Society of Extracorporeal Technology proudly confers the Lifetime Achievement Award upon Mrs. Rajshri Pimputkar in recognition of her remarkable contribution and 34 years of dedicated service to the field of cardiac perfusion. A graduate of Nagpur University with advanced training in perfusion technology from Sri Chitra Thirunal Institute of Medical Sciences and Technology, she has witnessed and contributed to the evolution of perfusion practice from the era of bubble oxygenators to modern membrane oxygenation systems. Since 2003, she has been serving at Dinanath Mangeshkar Hospital and Research Center as its chief cardiac perfusionist and consultant. Highly regarded for her expertise in newborn and infant cardiac surgeries, complex aortic arch procedures, including frozen elephant trunk and redo Bentall surgeries, and advanced ECMO management and retrieval. Her international exposure includes as observer at St. Thomas Hospital, along with ECMO training at Alfred Hospital, Melbourne. Her earlier services at Harkishan Das Hospital, Mumbai and CIIMS Nagpur, Mrs. Pimputkar's journey reflects clinical excellence, academic dedication and visionary leadership. To sum up, 34 years of perfusion experience marked by precision, commitment and innovation have significantly strengthened cardiac care in India. ISECT proudly honors a lifelong dedication and invaluable contribution to the profession. Along with the President ISEC and the General Secretary ISEC, I'd like to request Ms. Adsul Ratna to please step up on stage and honor Mrs. Rajshri Pimputkar. Congratulations, madam. Moving on, ladies and gentlemen. Thank you, Ms. Ratna. The Indian Society of Extracorporeal Technology proudly confers the Lifetime Achievement Award to Mr. Gideon in recognition of his extraordinary contribution to the science and practice of perfusion and cardiac care. With over 35 years of dedicated service, Mr. Gideon has exemplified excellence, courage, and unwavering commitment to patient care. From completing his postgraduate diploma in perfusion to contributing to the early foundations of open heart surgery at premier institutions including Nizam Institute, Medicity Hospital, and Care Hospital, his professional journey reflects pioneering spirit and steadfast dedication. In 1993, he played a pivotal role in the historic first open heart surgery in Odisha, marking a significant milestone in regional cardiac care. His ability to perform under pressure, contributing to multiple complex surgeries in a single day, demonstrates his exceptional skill and resilience. His expertise extended internationally through his service in the Kingdom of Saudi Arabia and his leadership in establishing new cardiac centers, expanding across to advanced cardiac services. As a freelance perfusionist supporting multiple institutions in Hyderabad and through his continued service at Care Hospital since 2017, he has been a pillar of reliability, mentorship, and quiet leadership. His commitment to academic excellence is reflected in his active participation and presentations at prestigious platforms including CREF, ISETCon, and international conferences in Saudi Arabia, California, and he's been conferred an honorary doctorate in 2024. So Dr. Gideon's legacy transforms years of service and lives in the countless patients healed, institutions strengthened, and professionals inspired. May I please request Ravinath Swami to please step up on stage and help present this recognition. ISECT takes immense pride in conferring the Lifetime Achievement Award upon Mr. Ramesh KK in recognition for his exemplary service and outstanding contribution to the field of adult and pediatric perfusion. With over 3 decades of dedicated clinical excellence, Mr. Ramesh KK has been a pillar of strength in advancing perfusion practice in India. Trained under eminent mentors and enriched by early clinical exposure at AIIMS, New Delhi, he further strengthened his legacy at Escorts Heart Institute and Research Center. Working alongside stalwarts of cardiac surgery, he has contributed to more than 14,000 cardiac surgical cases and currently leads pediatric perfusion services, managing over 500 pediatric cases annually with exceptional expertise. Renowned for his mastery in ECMO management, perfusion circuit innovations, and academic contributions, including presentations on modified BCD circuits and ultrafiltration techniques, he has mentored numerous perfusionists who now serve across the nation. His calm demeanor, technical precision, and unwavering commitment to patient care exemplify the highest ideals of our profession. Ladies and gentlemen, may I please request Shankar Gupta to please step up on stage and present this recognition. May I please request G. Satyanarayan Reddy to please step up on stage. Not there. Ladies and gentlemen, we request Dr. Jagannath to please step up on stage to us. as we move on to the next recognition. The Indian Society of Extracorporeal Technology proudly confers the Lifetime Achievement Award upon Mr. Surendra Mohan Perambur in recognition for his exemplary dedication and distinguished service to the field of cardiac perfusion spanning over 3 decades. After completing his BSc in Chemistry from Madras University, he pursued a diploma in perfusion technology at Christian Medical College, Vellore. Began his career in the Department of Cardiothoracic Surgery at CMC Vellore, later serving as Staff Grade 1 perfusionist. He contributed to establishing perfusion services at the Assembly of God Hospital and Research Center and the Dharam Singh Desai Memorial Institute of Cardiology and Cardiovascular Surgery Research Center, reflecting his leadership and technical expertise. Since 1999, he has been serving in the Cardiac Surgery Department at Southern Railway Headquarters Hospital with dedication and distinction, earning certificates of merit and appreciation. He has actively contributed to academic growth by presenting scientific papers at ISEC conferences, mentoring perfusion students, serving as a locum perfusionist in reputed centers including Kuwait, and supporting the administration of the ISEC Chennai office. Ladies and gentlemen, to do us the honors, may I please request KK Sharma to step up on stage. Ladies and gentlemen, moving on. The Indian Society of Extracorporeal Technology takes immense pride and honor in conferring the Lifetime Achievement Award on Kevin Menezes in recognition for his outstanding, exemplary and meritorious contributions to the field of perfusion technology and to the perfusion fraternity in India and abroad. Mr. Menezes began his distinguished journey in perfusion in 1986 at the Bombay Hospital and Medical Research Center, Mumbai. Over nearly 4 decades, he has demonstrated exceptional clinical excellence, technical mastery, and visionary leadership in advancing cardiopulmonary bypass and extracorporeal life support practices. He has been among the early pioneers in implementing advanced perfusion techniques in India, including retrograde cardioplegia, retrograde cerebral perfusion, VAVD, modified ultrafiltration, complex aortic bypass procedures, and ECMO practices during their evolving years. His commitment to academic growth is reflected in his numerous scientific presentations at national and international conferences. A respected teacher, mentor, organizer, and leader, including his key role in organizing ISEC scientific meetings, Mr. Menezes continues to inspire generations of perfusionists through his knowledge, humility, and dedication. His global exposure includes clinical work in Australia and leadership roles in reputed multinational medical technology organizations. In honor of his lifelong service, unwavering commitment, and transformative impact on the profession, the Indian Society of Extracorporeal Technology proudly presents this Lifetime Achievement Award. Ladies and gentlemen, may I please request Jaswinder Singh to please step up on stage, and President Rajendra Kokane. As we move on, ladies and gentlemen, the next recognition by the Indian Society of Extracorporeal Technology goes to Krishnaba BK in recognition for his outstanding and selfless contribution to the field of perfusion technology and healthcare services spanning over 4 decades. Mr. Krishnappa began his distinguished career in the Army Medical Corps on the 13th of November 1980 at Lucknow, serving the nation with dedication and courage. During his exemplary military service, including participation in critical national duties such as the Kargil War, he demonstrated exceptional commitment in emergency care, high-altitude casualty management and life-saving interventions. His meritorious service earned him the Long and Good Service Medal in AMC. His journey in perfusion formally commended at the Military Hospital Cardiothoracic Center, Pune, where he laid a strong foundation in cardiac perfusion. Over the years, he has contributed significantly to open heart surgeries, ECMO management, transplant support, and critical care interventions, upholding the highest standards of patient safety and clinical excellence. A dedicated mentor and teacher, Mr. Krishnappa has trained and guided more than 50 perfusionist students, shaping the next generation of professionals. His selfless service during COVID-19 pandemic, managing open heart surgeries and ECMO cases under challenging circumstances, reflects his unwavering commitment to the profession. In recognition for his lifelong dedication, professional excellence, mentorship and service to humanity, ISEC proudly honors you today. Ladies and gentlemen, may I please request BC Pant to step up on stage and help with presenting this recognition. For every one of these great, I'd like to request the President, Rajendra Kokane, the General Secretary, also to please continuously be available to assist our presenters. Ladies and gentlemen, the next Lifetime Achievement Award is presented to Dr. Vishwas Kiran Paul in recognition of his exceptional and lifelong contribution to the field of cardiac perfusion and extracorporeal technology. With over 3 decades of distinguished clinical excellence, I do believe we have an audio-visual there. Dr. Paul has successfully conducted thousands of adult and pediatric cardiopulmonary bypass procedures, demonstrating unparalleled skill, dedication, and commitment to patient safety. A life member and former Joint Secretary of the Indian Society of Extracorporeal Technology, he has played a pivotal role in strengthening the professional nationally while representing India with pride on international platforms. His pioneering innovations in perfusion safety, international research, presentations, patented contributions, and academic achievements, including a doctorate in cardiopulmonary safety management, reflect a career defined by excellence, integrity, and service to humanity. ISECT proudly honors Dr. Vishwas Kiran Paul for his visionary leadership, global impact, and enduring legacy in advancing the science and art of perfusion. May I please request Subhash R. to please step up on stage and help present this recognition with our President and our General Secretary. Thank you. As we move on, the Indian Society of Extracorporeal Technology presents a Lifetime Achievement Award to PVS Prakash. We also have an audio visual for Mr. PVS Prakash. The Indian Society for Extracorporeal Technology proudly confers the Lifetime Achievement Award upon PVS Prakash in recognition of his exceptional and lifelong contribution to the field of clinical perfusion. With over 3 decades of dedicated service and more than 10,000 successful cardiopulmonary bypass procedures, he has exemplified clinical excellence, innovation, and leadership and mentorship. As a consultant perfusionist and head of department at Narayana Hrudayalaya, Bengaluru, he has significantly advanced perfusion practices, ECMO programs, education and quality standards in India. A respected leader, researcher and national leader, his commitment to patient safety and professional development has inspired generations of perfusionists and strengthened the foundation of extracorporeal technology in our country. Ladies and gentlemen, honoring his remarkable journey, visionary leadership and enduring legacy, ISECT is today conferring the Lifetime Achievement Award. Please may I welcome Loknath Tiwari to please step up on stage and help present this award. Ladies and gentlemen, moving on. The Indian Society of Extracorporeal Technology, ISECT, confers a Lifetime Achievement Citation and Award to Lokendra Kumar in recognition of outstanding dedication, leadership and contribution to the field of cardiac perfusion. Awarded a certificate course in perfusion technology by IACTS in 1993, he began a distinguished journey at All India Institute of Medical Sciences, AIIMS, New Delhi, in the department of CTVS, where he served with excellence for 31 years and led the department as head of perfusion from 2005 until voluntary retirement. He was significantly contributed to academics and research through numerous scientific publications in national and international journals, mentorship of MSc Perfusion Technology students, and pioneering research to the development of an artificial heart model using skeletal muscle support. He currently is serving as the Chief Perfusionist and Senior Manager at Fortis Escorts Heart Institute and continues to inspire the perfusion community with his leadership and expertise. ISECT honors him for his lifelong commitment to clinical excellence, research innovation and academic mentorship. May I please request Dr. Vijay Bayhare to please step up on stage and present. As you can see, ladies and gentlemen, those 20 seats are filling up very fast, just a few more to go. And the next Lifetime Achievement Award is conferred by ISECT upon Suresh Chand Yadav in recognition for his outstanding and dedicated service in the field of cardiac perfusion for over 28 years. A graduate of Rajasthan University and a postgraduate in perfusion from Buchan Education Center, Mr. Yadav began his professional journey in training at Escorts Hospital, New Delhi and SMS Hospital, Jaipur. Since 98, he has been serving in the Department of CTVS at All India Institute of Medical Sciences, contributing to a vast spectrum of adult and congenital cardiac surgeries under legendary cardiac surgeons including Dr. P. Venugopal, Dr. A. Sampath Kumar, Dr. Balram Iran, and presently working with Dr. V. Devaguru and Dr. A. K. Bishoy. Beyond clinical excellence, Mr. Yadav has made remarkable contributions to ISEC, serving as organizing secretary of ISEC 2010 Delhi, executive member for 3 terms, joint secretary from 2010 to 2013, and website moderator from 2013 to 2016. A committed academician, he has presented scientific papers nationally and internationally, trained numerous MSc perfusion students at AIIMS, and holds the distinction of being the first government sector examiner for MSc perfusion students in India. ISEC honors his unwavering dedication, leadership, academic mentorship, and invaluable contribution to strengthening perfusion science in India. Ladies and gentlemen, I would like to request Shri Nivasalu Reddy to please step up on stage and help present this one. I hope I got the name right. Thank you. Thank you. I should get that correct. Srinivasalu Reddy. Thank you, sir. In a hurry, I don't know what I wrote. I write like a doctor, although I'm not. That means even I can't understand my handwriting. The next Lifetime Achievement Award goes to Mr. Rajiv Gupta. And I presume we do have an audio visual for Mr. Rajiv Gupta. In recognition for his outstanding and lifelong contribution to the field of perfusion science, academic excellence, and professional leadership in India. A dedicated member of ISEC for more than 23 years, Mr. Gupta has served the society with distinction as an executive committee member for 3 terms, the treasurer and editor of IJEC, the Indian Journal of Extracorporeal Technology. His visionary leadership and scholarly efforts have significantly strengthened the academic and organizational foundation of ISEC. With over 27 years of continuous service at the esteemed All India Institute of Medical Sciences, he currently holds the prestigious position of STO Perfusion, Chief Perfusionist. His clinical expertise, administrative leadership, and unwavering commitment to patient care reflect the highest standards of professional excellence. An exceptional educator and mentor, Mr. Rajiv Gupta has trained and guided more than 100 postgraduate students, PG diploma and MS perfusion, and served as guide or co-guide for numerous MSc theses. He has also contributed as an examiner for perfusion students at Nizam's Institute of Medical Sciences and AIIMS New Delhi, shaping the next generation of perfusionists. A prolific academic contributor, has delivered more than 100 scientific presentations at national and international perfusion conferences, including over 20 presentations at ISEC, both as delegate and faculty. He has served as a judge for scientific sessions and chairperson and moderator at state, national, and international ISEC conferences. His scholarly contributions include authoring and publishing The Oath for Clinical Perfusionists, writing original articles and editorials in IJECT, and co-authoring 5 scientific articles in IJECT and JECT. He is currently nominated by the Ministry of Health and Family Welfare, Government of India, as a member representing perfusionist professionals in the National Commission for Allied and Healthcare Professionals. He stands as a respected voice in shaping national policy for allied healthcare education and regulation. Ladies and gentlemen, Lifetime Achievement Award. May I please welcome Satyanarayana Reddy to please step up on stage and help present this one. We're almost to the end of the recognitions. The next recognition by the Indian Society for Extracorporeal Technologies is a Lifetime Achievement Award to Arun Krishna Patil, perfusionist, CPR Hospital and Government Medical College, Kolhapur, in recognition for his over 3 decades of dedicated service in the field of perfusion technology. Beginning his journey in 1993, Mr. Patil has consistently demonstrated clinical excellence, integrity, and commitment to patient care. As a senior perfusionist serving the government of Maharashtra, he has significantly contributed to strengthening cardiac services at CPR Hospital. His devoted service during the COVID-19 pandemic and his mentorship to younger professionals reflect his true spirit of healthcare leadership. ISECT honors his lifelong contribution and unwavering commitment to the profession with deep respect and gratitude. That's from the President Rajendra Kokane in ISECTCon 2026 Mumbai. I'll request Dinesh Maiti to please step up on stage and help with presenting this recognition. As we move on, the Indian Society of Extracorporeal Technology presents a Lifetime Award and citation to Mr. Surendra Pal Singh, Chief Cardiac Perfusionist. Honoring the legacy of Mr. Surendra Pal Singh for over 30 years in the field of extracorporeal technology in India, which has been strengthened by the steady hands and the visionary leadership of Mr. Surendra Pal Singh. Today, the Indian Society for Extracorporeal Technology is privileged to present him with the highest honor, the Lifetime Achievement Award, from his early academic roots at Meerut University to his specialized training at AIIMS Delhi. Mr. Singh has pursued clinical excellence with a singular focus. Since joining Medanta Gurgaon in 2008, he has served to the cornerstone of the perfusion department. His career is marked by participation in the most complex frontiers of cardiac medicine, from neonatal LVAD implantations to life-saving heart and lung transplants. Beyond his technical mastery, Mr. Singh is a celebrated mentor for building future professionals. His influence extends to the many professionals he has guided in the high standards of care he has established at institutions like AIIMS and Batra Hospital. Ladies and gentlemen, here we are to recognize the contribution of Mr. Surendra Pal Singh to your fraternity. Please welcome Dr. Alok Kumar to help with the presentation. Thank you, Dr. Kumar. Legend, we see that there's just one more vacant seat, and that one for the Lifetime Achievement Award from the Indian Society of Extracorporeal Technology goes to Yogesh C. Ludwig, clinical cardiac perfusionist. This is conferred upon Mr. Yogesh C. Ludbe, in recognition of his exceptional dedication and more than 3 decades of distinguished service in clinical cardiac perfusion. A graduate of Mumbai University and formerly trained at KM Hospital and GS Medical College, Mr. Ludbe has been a pillar of excellence in cardiopulmonary bypass, transplantation and advanced mechanical circulatory support. Serving as manager and head of department perfusion at Fortis Hospital Mulund since 2002, he has demonstrated outstanding leadership and clinical expertise. His early contributions at Kanbala Hill Hospital and Heart Institute and KEM Hospital further strengthened perfusion services in Mumbai. A core team member in the first heart transplant in Western India, Mr. Ludbe has served as perfusionist in over 120 heart transplants, multiple lung transplants, neonatal LVAD implantations, and numerous cardiac complex procedures, including mitral valve repair, MACE procedures, and awake cardiac surgeries. A recipient of multiple long service awards and the Outstanding Performance Award, his commitment, precision, and mentorship have profoundly influenced the perfusion community. ISECT honors his lifelong dedication, clinical excellence, and invaluable contribution to advancing cardiac care in India. May I please request Raju Madhvi to please step forward. I request the President and General Secretary So, ladies and gentlemen, this concludes our list of top 20. You know, if this were cricket, this top 20 would beat any team, international team across the world, hands down, because these are real stalwarts who spent 40 plus years, some of them, and definitely most of them over 30 years in the industry, gaining ground, leading the way, and mentoring. Please give them all a big round of applause for the hard work, for their dedication, and for the commitment to the profession. It's a great moment today. And the only thing we can do is thank them for the work and the service that they've done on behalf of not only the profession, but also the population as general. And also, you know, I wish and today at this point of time you had like a ramp and they could take a walk of pride, you know, down the ramp. We could do one thing though, we could have a photograph if all you gentlemen, if you could please step forward. There's some hot off the presses photographs coming up. So, the team backstage is working very hard. So, ladies and gentlemen, I'd like to request, you know, since you are here, if any one of these gentlemen want to share a moment or two about...
Excuse me, before we go ahead, I'd like to request everyone, each and everyone in the audience here to please stand up and give these legends an ovation to celebrate their life and times.
Yeah.
Thank you very much.
Yeah, thank you. I was going to get to that when I got them standing up, but that's important. Thank you very much. Yeah. while we're waiting for some of the photographs to turn up, because that will help in getting us a group photograph, we're making it very, we're ensuring that. Does everyone have a photograph? Still more to come? So I'd like to ask any of these gentlemen and the lady here today, in case they have any words to share, I'd be glad to give them the mic. Come straight over, sir. Yeah, thank you, Prakash. I'll put this mic on for you.
Thank you so much. It is a very, very emotional moment for that to get a Lifetime Achievement Award from the place where I started my life here. From here, we were sent to Baroda. I was the first batch of the Medtronic student along with Gideon. And the first case I saw was with Kevin at Hinduja Hospital. And I would like to thank my wife, Janaki. I think I have spent more number of hours in the hospital rather than the family. And my elder son is also there, Adesh, whom I missed seeing him many times growing up actually. And within no time they have become big persons, and many of this thing wife was taking care. Very, very thankful to my family, and thanks to all my students who are a big support for me. I might not have earned a lot of things in life, but definitely the love, the affection from all my students who are working all over the world. And I would also like to thank Dr. Devi Shetty, whom I had been working with him from 1993 onwards. In between 5 years, I didn't work. And I would also like to express my thanks to Mr. Gopalachari. I think he is little delayed in getting the Lifetime Achievement. He was my first teacher to show the heart lung mission in Medtronic, and they created the course, which later on became BSc. And because of him, I was able to create a syllabus and teach BSc and MSc students. Thank you so much, sir. No words to express you. I am seeing you after so many years, 25 years or 28 years. It's a great honor. Thank you. I think I have to give chance for others to speak also. Thank you. Love you, everyone. Thanks a lot. It's really emotional moment for me.
Thank you, sir. It is indeed emotional to encompass about decades of, work, dedicated to work, taking off from family, but being focused. And I know it's very emotional. I'll get the mic around in case any of you want to say a few words.
थैंक यू फॉर दिस अवार्ड। मैं सबसे ज़्यादा धन्यवाद देना चाहता हूं मैं डॉक्टर करण सिंह यादव जी को, जिनकी बदौलत मैं आज इस मुकाम पर पहुंचा हूं। उसके बाद मैं धन्यवाद देना चाहता हूं डॉक्टर वेणुगोपाल जी को, जिनकी बदौलत मैं आज एम्स में रुका हुआ हूं। और उसके बाद मैं डॉक्टर संपत कुमार, डॉक्टर बलराम, डॉक्टर बिगसोई और अब डॉक्टर देवगुरु के साथ मैं कार्यरत हूं। और सबसे ज़्यादा मेरे गुरु यहाँ पे बैठे हुए हैं, मिस्टर के जी, जिन्होंने मुझे सिखाया है वहाँ पे एस्कॉट में। उसके बाद मैडम के साथ मैं काम किया हूँ, डॉक्टर कमला साहब मैडम के साथ। उसके बाद इन लोगों ने मुझे एम्स में भेज दिया मिस्टर लोकेंद्र जी के साथ, एंड मेरे जोशी जी नहीं है, जोशी जी के साथ मैं थोड़ा काम कम किया है, 3 साल ही। बाकी लोकेंद्र जी के साथ मैंने 20 साल काम किया है। इन्होंने मुझे बहुत कुछ सिखाया है मेरी ज़िंदगी में। मैं धन्यवाद देना चाहता हूँ लोकेंद्र जी एंड सुरेंद्र जी को भी। जब एम्स में मैं आया तो मुझे सुरेंद्र जी के साथ पोस्ट कर दिया गया, तो सुरेंद्र जी काम करते थे और मैं भाग के चला जाता, क्योंकि मेरी वाइफ की ट्रेनिंग हो रही थी। तो मेरी वाइफ ने ट्रेनिंग की टीचर की, तो मैं सुरेंद्र जी को गोली दे के चला जाता था कि मैं अभी आता हूँ, और मैं वाइफ को लेने चला जाता था। अभी सुरेंद्र जी ने आके मुझे कहा है कि तू मुझे बहुत गोली दे के गया है। पर मैं सुरेंद्र जी आपके लिए दिल से धन्यवाद, वेरी वेरी धन्यवाद सुरेंद्र जी। और मैं सबसे ज़्यादा योगदान मेरे साथी डॉक्टर आलोक कुमार व्यास, राजेश यादव, जो मेरा भाई है पर मेरे से थोड़ा सा दुश्मनी रखता है, पर थैंक यू, पर इसने मेरा साथ भी बहुत दिया है। धन्यवाद राजेश, थैंक यू मच।
दिल से बोले लेकिन दुरुस्त बोले. Thank you very much, sir. Can we have a photograph, everybody, little forward? Yeah. Group photograph. Ladies and gentlemen, this is the time. Now they're already here together. Can you please give them a big rousing round of applause? You gave them a standing ovation earlier. Keep the round of applause going. 20 stalwarts on stage at one time. This is your life, your profession, your past, your history, and of course your future. Because they have written it and you are living it. At the end of it all, I'd like to request this gentleman to very slowly give us a nice walk past. We'll start at this end, walk across the stage and exit from those steps, one by one, very slowly. Okay? So we get a good video, good photograph. Before you go, let me do something. Let me just remove that. Let me show you. Come this way slowly, okay? Take your time. You spent 40 years in the profession, no need to rush. Come across. Go slowly, and every one of you is going to give you a round of applause, continuous, as it goes. Oh, okay. Start from that corner. Wait. Let me go out of the frame. Now you start. Give the applause. Come on, guys. Slowly. Wait, slowly. Now go. Aram se. Gentlemen. धीरे आराम से Too much crowd. Wait. Slowly, guys, enjoy this moment, savor it. It took 40 years to get here. Don't finish it off in 4 seconds. Ladies and gentlemen, we shall now unveil the ISEC journal. Ladies and gentlemen, while you're in the hall, we are now going to unveil the ISEC journal. May I please request the President, Mr. Raju Kokane, the General Secretary, Mr. Tiwari, and the editor, Vijay Lange, to please step up on stage and unveil the journal. Ladies and gentlemen, the Indian Journal of Extracorporeal Technology will be unveiled today. I'd like to request the people behind it all. First of all, of course, the president of ISECT, the general secretary of ISECT, who's already here with us, the associate editors, Mr. Suresh Chand Yadav, Mr. Debashish Roy, the chief editor, Dr. Vijay Lanje, assistant editors, Mr. Thanigyanathan, Dr. Akhilesh Suresh Chand Maurya, the editorial board members, Ms. Ritu Airam Goel, Ms. Pallavi Shetty, my apologies, Ms. Pavana Shetty, Mr. Sanjeen Sani, Ms. Divya Tejani, Ms. Kinnari Chudasama, Mr. Abhijit Paul, Mr. Syed Asim Ali, Ms. Drishya Paul, Ms. Thilagavati Raju, Ms. Maria Magdalene, Ms. P. Suguna, Ms. Jainam Sharma, the Editorial Review Advisory Board, Ms. Lakshmi Nagarajan, Mr. B. Ilaiyaraaja, Mr. Gopal Pasam, Ms. Meeta Mathur, Mr. Senthil Kumaram Danakoti, Mr. Ramesh Garipalli, Ms. Viju Vincent, Ms. Suni Jose, and Ms. Vijayanti, my apologies, Ms. Jayanti V. Very quickly, I'd like you to pause the photograph ceremony. You guys are like tourists when you come to a new place. You want to take your photographs. I like that, and that's necessary. But right now, I'd like to request the President of ISECT, Mr. Raju Kokane, General Secretary, Mr. Loknath Tiwari, to please step up on stage to unveil the journal. For unveiling of the journal, Mr. Loknath Tiwari and Mr. Raju Kokane, please step up on stage. Also, I'd like to, the Chief Editor, Dr. Vijay Lanje, the Associate Editors, Mr. Suresh Chand Yadav, Mr. Debashish Roy, the Assistant Editors, Mr. Thyaganathan, and Dr. Akhilesh, I'm sorry, that's Dr. Akhilesh Suresh Chand Maurya, to please step up on stage. Also, the editorial board members, who include Ms. Ritu Airam Goel, Pavana Shetty, Sajin Sunny, Divya Tejani, Kinnari Chudasama, Abhijit Paul, Syed Asim Ali, Drishya Paul, Thilagavati Raju, Maria Magdalene, P. Suguna, Jainam Sharma, and the Editorial Review Advisory Board, Lakshmi Nagarajan, B. Ilaiyaraaja, Gopal Pasam Naidu, Meeta Mathur, Senthil Kumaran Danakoti, Ramesh Garipalli, Vijay Vincent, Sunil Jose, Jayanti V. Ladies and gentlemen, can we do the photography later? We'll just do this. Guys, photography just 2 seconds later. Once again, very quickly, Chief Editor Dr. Vijay Lanje, Associate Editor Suresh Chand Yadav, Debashish Roy, Assistant Editors Thanigyanathan, and Dr. Akhilesh Maurya. Ladies and gentlemen, we now unveil the ISECT Journal 2026. I'd like you all to please look forward to the stage. We'll give you the stage in a short while to take photographs, but right now we'll just do this, if you don't mind. Can I ask the editorial board members? Are you all editorial board members? No, okay. All editorial board members, associate editors, assistant editors, chief editor, general secretary, Mr. Loknath Tiwari, Mr. Tiwari, photograph, yeah. Once again, very quickly, Ritu Ayrangowal, Pavana Shetty, Sajjan Sanni, Divya Tejani, Kinari Chudasma, Avijit Paul, Saida Simali, Drishya Paul, Tilagavati Raju, Maria Magdalene, P. Suguna, Jayanam Sarma, Lakshmi Nagarajan, B. L. Raja, Gopal Pasam, Meeta Mathur, Senthil Kumaram Danakoti, Rajesh Garipalli, Vijay Vincent, Suni Jos, and Jayanti V. This is the fantastic magazine. They put it together. Please give them a big round of applause. Thank you. Those are big hands. Thank you for that. Guys and gals, all right. Photo. Where's the photographer? Photo take-outer वाला कहाँ है? Photographer नहीं है तो radiographer को बुलाओ. Anybody from the radiography department? बराबर फोटो आ जाएगा. फोटो टेकआउटर कहाँ है? बुला लो. आ जाओ जल्दी भाई. सबसे ज्यादा मैगजीन वाले हैं. आपका फोटो उसमें पब्लिश हो जाएगा. बोलेंगे ये तो ये कहाँ था? सर फोटोग्राफर वाला आ गया. आपका भी नाम होगा. हाँ. वाह. क्या भारी मैगजीन है और मंच पे भी लोग भारी लोग बैठे खड़े हैं तो सबके लिए एक भारी तालियां से थैंक यू कीजिएगा. एवरीबॉडी बिग राउंड ऑफ अप्लॉज वन मोर टाइम. लई भारी लोगा
एक
बगा फेटा पर.
डॉक्टर लांजे को मैं धन्यवाद देना चाहता हूं कि 3 महीने के अंदर उन्होंने हमारी जर्नल को पब्लिश कर दिया है. धन्यवाद डॉक्टर लांजे. धन्यवाद धन्यवाद धन्यवाद. 3 महीने में हमारी जर्नल पब्लिश हो गई है. 3 महीने में ओनली. डॉक्टर इसमें डॉक्टर लांजे का बहुत बड़ा हाथ और बहुत तगड़ी मेहनत. धन्यवाद डॉक्टर लांजे.
थैंक यू दोस्तों. लेडीज जेंटलमैन आप जाइए नहीं कहीं. आप देख रहे हैं कि ये तैयारी हो रही है ऑर्केस्ट्रा का. मैं सुना कि रशिया से डांसर्स भी आने वाले हैं. ऐसा सुना, पता नहीं.
Just taking a small moment to thanks to all my associate editors, assistant editors, my review board editors, supporter, our sponsorer, office bearer, and great thanks to sponsorer and last organizing secretary Ravindra Pal sir. By open-handedly he helped us for this journal. Thank you to Kamala ma'am, to advisor for this IJEC journal. Thank you to Raju K sir from Chennai, and no doubt my review board has been worked hard and a lot for to get this journal get done and come out very beautifully. I'm asking everyone and give you a review, ideas, suggestion, and constructive criticism so we can improve it again more beautifully. And again, I'm welcoming your all the articles, manuscript as soon as possible for our next issue of the 2027 Kolkata conference. Thank you everyone.
That was the chief editor, Dr. Vijay Lanje. Thank you very much, ma'am, for rounding up and with the vote of thanks, because it's very important that we thank everybody who made it, and it's important for an editor to have the last word. So, so with that, I leave you to the preparations that are being made on stage. There's going to be an orchestra, there are going to be singers, there might be dancers, but there's going to be enjoyment and entertainment for all of you. So stay with us, ladies and gentlemen. Just to remind you that tomorrow morning we'll start on time. We have a busy schedule as with today, and we request you all to please be on time, no matter how late you finish up or wind up today. Tomorrow morning we start at 8:30, so if you could be in the hall at least 15 minutes prior, because we will definitely start on time. So once again, reminding you, tomorrow morning we start at 8:30. Please be in the hall at least 15 minutes before. Right? Thank you very much, ladies and gentlemen. From me, that's all for tonight, and good night.
Bangalore.